pregnancy. I'll try to limit my class to the changes. I'm not getting to puerperium today. Puerperium is also an important topic. Let's see if we can do that also some other time. But right now we are discussing about the physiological changes in pregnancy, and we'll start from the most important organ because I'm an obstetrician. So I'll start with the uterus. A non-pregnant uterus, if we see, is a size of 70 grams. So when the woman gets pregnant at term, you know, the uterus is as big as the coming till the xiphisternum. So when it is coming to the xiphisternum, it is 40 weeks. Now that uterus has a baby also inside. So the baby weight I am just taking off, that is 3.5 kg, whatever. But the weight of the uterus alone at term is 1100 grams. So 70 and then it becomes 1100 grams. So what is the reason of this rise in the weight? The reason of this rise in the weight is the hypertrophy, okay? And that is because of the estrogens. Remember, hypertrophy because of the estrogens. And yes, it is also because of progesterones. They say there is some role of progesterones also. Now, what else I want to tell you here? In addition to understanding that there is hypertrophy of the uterus, please remember that after the pregnancy is over, delivery is done, then the uterus goes back to its normal size, correct? So the uterus, which was 70 before pregnancy, during pregnancy it became 1100 grams at term. Just the weight of the uterus is 1100 grams, and after delivery it should go back to 70 grams. No, it doesn't go back to 70 grams. It goes back to 100 grams. The least it will come back to is 100 grams. So what I want to impress by this bit of information, I want to impress upon you guys that please understand that from 70 to 1100 it is hypertrophy, correct? But there is some hyperplasia also, guys. There is some hyperplasia. That's why the weight is never back to 70. It will be around 100 grams. So we always, when we do a per-vaginal examination, we obstetricians know that whether we are feeling a nulliparous uterus or a woman who's delivered. So we say it's a multiparous uterus. She's not pregnant. Let's say she's have 2 children and the last child is 10 years old. But if I do a PV of a lady in the OPD, I know she's a multiparous woman because the uterus will be a little bit bigger than the size when she was a nulliparous woman. So there is hypertrophy mostly, but there is some hyperplasia also. They keep asking you these bits in the MCQ exams. Yes, you'll be enough for your MBBS exam that it is a hypertrophy. That's enough. All right, let's go. I'm sure you know all these details. We are supposed to actually do a revision here. So we'll just tell you how does the uterus enlarges. So I've already drawn it here so that we save some time. So uterine enlargement, the uterus is globular and spherical by 12 weeks of gestation, and then it is palpable in the abdomen by 12 weeks. If you see this one, this picture inside, this is the normal size uterus. Now this is the symphysis pubis here, and the uterus is just above the symphysis pubis and palpable at 12 weeks. And then it is at the level of the umbilicus at 24 weeks. And then it has the level of the xiphisternum at 36 weeks. Now, after 36 weeks, it cannot go higher anymore. So it starts filling up the flanks of the mother, the sides of the mother. So the flanks start getting filled up. And that's why we say now it is 40 weeks because the uterine height goes down. The height goes down, but the flanks start filling up. So when the flanks fill up and the height goes down to 32 weeks, we say the woman is at term now. So for saying term, the flanks should be full and the height should drop down a little bit from this xiphisternum. Remember, the sides, the flanks get filled up. Right, guys. So let us see how does the uterus come back to its normal size. How does the uterus increase? We've seen now. How does the uterus come back to normal size after delivery? That has become an even more important question. So after delivery, uterus is felt just below the umbilicus. Massive MCQ. Just below umbilicus. Now, what is the importance of this? This is what is going to come in your table viva. When a woman has delivered, the uterus is just below the level of the umbilicus. Why is it important? I'll just try to show you something. I'm putting a phone into my shirt and showing you. See, she's just delivered and I can put my hand on the abdomen of the mother and feel the uterus. She's delivered in the morning. Evening, I go for the rounds. I can feel the uterus. Why am I so happy about feeling the uterus like this? Because now, if she has delivered 2 children, tomorrow morning I can go and I can make a small incision here and get the tubes very easily. Yes, the uterus is an abdominal organ after delivery. So when the uterus is an abdominal organ after delivery, I can do something called a very easy tubectomy. So these are the fallopian tubes. We can make a small incision, and with this small incision go and ligate these tubes very easily. Otherwise, you look yourself, the xiphisternum is here. Suppose the woman is, let's say, she's 30 years of age and she's got 2 children. The last child was born 5 years back. She comes to me, sir, I don't want to have any more children. Please do a tubectomy for me. So if you have to do a tubectomy for a woman in regular days, not in the postpartum days, in the regular days, last child was 5 years born, then the uterus is inside the pelvis. So you will have to make an incision above the pubic symphysis and go so much deep inside to ligate the tubes. It will be difficult. It will be a much bigger incision. But when the uterus is in the abdomen, it's a very easy small incision and you can get the tubes and do a postpartum sterilization. So just below the umbilicus, it's a good time. It's a good time to do a puerperal or postpartum sterilization. A tubectomy surgery is very easily. Now related to this, they'll ask you other questions. Why is this information good that the uterus is just below the umbilicus? You can do an easy tubectomy. How long can you do this tubectomy after delivery, the easy tubectomy? How long can you do it? You can do it as long as the uterus is in the abdomen. So the next question is, how long is the uterus in the abdomen after delivery? In other words, when does the uterus become a pelvic organ? Guys, if you've not understood, please stop, rewind and hear to this again, okay? When does the uterus become a pelvic organ? A major MCQ. Don't say 6 weeks. Uterus becomes a pelvic organ in 2 weeks. So yes, when it becomes a pelvic organ, you can no more do a puerperal sterilization. So puerperal sterilization can be done very easily because the uterus is an abdominal organ after delivery. She delivers today, tomorrow morning you can post her to the OT and do a sterilization. How long can you do it? You can do it for 5, 6, 7, 10, 12 days, but not beyond that, because now the uterus becomes a pelvic organ again. Pelvic organ in 2 weeks. When does it become a normal organ again? It becomes a normal organ again in 4 to 6 weeks. It becomes a normal organ again in 4 to 6 weeks. So these are the questions which keep coming in your exams and in your table vivas, guys. Very practical information, right? Good. Harsh is giving the answers. Some Hindi also, but my Tamil friends and my Telugu friends are going to get angry with me, guys. So ठीक है, I can talk in Hindi थोड़ा बीच में, but फिर मुझे तमिल में भी बोलना पड़ेगा, guys. So I'll try to stick in Hindi for the time being and more English. Chalo, let's move on and see after delivery. This is what happens. Then after delivery, what is the weight of the uterus? मैंने आपको बताया कि the uterine weight is around 1100 grams at term. 1100 grams at term, just the weight of the uterus. Baby weight is 3.5 kgs. So at term it is 1100 grams. What is the weight of the uterus on the day of delivery? That means 1100 grams. So how does the weight reduce? Again MCQs. At 1 week the uterus is approximately 500 grams. And 1 week later again it is about 300 grams. And then again after 2 weeks it is something like 100 grams. So on the day of delivery 1100 grams, 1 week later half of that, 500 grams. Another 1 week later half of that, 300 grams. Then 2 weeks later it is half of that, it is 100 grams. Yes sir, this is some abnormal mathematics which I am trying to teach you. 1100 ka aadha 500, 500 ka aadha 300, 300 ka aadha 100. So pardon my mathematics here, but this is how I generally remember it very easily. So 1 week after delivery it is 500, 2 weeks after delivery it is 300, and 4 weeks after delivery it is 100. Please remember, this is the most favorite MCQ in the exams. What is the weight of the uterus after 2 weeks of delivery? That is 300 grams. And please remember, it is 1 week, 2 week and 4th week. Not first week after delivery, second week, third week and 4th week. No, I didn't say that. First week, second week and the 4th week. So how I remember? 1 2 ka 4, 4 2 ka 1. My name is Prassan. All right. Chalo, आगे बढ़ते हैं. So we are talking about uteroplacental flow next. Uteroplacental flow 36 weeks. अब uteroplacental flow is 36 weeks means around 550 to 750 ml. Now uteroplacental, please don't get confused. There are two uterine arteries. Each uterine artery is giving 500 ml of blood. See, this uterine artery is giving 500 ml of blood. This uterine artery is giving 500 ml of blood. So, if they ask you uterine artery per se, one uterine artery, how much of blood it is giving to the uterus? 500 ml per minute. But both these uterine arteries go and give blood supply to the uterus and to the placenta. So, uteroplacental flow is up to 750 ml per minute. So, we roughly say 750 ml to 800 ml blood is there in the uterus at any given time. So, iska importance kya hai? What will happen because of this so much of blood in the uterus? It is good for the perfusion of the placenta, correct? But we also have to remember that when the placenta separates, then the base of the placenta can bleed, and when the base of the placenta can bleed after delivery, PPH, she can lose 800 ml blood in every 1 hour. Yes, she can, 1 minute, I'm sorry, she can lose 800 ml in every 1 minute. That's the kind of flow happening. That's why after delivery we keep saying contract karo uterus ko, contract, do a gentle uterine massage. That's why massage is important, guys. Massage karna hai. If you're saying no massage, then I don't know what else are you going to do. Please, uterus has so much of blood inside. So when the placenta separates, the base of the placenta bleeds, and it can bleed 800 ml per minute. That's why we do active management of third stage of labor. Give oxytocin at the delivery of the anti-shoulder, so that by the time the delivery is completed, the placenta is removed, the uterus will contract and squeeze, and the uterus will not lose so much of blood. And after delivery, you do a gentle massage. After the placenta comes out, do a gentle massage so that the contraction is promoted. Your oxytocin will act and your massage will promote contraction. So please do uterine massage. All you MBBS students and all you interns will also know it, I'm very sure. Interns also worked in the labor room. Without uterine massage, your PG won't let you have your lunch. He'll say, aaj teri punishment and no lunch for you if you're not doing uterine massage. Yes, you have to do uterine massage, guys. Gentle uterine massage, obviously. So that's about the uteroplacental flow. That's why we keep telling you this physiology, because it is important in the delivery. Dekho, there are so many details about physiology. You can go on remembering them in details. You can go on remembering rat ke chale jao sab kuch. Application is going to come in the exams. What is the importance of so much of blood in the uterus? That this much can be lost in PPH. Other importance is after delivery, the uterus contracts. Yes. So when the uterus contracts, PPH has not happened. The uterus contracts. So all this 800 ml blood from the contracted uterus will go back into the circulation. And the mother will have extra 800 ml in the circulation. Achhi baat hai. It's good that she has 800 ml which was in the uterus has come to her circulation. It's very good. But if she is a case of heart disease and a case of hypertension, you don't want the uterus to suddenly contract, because so much of blood suddenly goes into the circulation, and a hypertension patient can have an increase in hypertension and she can convulse, eclampsia can happen, and a heart disease patient will suddenly have 800 ml blood going into her and she'll go into failure. So these are extremely important details. I know some of you guys are watching this because you have got an exam coming up on 17th. Please remember, this 800 ml which is there in the uterus is good that the uterus contracts and all that blood goes back into the circulation. But if it's a case of a heart disease and hypertension, do not give methyl ergometrin, because it causes sudden contraction and a lot of blood goes into the circulation. Patient can go into failure because of heart disease and can go into sudden increased hypertension because of a gestational or chronic hypertension if she may have. All right, a lot of theory going on, guys. Chalo, let's make it a little light. Let's tell you some basic wala details which keep coming. Uterine massage, please tell once why it's needed. Sutta, remember, uterine massage, when you put your hand on the uterus and gently massage the uterus, massage will promote contractions. That's why it is needed. So, moment you take out, the baby comes out, you take out the placenta by control contraction, and now the uterus base, the placental base, this placental base is going to bleed. So I want the uterus to contract fast. So my massaging will promote contractions. That's why uterine massage is required. All right, please ask questions. Always good to ask questions. Chalo, आगे बढ़ते हैं. Cervix. Cervix. Now some details, some pakka details. हमारे हिंदी में बोलते हैं रटंत विद्या, or what we say in your Gen Z language. Some things you have to mug up, guys. Some things have to be remembered because they have to be remembered. So that is the details. The estradiol stimulates the growth of column epithelium of the cervical canal, and that is what is violet, reddish violet in color, which is known as a ectropion. And then there are these signs which keep coming in your exams. Chadwick sign or Jacquemus sign is the bluish discoloration of the cervix and of the vagina, obviously. not just of the cervix, because classically it is mentioned for the cervix, but it is also of the vagina. Look, the cervix is blue, the vagina is not going to be yellow. I don't know why you guys have a confusion, because you say, nahi sir, hamara books kehta hai ki it is only for the vagina. Please guys, the choices given in some MCQs I saw, vagina, cervix separately they had given choices, vulva also was given. Cervix, vagina will be the same color, obviously. They won't be two different colors, please. So please understand, it is classically mentioned, if you read your Williams obstetrics, it is classically mentioned for the cervix, and the vagina will also be blue. Chadwick sign, also known as a Jackimer sign. All of these signs are seen around 8 weeks. Most of the signs, only Hegar sign, which is going to come next, is seen around 6 weeks. So Chadwick sign is that. Then what is the Osiander sign? Pulsatility in the lateral vaginal fornices around the 8th week of pregnancy. Pulsatility here in the lateral fornix. You put your fingers in the vaginal fornices, you will feel some pulsatility. That is the Osiander sign, also known as the vaginal sign. Now, Hegar sign is the softening of the isthmus. See this isthmus, this area. This is, you know, the area between the anatomical internal os and the histological. I have written histological internal os. So this anatomical internal os, histological internal os, between that is the isthmus, and this isthmus. This isthmus is 0.5 centimeters in size. This becomes 7 centimeters when the patient is in labor. It becomes the lower segment. Big discussion we've done about this in the menstrual physiology chapter, the basics which I've taken in the app. You must see that, okay? So 0.5 centimeters is the isthmus. It becomes 7 centimeters in a woman who is having labor. And now this isthmus in early pregnancy becomes very soft. How can you feel that softness? You can put your hand in the vagina and in the abdomen like this, you know, one hand in the vagina, one hand on the abdomen of the mother, and through the abdomen and through the vagina you can go, and you can go through the isthmus, and you can actually touch your fingers through the isthmus. It is so soft. What can happen if you're not very careful? You may go a little high and press like that, and you may actually cause an abortion. So that's why I'm not a very big advertiser of Hegar sign. I would want you guys not to do it. Yes, I'm telling it on YouTube, and everybody is going to hear this. Whoever is a medic also is going to hear it, my friends and my seniors. But please, this Hegar sign, if you're not very careful, you can actually end up doing the rupture of a sac. Okay, so remember, can cause an abortion. So be very careful. If you can just read about this sign and finish your PG, I'll be happy. You don't have to try this. If you become a postgraduate of gynecology, don't try to go and keep doing the Hegar sign. Cervix will be soft in pregnancy. You and me know that anyway. Okay. For the sake of giving respect to the gentleman, we are remembering this sign. Okay. Hegar sign comes in your exam. Okay. Now that is the Hegar sign. Then what is the Goodell sign? Goodell sign is the softening of the cervix. So Hegar sign is the softening of the isthmus, and Goodell sign is the softening of the cervix, again 6 to 8 weeks, but Hegar is at 6th week. Now Goodell sign is softening of the cervix. What is Hartmann sign? Implantation bleeding. Now you have to mug up a few details. What is Palmer sign? Rhythmic uterine contractions, 4 to 8th week of pregnancy. When you put your hand inside the vagina and one hand on the abdomen, and just keep your hands with the uterus between your hands, don't keep pressing, just feel the uterus between your hands. You will feel some rhythmic uterine contraction 4 weeks to 8 weeks. That is what is known as a Palmer sign. It is not the Braxton Hicks contractions. Braxton Hicks contractions come later, 16 to 18 weeks. Palmer sign, 4 to 8 weeks. We are coming to Braxton Hicks. So Braxton Hicks contractions, these are the painless. These are painless contractions. These are the painless contractions which are having an intensity of 5 to 25 millimeters of mercury, and this are lasting around 30 seconds to 2 minutes and usually infrequent, but during term they become something like 10 to 20 minutes. Very nahi hai, every 10 to 20 minutes. So nearing term they can be more frequent. So these are painless contractions. The women will come to me in the labor room, in the OPD, and they'll say, sir, my uterus around 16 to 18 weeks. Did I write that? I think I forgot. 16 to 18 weeks it starts. So this woman will say, sir, my uterus becomes as hard as a stone. I'll ask her, is it painful? No, sir, it's not painful. And how does it go off? Sir, it just goes off by itself. or if I walk, I get better, or if I'm walking, I sit, it gets better. Both ways it works. So it gets better by itself. It is not very painful. So that is what is the crux of the discussion about Braxton Hicks. Painful contraction seen around 16 to 18 weeks, and it will be relieved by resting or by walking also. Both ways it works. So it is not associated with cervical dilatation. That's why it is also known as false labor. So it stops with resting. Some women will say it stops with resting. Some women will say if I walk around, it stops. Both works. And then also called the false labor, because these are contractions, but they are not associated with cervical dilatation. We also call them the practice contraction. The uterus is doing some practice to get into labor later on. So these are painless contractions. Okay. What about the breast? Breast, we see changes, very important changes. The estrogen will lead to the formation of the glandular ducts, estrogen for the ducts, ED, and progesterones for the epithelium, PE. I know I have a dirty mnemonic here, but anyway, I'll give it a chance. Erectile dysfunction, premature ejaculation. These are the only two psychiatric disorders I know, guys. So please remember them. So estrogen for the ducts and progesterone for the epithelium of the alveoli. Then prolactin leads to the formation of milk. Yes, the milk letdown is happening because of the baby being born, and then the baby suckles on the breast, and that suckling releases oxytocin, which causes the letdown. Yes, that is the letdown reflex. Formation of milk, prolactin. Now, please understand, the milk formation starts in pregnancy itself. The letdown happens after delivery when the baby suckles on the breast. So yes, the milk formation starts, the colostrum formation starts as early as first 4-5 months. Thick yellowish fluid called colostrum, which is rich in IgA. Your pediatrician will teach you great detail about this. So when you see that the breast will have some amount of colostrum coming out as early as 5th month itself. I'm not saying she's going to keep discharging milk. No, that will happen only after delivery. I'm saying formation starts. Yes, once the baby is born, the first 3-4 days, the milk is called colostrum, and that is the most important part of the milk for the baby, all that you know. When does the formation start? I'm repeatedly telling you, it starts forming as early as 4th to 5th month of pregnancy itself. So areola become broader, and many small elevations are seen, which are hypertrophied sebaceous glands. So on the edge, you'll see these sebaceous glands. Men, women both have these sebaceous glands, but they become hypertrophied. They become a little bigger in pregnant mothers. So that is what is known as the hypertrophied sebaceous glands, also known as the glands of Montgomery. The glands of Montgomery. Montgomery tubercles. All right. कुछ नहीं पढ़ा, please guide. Circle MBBS first year के terms का tension हो रहा है. All right, guys, people who are not getting tense because of an exam coming up, they are not reading. तो देखो, tension होना अच्छा है, थोड़ा सा डरना जरूरी है. If you're not scared, that means you're wasting your time. You should be scared of the exam. Then only you'll read यार. कोई बात नहीं, पढ़ते रहो. Even if you're tense, if you're not able to read and you're not able to understand, sit with your best friend. He's reading, ask him questions, he'll help you. He or she will help you. So please understand that do not take an exam very cool all the time. ये जो तुम लोग का Gen Z वाला एक let it be cool यार, stay positive. अरे negative रहो थोड़ा, नहीं पढ़ोगे तो फेल हो जाओगे ना. तो मैं तो कहता हूँ negative रहो. एक दिन एग्जाम के पहले आके मुझे बोलोगे सर मैं पढ़ा नहीं हूँ, हाँ stay positive, अच्छा है, oh you're good, you will pass. वो सब झूठा है. थोड़ा डरो, थोड़ा नेगेटिव रहो, तभी तो पढ़ोगे. पॉजिटिव ही रहोगे, सारा टाइम पॉजिटिव रहोगे तो डरोगे कैसे? इफ यू आर नॉट स्केर्ड, हाउ विल यू रीड? ये बहुत सिंपल सा प्रिंसिपल है लाइफ का. इफ यू आर नॉट वरीड, यू विल नॉट रीड. ठीक है, थोड़ा सा डरना चाहिए, इट विल पुश यू. And maybe if you're not doing good in this exam, learn from this experience that one day before the exam I was so tense. Learn from the experience. Let the experience drive a message onto you that next time I have to be better prepared, my friend. Next time I have to be better prepared. तो ये भी एक एजुकेशन है. Yes, to get tense before the exam which you've not prepared for, it's an education that next time, bloody hell, I have to be better prepared. I was in a revision class, but I was asking sir about how to write an exam. I was not worried about what was coming on the subject. That's how tense you are. All right, chalo, let's get on to the subject because we have more work to do. Chaliye. So cardiovascular system. So cardiovascular system, what happens? The heart moves upwards because of the increasing in the height of the size of the abdomen. The heart moves upwards and outwards. So heart moves upwards and outwards. And see this heart. Can you see this is the mid-clavicular line? The mid-clavicular line, you generally see the apical impulse. But now what happens? The heart will move outwards. This heart will go outwards like this. So the apical impulse, the apex will go to the anterior axillary line. So you will hear the heart a little bit later and upper, the anterior axillary line. There is hypertrophy of the cardiac muscle. Cardiac output will increase. Now cardiac output starts increasing as early as the 5th week and it peaks at 32 to 34 weeks. So the maximum cardiac output, these MCQs keep coming in your exams. When is the cardiac output maximum? That's what we are going to discuss in the pregnancy and then in labor and then in delivery. So that's the most important chapter about the organs, which we keep talking to you, changes in organs in the woman's physiology, and the cardiac changes are the regular questions which are asked in the exams. So this is a diagram inspired by Williams obstetrics. A non-pregnant woman has 5 liters of output per minute, and a pregnant woman will have 7.1 liters per minute. And after delivery, it will be 9.3 liters. So heart is having a lot of work to do around 30 weeks. Around 32 weeks, the heart is pumping a lot of blood because volume is maximum in the antenatal time. But now what happens after delivery? 800 ml blood is there in the uterus. Remember that 800 ml goes with the contraction of the uterus, that 800 ml blood goes into the circulation, and that high volume will make the mother have a cardiac output even more. The cardiac output will be even more, 9.3 liters per minute. So yes, the heart works even more after delivery. That's fine. The mother is healthy. She can manage all of this. No problem. She is 5 liters in non-pregnancy, 7.1 liters at 32 weeks, and first 24 hours after delivery, immediately postpartum, 9.3 liters. This is all normal physiology. Women are ready for this. They are prepared for this during the pregnancy. Everything is fine with this. Problem happens when she is pregnant with a heart disease. Then these times, the antenatal time 32 weeks and postnatal time first 24 hours become problem. So see here, cardiac output, maximum cardiac output in the antenatal time is 30 to 32 weeks. Maximum cardiac output in postnatal time is the first 24 hours. Cardiac output in patients will increase at these times. But if it's a case of heart disease, then cardiac failure can happen because the heart is not so good. Let's say it's a case of rheumatic heart disease and the patient is having mitral stenosis, and the mitral stenosis heart will not be working very well. It will be probably fibrillating sometimes. So that heart which is not working properly will have to suddenly work too much at 32 weeks, will have to start working too much in the first 24 hours. That's why cardiac failure happens in these times, in antenatal time 32 weeks and postnatal time first 24 hours. Solid in MCQs. And when you have your heart disease exams in the obstetrics, when you have this cardiac case, they'll ask you about these details, normal and what happens in a heart disease. Then what happens to the blood pressure? In the early pregnancy, the blood pressure reduces. Then later pregnancy, the blood pressure goes back to normal. It picks up. It goes back to normal. I'm not saying it increases. No. Normal is that in the early pregnancy, in the first trimester onwards, till the early second trimester, blood pressure is dropping. And by the late second trimester, blood pressure goes back to normal. Okay, this is what is the normal changes. Heart rate will increase, stroke volume increase. Just now I told you cardiac output will also increase. But what does not increase? Let me just tell you. We're talking about the heart, but just to make you remember, respiratory rate, there is no change. This is, I have a habit of telling you MCQs all the while because ultimately we are writing PG entrance now. So that's why I have a habit of telling you a lot of MCQs when we're discussing theories. So respiratory rate, there is no change. Okay, so heart rate increases, stroke volume increases, cardiac output increases, and mean arterial blood pressure decreases by 10%, peripheral resistance decreases by 35%. These are the two things we reduce, and MCI exam, they kept asking you this MCQ many times. And INICET, these two exams generally keep, adan pradan chalta rehta hai MCQs ka between these two exams, INICET and MCI. So mean arterial blood pressure, peripheral resistance decreases. What is the supine hypertension syndrome? when the mother is lying down supine, if you see the mother lying down, then the weight of the baby presses on the vena cava, and that reduces the venous return to the right heart. And when reduces the venous return, the cardiac output reduces. Reduced cardiac output for the mother, she may feel a little giddy or a little sleepy, but it is not a major problem for the mother. It's a big problem for the baby. The baby will get hypoxic sometimes. 10% women, not all women, okay? So in 10% women, the weight of the baby when it presses, it causes significant hypotension, which can cause hypoxia to the baby. So yes, supine compression of great vessels by the uterus, significant arterial hypertension, good enough to cause hypoxia of the fetus. That can also happen. Right, that's why we say that the pregnant mothers should sleep like this, on the left side or on the right side, one of the sides. So the weight of the baby will fall away from the vena cava. But also for the cesarean sections, the mother should not be like this. The mother should be like this, a little bit tilted, 15-degree tilted. Today, just today, around 4 hours back, one of my IVF conceived patients was having a cesarean, and God bless her, she had a tough time to have a pregnancy, and now finally she's on a very happy day today. And when the cesarean was happening, I went to the OT, although I hardly get time to get into obstetrics these days. But I went to the OT, I was requesting the consultant, please give a lateral tilt. So the anesthetist was one of my students, old PG entrance student. She said, sir, I've given a lateral tilt. I'll never forget how you demonstrated in the class that you were turning. So I'm so happy that my students remember. She was anesthetist in the OT today, and she had already given the table a lateral tilt. Generally what we do, we don't have suppose a motorized table, so we put a wedge, what do you call, a wooden block under the buttock, and we give her a 15-degree lateral tilt. Or sometimes what we use, a IV fluid bottle, we put it under the buttock, and that's why it gives a lateral tilt. So yes, even during a cesarean, you should do this lateral tilt. See, when the baby is mother supine, the baby's weight is pressing the vena cava here. If you can see, this is the vena cava, it is compressed. So if you give a 15-degree lateral tilt, see, the vena cava is now distended and it is not compressed. All right. Okay. Childbirth, yes, the milk is released only after childbirth, obviously, because you need the suckling reflex and the oxytocin. So yes, that can happen. But yes, lot of women who are pregnant for the second time, and the first child is only 1.5 years, so they are breastfeeding also during pregnancy. That it's not that it cannot happen during pregnancy. Some child has to suckle on the breast and they will be milk discharge, but we don't advise it. It's a little controversial. We don't advise mothers who are pregnant to breastfeed the previous child. We don't advise. So breast milk production starts in pregnancy, and if really you ask me, can breastfeeding happen during a pregnancy? Obviously it can happen, but it's going to drain out the woman a lot, because breastfeeding requires a lot of resources of the mother's body to make breast milk. So it's not advisable to breastfeed a previous child when you're pregnant for the second time. All right, I hope that answers your question. Cardiac output, I've already told you, cardiac output increases during pregnancy 30-32 weeks, and during labor after delivery in the first 24 hours. So 50% increase in the 30-32 weeks, and after delivery 70% increase. That's why these two times when the heart work is more, if a patient is a case of heart disease, there is more chances of failure. I'm sure if you want to hear this again, it is already recorded. It will be there on the YouTube. So don't get upset if I've gone a little fast, because I was told it's a revision, right guys? So we must finish things a little snappy way. I'm not going to rush through it. We are discussing with a lot of examples. We'll try to make use of this class. All right. So normal change in the heart sounds with pregnancy, then exaggerated splitting of the S1 because of the large volume of blood. So increased volume is the reason why there is exaggerated splitting. Loud and easily heard third sound, the S3, because of the rapid filling. There is rapid filling of the left ventricle. Rapid filling of the left ventricle is the reason why you'll hear the S3. And then 95% patients will also develop a flow murmur, simply because of high volume of blood going through the aortic wall. So there will be a systolic murmur also. These are all physiological changes. Hematology. Another example, another organ which is asked a lot in your exams. So blood volume increases by 30 to 45% at 32 weeks of gestation. I told you cardiac output increases. That's because the blood volume increases. So this blood volume increase is because of the reduction in the threshold for thirst. प्यास ज़्यादा लगती है. She is thirsty early. நிறைய தண்ணி கொடுக்குவாங்கப்பா அவங்க அதுக்காக. So she's going to drink a lot of water because she's thirsty faster. So that's why more water goes in, and then she's got a sodium retention. So both these can happen. That's why there is more fluid. That's why there is more fluid in the mother who is pregnant. But we must understand a few more things, not just increased blood volume. We must think in terms of fluid and RBCs. Please look at this diagram very carefully. Red cell number increase, fluids also increase. But can you see the red cell number is increased, but the fluid amount increases much more in proportion to the RBC increase. Once more, see, if you look at these two diagrams behind me, yeah, fine. Okay, RBC volume increasing, correct. Fluid volume increasing, correct. RBC increases, fluid increases. But the fluid increases much more than the RBC increase. So what happens? There is more fluid rise than RBC rise. There is a net hemodilution in pregnancy. खून पतला होता है pregnancy में. So RBC amount increases, correct. They'll ask you a question. What is the net number of RBC in pregnancy? More. Net amount of fluid in pregnancy? More. But what about the RBC concentration? There is hemodilution because the rise in RBC is lesser than in proportion to the rise in the fluid. So there is net hemodilution. खून पतला होता है pregnancy में. So what is the benefit of that? Why is nature making the blood thinner in pregnancy? It is good for the see, hemoglobin drops here from 13, it drops to 11 gram%. That is because the RBC is the blood is getting hemodiluted. I'm not saying less than 11. Less than 11 is anemia. So why is it good to have hemodilution? It is good to have hemodilution because I've written this here. It is good for the fetal perfusion. Can you see the uterine artery which is giving blood to the spiral arteries? If the blood is too thick, the blood will get static. There will be stasis of blood in these spiral arteries, and stasis of blood means there will be clotting of blood. So you want thin blood. So that's why the blood in the state of hemodilution will be good for the perfusion in the placenta and nourishment to the baby. Also, when delivery happens, when the baby delivers and the placenta is removed, the base of the placenta will bleed, and that time the blood is thin blood which is lost. There is more fluid loss than RBC loss in delivery. So very important, the blood in delivery is more fluid loss than RBC loss because खून पतला है. That's why nature has done a very wonderful arrangement that blood is thin so that perfusion is easy for a small early initial placenta. Number two, when the delivery happens, the blood loss is more fluid loss than RBC loss. That's why we say that there is a good arrangement to conserve the RBCs in pregnancy. All right, let's move on and see that there is decrease in the, just a summary, decrease in the red cell concentration. There is increase in the number of RBCs, but concentration reduces. That is what I told you just now many times. Hemodilution will happen in pregnancy. Now, hemoglobin concentration will also reduce. Hematocrit, which is another method of saying hemoglobin is less, and plasma folate concentration will reduce. But what will increase? Clotting factors will increase. See, WBC increase, ESR increase, but the clotting factors will increase in pregnancy. Why am I shouting now? When a woman delivers, the placenta delivers, and the placenta delivers, the base of the placenta bleeds, and the base of the placenta can bleed 800 ml in a minute. So you want more fluid loss than RBC loss, correct? So the blood is thin, more fluid is lost than RBC loss. That is one thing I already told you. Now, wherever the bleeding is happening after delivery, जहाँ पे bleeding हो रही है, वहाँ पे clotting ज़्यादा है कि कम है? There is more clotting or less clotting at the place? There is more clotting in pregnancy. Another wonderful arrangement by nature that at the site of the bleeding, the base of the placenta, the clotting is much better in pregnancy. That's why we have a very good arrangement by nature. Thin blood, loss is more fluid loss than RBC loss, and at the site, of the bleeding, the clotting factors are more. So clotting will prevent more further blood loss. So all clotting factors in pregnancy are increased except 11 and 13. All those who are writing the exam on 17, this is likely to come in exams, guys. Clotting factors 11 and 13 are not increased. Rest all the factors are increased. There are 13 factors, out of which 11 are increasing. Only, I mean to say total 11. Factor number 11 and 13 are not increased. All right. Fibrinogen levels, I'll just tell you, these may come in your NEET exam. That average is 300 milligram per deciliter in a non-pregnant woman. In a pregnant woman, it is increased by 50% and goes up to 450 milligrams per deciliter. Right, respiratory system, the chest will open up a little because the baby is coming up and the chest opens up. So the subcostal angle, this angle, if you see this subcostal angle here, this angle, this will increase. So from 68 degrees goes to 104 degrees, diaphragm rises by 4 centimeters, but respiratory rate, there is no change. I'm writing William says so that you don't contradict what I'm saying. Okay, so respiratory rate, there is no change. Vital capacity, there is no change, but the tidal volume increased by 40%. All right, so tidal volume increases, respiratory rate, vital capacity is unchanged. Mug it up, you can understand also easily. But what is more important? The functional residual capacity. It is the personal scuba tank. That's how I understand this. FRC is my personal scuba tank. Like when I hold breath, why don't I die? When I'm underwater and I'm not coming up for, let's say, 30 seconds, why don't I die? Because my FRC, my own oxygen tank, which is there, the residual oxygen in my lungs is keeping me alive. So that functional residual capacity, which is the expiratory reserve volume and the residual volume, that reduces 20 to 30% in pregnancy. Don't feel bad. Don't feel bad for this pregnant mother because she increases her inspiratory capacity in pregnancy to compensate for the loss of this. So inspiratory capacity increased by 5 to 10%. So what is the net result? Total lung capacity, which is a combination of functional residual capacity and inspiratory capacity. FRC plus inspiratory capacity is the total lung capacity, and this is unchanged. So that's why therefore, pregnant mothers are not hypoxic. Please remember that. Pregnant mothers are not hypoxic because the FRC has reduced, but the inspiratory capacity has increased. This will compensate for the loss of the FRC. So total lung capacity is unchanged in pregnancy. All right. I've tried to God, not nature. Okay, God, not nature. Okay, fine. That discussion is some other place. Nature is also under God's commands. So we'll do that discussion some other time, my friend. So for the time being, I think, I don't know what Batao he's asking me, but you can ask me the question again later on, my friend. So right now, we'll just get into our other discussions. So urinary system, kidney size increased by 1.5 centimeters and glomerular filtration rate increased by 50%. Now, this hyperfiltration is because of the hemodilution. Now, there is reduced protein and reduced oncotic pressure and increased renal plasma flow. These are things which you have to remember, but remember this part easily. The glomerular filtration rate increases. Why am I stressing on this part? If the GFR increases, that means the clearance of waste from the body will increase. What is waste? Urea. Creatinine is what is the waste? So the waste is cleared faster in pregnant mothers. So that's why the serum creatinine levels will reduce and the creatinine clearance increases. That's why serum creatinine is reduced. We'll discuss that in the next screen. One more thing I have to tell. 155 milligram per deciliter. Mother has had just a bowl of rice with some dal and she has the sweet lassi and the sugars increased to 165. That itself will come in the urine and you will think maybe this patient is having diabetes. This kind of glucosuria can happen to a lot of pregnant mothers. It may not be abnormal because the threshold is reduced. Right? I hope you understood that. No, obviously, twins, the physiology gets more reverse. The anemia is more and the the uterine distension is more. Obviously, that's correct. You will have to ask me a specific question. We're not doing the twins class right now, guys. We're doing the basic discussion. But yes, in twins, it is still worse. Correct. So, serum creatinine, like I was telling you, serum creatinine levels will decrease and creatinine clearance will increase because the kidney's filtration is more. So, waste will go out more from the kidney. So, creatinine clearance is more. That's why creatinine levels are less in the body. So, bladder frequency will increase because of the the pressure of the pregnant uterus on the bladder. So, there will be more pressure and more urethral length because of the stretching. That's why frequency also increases. Now, what about the gastrointestinal system? That is what is also important. Pyrosis, heartburn increases, and there is a thought that in pregnancy progesterone is more, and progesterone makes everything slow. Correct. I agree with you. Progesterone makes the person also lazy. First of all, the mother wants to sleep most of the time. She's slowly walking, and she's mostly in a sleepy this thing, because progesterone makes a person very relaxed. So the bowel also gets relaxed. What did I say? The bowel gets relaxed. The gut, the large bowel especially, gets relaxed. So that's why the pregnant mothers are constipated. The liver canaliculi movement is also reduced. The gallbladder duct movement also reduces. So there will be some biliary stasis also. But I did not say that the gastric clearance is not changed. Gastric emptying time is different from bowel. Gastric means stomach. So stomach empties in 4 hours like it does for all of us. We eat lunch at 2 o'clock, and by 6:30, 6 o'clock, 4 hours later, we are thirsty again, isn't it? We are hungry again. So 4 hours it takes for the stomach to get empty, and it's the same 4 hours in the pregnant mothers. So gastric emptying time is unchanged. Bowel is slow. So yes, mostly your large bowel is reduced because of the progesterone. There is constipation, there is increased presentation of the hemorrhoids. Now what happens to the liver function? SGPT, SGOT, gamma glutamyl transferase, all are reduced, but only alkaline phosphatase doubles. Alkaline phosphatase doubles up. Although the total albumin amount increases, but the fluid rise will cause the reduction in albumin concentration, just like the RBC I discussed earlier. And progesterone, like I told you, inhibits the cholecystokinin mediated smooth muscle stimulation. So this progesterone will make the gallbladder and the biliary canalicular movement reduce. So that's why impaired gallbladder contraction will cause the retention of the bile salts. So that's why bile salts will be retained, and bile salts cause the itching. Yes, bile salts itch, BSI, bile salts itch. So retained bile salts, because of slow movements, that retained bile salts, what? Cholic, phenoldeoxycholic, these are the bile salts. Then bile acids, you should know, they are the combination of these bile salts with the glycine and the taurine. You must know all of that, okay? So bile salts kya hai, bile acids kya hai, primary bile salts and secondary bile, you have to know all of this, okay? So please read your biochemistry well, but remember that bile salts, when they are retained, they cause a lot of itching. So itching is not because of bile acids, it is not because of bile pigments, it is not because of bilirubin. Bile salts will cause itching. Bahut sari itching, that's the mnemonic which I am giving you here, right? Endocrine. Now before I go into endocrine, I'll just see some questions, because bahut sari itching, okay? Medico Traveler remembers that, okay? Fine. Why bowel slow here? Because of progesterone. Progesterone causes smooth muscle relaxation. I told you that. Progesterone also, remember, progesterone is used for tocolysis also, for stopping uterine contractions. Preterm labor, progesterone is a tocolytic because it relaxes. We give a lot of progesterone tablets to mothers to prevent preterm labor and also to treat preterm labor sometimes. So yes, progesterone causes smooth muscle relaxation, that you have to remember. And that's what helps in understanding that the gut is peptin neurons, and that reduces the gonadotropin releasing hormone. So high prolactin reduces the kiss-peptin neurons, and that's why the GnRH amount coming from the hypothalamus will be stopped, and that's why the FSH in LH will be reduced. That's why pregnant mothers do not ovulate. That's why mothers who are lactating do not ovulate. Very, very important, okay? So this reduction is because of high prolactin reducing the GnRH. High prolactin reduces GnRH. So that's what I written here. Gonadotropins decline in number. This is a very important endocrine change. Right. How to feed this? Internet connection. Wait a minute. I think it's working now. I'm sorry if there was a problem. How does the fetus excrete? Fetus, see, fetus also excretes like us. Fetus will excrete. I did not discuss that in the class, so you didn't miss anything. Fetus will have no food in the gut. Fetus only has fluid coming to the body from the mother through the umbilical artery, and that umbilical vein, rather, the fluid, the blood which comes from the placenta goes to the baby, and that fluid will keep coming, and that baby is absorbing a lot of fluid from the mother's circulation. That fluid will go to the kidney, and the baby will excrete through the kidney. But the baby also has a gut which is made, and the gut will have epithelium. The epithelium will be shedding, and the gut will also be having some amount of bile coming in because of the gallbladder. So gallbladder will give some bile into the gut, and the epithelium will shed in the gut, and that will make that pasty meconium which will come out as stools. So these are the two mechanisms, stools and urine. That's what is the mechanism of excretion in all humans, including the fetus. So I don't know, maybe you want to ask me a special question. That's why. So it doesn't matter. Your handwriting is not visible, so I'll not use red. Red was a problem I could see. I'll use black. Yes, thank you for reminding. I keep forgetting. So I'll use only black. Thank you. So this, you remember, the high prolactin reduces the kiss peptide neurons, that reduces the GnRH, and that is causing reduction of FSH and LH. That's why there is no ovulation. No ovulation in pregnancy and in lactation. All right. Then one more thing I want to tell you, that the corticotropes and the thyrotropes are constant in pregnancy, but the somatotropes are generally suppressed. Somatomamotropin, yes, the growth hormone stimulation. The growth hormone stimulation reduces. Why? Because the growth hormone which is made by the placenta makes a lot of growth hormone, and that will reduce the somatomamotropin. That's why the somatotropes are reduced in pregnancy. Again, you have to mug up a few things, okay? Corticotropes, thyrotropes are constant, but somatotropes are reduced. But the next one is most important, the thyrotropes. Now let's get into the thyroid function. Very important slide again. So please remember, the free T3 and free T4 are unchanged in pregnancy. Solid MCQ. Free T3, free T4 are unchanged. The active form of thyroxine is unchanged in pregnancy, the amount. But what happened to the thyrotropin or TSH? Now let us see that first. So what happens in pregnancy? I'll just tell you. Before that, see this. Hypothalamus, again, it acts on the pituitary by thyrotropin releasing hormone. Thyrotropin releasing hormone from hypothalamus acts on the pituitary, and pituitary will release what? Thyrotropin releasing hormone will obviously release the thyrotropin. It releases thyrotropin. I know you're screaming wherever you're sitting. Nahi sir, TSH boliye aap. Yes, it is also known as TSH. So remember this thyrotropin. That's why you'll remember thyrotropes. So if you know, increase your vocabulary, you don't get confused in the exams. That's my impetus in all my classes, that please remember synonyms. So I told you gonadotropin releasing hormone releases what? You say FSH and LH. No, you must say gonadotropin releasing hormone releases gonadotropins. What are gonadotropins? FSH and LH. Similarly, thyrotropin releasing hormone releases thyrotropin. So what is thyrotropin? A hormone which acts on the thyroid. Thyrotropin. It is also called TSH. So you must know the synonyms. So this will act on the thyroid. I know most of you know that, but some of you are in a hurry to read and you miss out on the synonyms. So thyroid releasing hormone acts on the thyroid gland, and the thyroid gland will get stimulated to make the thyroxine. Now, what happens in pregnancy? In pregnancy, there's a formation of a placenta, and the placenta makes the HCG. Are you able to see this? No, we'll stick with the black. So the placenta makes the HCG. This HCG, remember, the alpha subunit of HCG is same as the alpha subunit of TSH, is same as the alpha subunit of LH. Please remember that very important part of your basic biochemistry. Alpha HCG is same as alpha TSH is same as alpha LH. So we are keeping this in our mind. So the alpha subunit of HCG from the placenta, this will come and directly stimulate the thyroid gland. So the thyroxine will increase in production because of this alpha HCG acting like the alpha TSH. Now the thyroxine will increase, and this high thyroxine will give a feedback message to the hypothalamus, and hypothalamus will reduce the thyrotropin releasing hormone, which will reduce the TSH or thyrotropin. Extremely important, guys. This is coming in your INICET exam nowadays. So the HCG from the placenta stimulates the thyroid gland to make the thyroxine. Thyroxine is high, gives a message to the brain that there is enough thyroxine, don't stimulate me anymore. The thyroid is telling the pituitary, मेरे को धक्का देना बंद करो. So this high thyroxine tells the brain to stop the TRH. So TRH reduces, so that's why the TSH reduces. So in pregnancy, TSH reduces. Yes, that's why they'll ask you what is the level of TSH in pregnancy. You and me, if we ask, the upper level of TSH should not be more than 5. In pregnancy, it should not be more than 2.5, because the TSH is not required so much in early pregnancy, because the placenta is giving HCG, which is stimulating the thyroid gland to make the thyroxine. Yes, stop, rewind, and re-listen to this part. All right, please remember, TSH is reduced in early pregnancy because the placenta has high HCG, and the high HCG is there only in the initial few months, that is 9.5 weeks of pregnancy. The HCG is high, so that high HCG is stimulating the thyroid gland to make the thyroxine. That's why there's a feedback which reduces the TSH. I've told this many times here. Right, guys? So HCG, I've written that also just for you want to remember this. So HCG has intrinsic thyrotropic activity, and that high HCG will cause a stimulation of thyroid, and that's why the TSH reduces in early pregnancies more than 80% of patients. So normal TSH levels in pregnancy are less than all of us 2.5 international units in the first trimester and 3.5 international units in second trimester. You and me, normal adults, in normal adults, it is up to 5 international units in normal adults. All right. Right, that's what I wanted to teach you about the physiological changes. You can ask me some questions. A lot of you ask me a lot of things, and will you give any lecture for this January FMG? Yes, we are coming on 9th. On this 9th, we are having a big marathon discussion. Not marathon, don't think 9 hours, 10 hours. Good enough time for your discussion of all the gynae MCQs. Don't miss out on that, guys. I've sent it on a lot of forums, but yes, sometimes I may not be able to put it on all the sites. So you'll have some advertisements coming up now. So there is a proper FMG exam revision on 9th, 6 p.m. Okay, we'll be doing all the MCQs. Do not miss out on that, guys. Yes. Endocrine part, tell again. Sutta Prasmanta. Which part? You tell me. Endocrine, which part? Which one do you want me to tell? This one? Okay. Yes. 6 p.m. guys, 6 p.m. 6 p.m. on 9th. Okay, this part you want? So yes, once more, just for my good friend here. So remember, okay, I'll tell you about this one also first then. Okay, here. So first I'm telling you about the GNR relation. Hypothalamus acts on pituitary by gonadotropin releasing hormone. The pituitary will make FSH and LH because of gonadotropin. Pituitary also will make the prolactin. Prolactin will act on the breast. Breast will be stimulated to make milk by prolactin, which you know. But this high prolactin gives a message to the hypothalamus to reduce the kiss-peptide neurons. The kiss-peptide neurons are used to stimulate the GnRH release. So you reduce the kiss-peptide neurons, so GnRH will be reduced. The high prolactin reduces GnRH. GnRH is reduced, so there is no LH and FSH in pregnant mothers. That's why they don't ovulate in pregnancy. And also after delivery, the mothers are breastfeeding the children. That's why they don't ovulate during breastfeeding also. Okay, that's one. Number two, I was telling you about the thyroid function. So hypothalamus acts on the pituitary by thyrotropin releasing hormone. So when the TRH reduces, okay, fine, I'll go the other way. Hypothalamus acts on the pituitary by thyrotropin releasing hormone. This pituitary will act on the thyroid gland to make the thyroxine. So thyrotropin releasing hormone acts on the pituitary to release the thyrotropin, also known as TSH, which acts on the thyroid gland to make the thyroxine. Now, what happens in pregnant patients? That the plasma makes alpha HCG. Alpha HCG is same as the alpha subunit of TSH. So this alpha subunit of HCG acts like thyroid stimulating hormone. So that acts on the thyroid gland to increase the thyroxine. Now thyroxine production is met with, ban gaya, jitna thyroxine banna tha ban gaya. So enough thyroxine made, it gives a negative feedback, not positive guys, a negative feedback to the brain that there is enough thyroxine. So brain reduces the thyrotropin releasing hormone. That's why it reduces the TSH. So that's why in pregnancy, the TSH is reduced 2.5 versus 5. All right. Palmer sign is rhythmic uterus contract. Kiss peptine is the neurons. Kiss peptine are neurons, facts, which are stimulating the hypothalamus. These neurons stimulate the pituitary by releasing the GnRH. Facts. You have to remember some facts. So Palmer sign, rhythmic uterine contraction between 4 to 8 weeks. Chalo, which channel? I'll be here, man. Doubt. Okay, keep telling me the doubts, Aditya. I'm here for your doubts. I'm here. This PW, man, PW. We are going to discuss here live on YouTube. Yes, you're going to get it, all of you. Please tell your friends to come and attend the class. And going to be a lot of MCQs. I'm trying to cover all the topics. But do not miss out on this, please, guys, because it's important to do a quick revision. So I hope you're reading all the notes which we've given you. All those who have read the, the notes earlier, please come and revise with me. Those who have seen me in live classes also, please come and see me here again. And so that we can do a quick revision. Ask me a lot of questions. I'm always here. Triiodothyronine, man. T3. Okay. Supine hypertensive syndrome. When the person is supine like this, the weight of the baby will press on the inferior vena cava, and that pressure on the inferior vena cava will reduce the venous return to the mother's right heart. So there will be reduced perfusion of the lung, reduced return to the left heart. So left heart will have less output. Less output means the mother will be having less cardiac output. She'll be not having much problem with that. She might be getting a little giddy because of that. But the lesser output means lesser perfusion to the fetus also, and that's what can cause the fetus to have hypoxia. The baby can have hypoxia, 10%. Yes. Medical problems in obstetrics and those medical problems which are very important are hypertension, pregnancy and GDM. And please remember, both of these topics regularly come as your exam cases also in your final year. So in this quick fire revision, we are going to discuss about those intricate bits which come in your exams as theory also, and also come as your viva questions, right? So let's see hypertension first and then diabetes. But before I go into detail, I want to give you a broad understanding of these two topics. Look, even if you're joining late in this class, I want you to understand this upfront. Hypertension pregnancy and diabetes in pregnancy. Both I'm going to give you a common information which is extremely important for the understanding. Hypertension can be chronic. Let's see, there's a girl who is only 15 years. At 15 years of age, she has high blood pressure. Already she's a case of hypertension. She gets pregnant, let's say at 30 years of life. At 30 years, when she's pregnant and she comes to me at 7 weeks of pregnancy, she's already a known case of hypertension. So what kind of hypertension that is? Chronic hypertension, which is presenting in pregnancy. Or they can be women, let's say a 29-year-old woman who's got married and she's now pregnant. She's never had hypertension, and she's now coming to me around 24-25 weeks. Now her blood pressure is high. So if the blood pressure increases after 20 weeks, then we say it is gestational hypertension. So hypertension pregnancy can be two types. The chronic hypertension, she's already a case of hypertension, now got pregnant. Or it can be gestational hypertension, that the blood pressure is high for the first time during the pregnancy. Now, when that happens, when the gestational hypertension happens, this is happening after 20 weeks. So this will have a somewhat better prognosis as compared to gestation, as compared to hypertension, which is present from many years before she got pregnant. So chronic hypertension will behave worse. So let's say you could be having chronic hypertension because of essential hypertension, renal artery stenosis, or pheochromocytoma, whatever reason. And gestational hypertension is blood pressure more than 140/90 after 20 weeks. And obviously, chronic hypertension will have worse prognosis in pregnancy. Similarly, we have the same understanding for diabetes in pregnancy. A young girl, let's say a 10-year-old child, she's a case of insulin-dependent diabetes mellitus. She's on insulin all her life. She gets pregnant at 30 years. So she has pre-existing diabetes or overt diabetes, and now she's got pregnant. But there can be a girl who comes to me, she's got married at 25 years, and she's never had diabetes in her life. And for the first time, her sugars start increasing after 24 weeks. She was never a case of diabetes ever in her life, but the sugars increase in the 24th week onwards. So that is known as gestational diabetes, gestation diabetes mellitus. So diabetes can also be like this, that she could be having a chronic or a overt diabetes and she's got pregnant. She's come to me at 7 weeks of pregnancy. She's already a case of diabetes. Or she gets diabetes for the first time after 24 weeks of gestation. You tell me which one will be worse. The diabetes which is present chronically, because if she is a diabetic chronically ever since she was 10 years of age, she'll be having nephropathy, retinopathy, neuropathies, all these problems will be there, or some damage to all these organs. If not frank retinopathy or neuropathy, some organs to this damage to these organs would have already started. So that's how we must understand that hypertension can present for the first time pregnancy, diabetes can present for the first time pregnancy. Hypertension presents at 20 weeks after gestation. Diabetes presents after 24 weeks after gestation. After 24 weeks, gestation diabetes. So we'll be talking about all of this. We'll be talking about gestational hypertension and chronic hypertension. We'll be talking about gestation diabetes and chronic diabetes. But you must have a basic understanding that chronic hypertension pregnancy and chronic diabetes in pregnancy will behave worse. That's the first part. But I want you to ask you a very simple question. If a woman gets hypertensive for the first time after 20 weeks in a pregnancy, if a woman gets diabetes for the first time after 24 weeks in pregnancy, what went wrong in the pregnancy? What was the reason because of which she has hypertension in pregnancy after 20 weeks and diabetes in pregnancy after 20 weeks? Yes, there's a common reason. Yes, it is the placenta which is the reason. Very, very important to understand. That's why it is called pregnancy-induced hypertension, gestational hypertension. Diabetes in pregnancy, which is gestation diabetes, is because of gestation. So what is the gestation doing to make this woman have hypertension and make this woman have diabetes? It is the placenta which is the main culprit. The placenta does not give good blood supply. Mother has to increase her blood pressure. Gestational hypertension after 20 weeks. Placenta is interfering with the endocrine and the metabolisms by making human placental lactogen in high amount after 24 weeks. That interference will increase the sugars in pregnancy after 24 weeks. So that's why in both the conditions, gestational hypertension, gestation diabetes, the placenta is the culprit. That's why we say moment the delivery happens, the woman becomes better with these two conditions. That is the confirmation of your diagnosis, that once the delivery happens, the blood pressure gets all right and the diabetes also gets all right. That's why it is known as gestational hypertension and gestation diabetes. All right. Keeping these figures in mind and keeping these ideas in mind, we'll get into the discussion. Excuse me. Let's move on and see. First, we'll see hypertension pregnancy, they'll get into diabetes. Yes, all of this probably you have read a lot of times and your teachers have also taught you, but let us just quickly do a revision today here. Gestation hypertension, blood pressure more than 140/90, protocol 5 sound we have to use. We have to use the muffling, okay? 140 by 90. After 20 weeks, 2 times, 6 hours apart, not one reading, and in a previously normotensive woman. Now, along with that, when there is proteinuria, we call it preeclampsia. But remember, this gestational hypertension is going to get better after the delivery. So that's why it is also known as the transient. It is also known as the transient hypertension. It is known as the transient hypertension. All right. Then what is preeclampsia? Along with this hypertension, there is proteinuria, which is more than 300 milligrams of protein in 24 hours, or 1 plus or more on dipstick. The urine protein creatinine ratio, that means more protein is coming in the urine. So if this increases more than 0.3, that is also suggesting. So these are the methods of diagnosing preeclampsia. Just hypertension after 20 weeks, we say gestational hypertension. If there is proteinuria, we call it preeclampsia. And then along with that, if there are convulsions, tonic, tone, whole body tone increases first, whole body tone, and then clone, generalized tonic-clonic convulsions. Please, I'm not seeing any other type of convulsions. Tonic-clonic convulsions. All right. So that is what is known as eclampsia. Before I go into, I think I'm not able to see your questions. Just give me a moment. Yes, I think they'll fix it up. Let's get to work. So that is the basic 3 definitions: gestational hypertension, preeclampsia, and then eclampsia. Now, once a patient has eclampsia, this we say is the worst case scenario. Anytime a woman comes with high blood pressure in pregnancy, eclampsia na ho jaye. She gets preeclampsia. God, the stage before eclampsia is preeclampsia. This is also known as earlier as pregnancy-induced hypertension, also called preeclamptic toxemia earlier. So this is the stage before eclampsia. So you're worried, admit the patient and manage her because she's getting preeclampsia. And eclampsia means the worst case scenario. Why worst case scenario? Next, the patient is going to die. Yes. What happens next? She goes into HELP syndrome, hemolysis, elevated liver enzymes, low platelets. Then she has worsening of her kidney function. She'll have pulmonary edema, cortical venous thrombosis, and then she'll have DIC and she will die next. So that is the problem with eclampsia. Next, she's going to die. So guys, eclampsia means end of pregnancy. Yes, this is what they will ask you in your exams. When a woman has eclampsia, what do you do next? You will give magnesium sulfate, you know that. But what do you do with the pregnancy? The pregnancy is the cause of hypertension. Remember, the placenta is the culprit. So you have to remove the placenta, meaning you have to remove the pregnancy. That is the best management of eclampsia. So remember, we are doing the basic understanding of the topic, but the crux of the complete management should be understood right now. That if a woman has hypertension pregnancy, the worst case scenario is eclampsia, and she's had the eclampsia. That means take the baby out. The pregnancy does not continue after that. Magnesium sulfate and out. So that's why we teach you the way, we tell you all of this. Okay. So very important. There are some other definitions which you have to know. Chronic hypertension, that is pre-existing hypertension presenting in early pregnancy, which I told you just now in the beginning of the classification. This can be essential hypertension, renal artery stenosis, and pheochromocytoma. But there can be another third question which comes in your INICET many times. What is acute on chronic hypertension? There's a young girl who was having blood pressure ever since she was 15 years. She got pregnant at 30 years of age. And while she was coming to me in the first trimester itself, she was a hypertensive. I started on labetalol or methyl dopa or hydralazine, whatever drug. She's already a hypertensive in the first trimester. I've put her on some drug. Whatever drug she was taking, let's say she was taking a beta blocker or whatever she was taking, I have changed that and I've started a pregnancy safe drug in the first trimester. Now, while she was pregnant, at 20 weeks, she gets super added hypertension of pregnancy. She gets super added gestational hypertension. So that's why it is called acute on chronic. That means she was already a hypertensive. Now in pregnancy, she got acute on chronic hypertension. So that is super added gestational hypertension. So how do you diagnose that? The diagnosis of this is done by new onset proteinuria, first time protein coming in pregnancy, which was not there earlier. So that is the criteria of diagnosis of acute and chronic. Platelets become less than 100,000, that is less than 1 lakh. Creatinine 1.1 milligram per deciliter, and liver enzymes more than 2 times the normal. So that is the diagnosis of acute and chronic. There's another entity known as delta hypertension. Delta hypertension means her blood pressure was low throughout pregnancy, but later half of pregnancy, last trimester, it becomes a little higher than this. It is still in the normal range, but understand this delta hypertension. The blood pressure was normal throughout pregnancy. Later half of pregnancy, it is a high normal. Let's say in early pregnancy, the BP was 130 by 80. Later half, let's make it even more lesser. It'll be easier for you to understand. Early pregnancy, it was, let's say, 100 by 80. And later in pregnancy, it becomes 130 by 84. So this is normal and this is also normal. But later half of the pregnancy, it's become higher than the low normal it was. So it is high normal. You know what? If the blood pressure becomes 130 by 84 for a woman who was always 100 by 80, this itself can cause a woman to go into having proteinuria, and rarely patients have thrown convulsions, and you are surprised that the blood pressure is not so high. Why is she throwing a convulsion? So please understand, delta hypertension is also an entity, again an INICET favorite question. So we are still discussing the definitions. I told you about gestational hypertension, then I told you about chronic hypertension, and then I'm now telling you acute on chronic, and then delta hypertension. Let's move on and see the main question which is coming in all the exams, whether you're writing your final MBBS exam or you're writing your PG entrance exam. They're always asking you a stage which comes before the stage of eclampsia. The stage before eclampsia. It is not a defined stage, but it is a stage which is very important for you to know, because you can prevent eclampsia in that stage. So that is what is known as imminent eclampsia or impending eclampsia, or the stage of worsening hypertension. Wait, let me explain that to you once again in detail. There is gestational hypertension, blood pressure more than 140 by 90. Then there is proteinuria, means preeclampsia, and then she throws a convulsion, which is eclampsia. This one you understood very well. There is a stage which is here, it comes here. Before eclampsia, you can see some signs and symptoms which tell you that she's about to throw a convulsion. So you can prevent that convulsion from happening. What happens in a convulsion? She's convulsing, she's not breathing when she's convulsing, isn't it? Any woman or a man, any child who throws a convulsion, any moment of life, that moment the person is not breathing at all. So the person is not breathing, the person gets hypoxic. But what's worse, this woman is pregnant. The baby gets severe hypoxic brain damage, maybe born hypoxic and have brain damage for the rest of his life. Or maybe the baby will be dead intrauterine because of the hypoxia for 7-8 convulsions which this woman had. When a woman convulses, we know it can be bad for the mother, but worse for the baby. So if you can catch this before she convulses, that is what is imminent eclampsia. So how do you know she's about to throw convulsion? What are the signs of imminent eclampsia or impending eclampsia? Please mug up these signs: nausea, vomiting, headache, blurring of vision, epigastric pain, exaggerated knee jerk, reduced output, diastolic blood pressure more than 110, and proteinuria more than 2 grams in 24 hours. That is severe proteinuria. If it is more than 3.5 grams, we call it nephrotic range of proteinuria. So those are the problems which can be there when a woman is having this impending eclampsia. Catch the woman at this stage before she throws a convulsion and treat this patient. How do you treat this patient? Same management of eclampsia. What is the drug of choice for eclampsia? Magnesium sulfate. And then what do you do? Terminate the pregnancy. Then what is the management of imminent eclampsia? Give magnesium sulfate now and plan a delivery now, because you are smart enough to catch a woman at the stage of imminent eclampsia. Start giving Maxel, and also make sure you are planning the delivery, because she is now about to throw a convulsion. So that's what is imminent eclampsia. Extremely important for you to remember this. So what is the etopathogenesis? Now, basically, there are 2 stages of hypertension happening. One is the poor placentation, which I have already told you. I've given you a I've leaked the answer before I started this topic, that what is the main culprit in gestation diabetes and gestation hypertension? It is the placenta. If the placenta is not formed properly, there will be increase in the blood pressure. Yes, I'll tell you that exactly how it happens. And then there is a maternal syndrome. So what is poor placentation, we'll see, and what is maternal syndrome, we'll see. There are two stages. We'll quickly go through this. You have read about this, but it's extremely important to revise. So in normal placenta, what happens? The blood flow from the uterine artery and then the arcuate arteries and then the basilar arteries, then the spiral arteries, they are giving blood supply into the placenta. How does the baby get the nourishment? Baby has got his villi. See this? These blue things which I have made. The baby is dipping the villi into the blood in the placenta. The baby doesn't take the blood of the mother. All of you know that. No blood transfusion happens across the mother and the baby. Mother could be A positive, baby could be, AB negative. So, mother could be O, baby could be B. So, all kind of blood groups can be there in mother and baby, but they can never be a mixing of the blood. So, how does the baby take nourishment? Baby will just dip his villi into the mother's blood. So, that villi which is going inside is dependent on a good placental flow. The spiral arteries which I have made here, these spiral arteries should give a good flow into the placenta, and that placenta which has a good amount of blood, the villi which has dipped into it are going to take the nourishment. So I'm going to show you this in a diagram here. Now look at this diagram, again inspired by Williams Obstetrics. If you see, these are the spiral arteries, these are spiral arteries. See, same thing. These spiral arteries, I'm giving you a much better diagram here. So the spiral arteries are giving the blood into the placenta. So this black thing is basically the blood of the mother. And what is happening? The villi are dipped into this blood. So baby is not taking the blood of the mother. The villi are the suction tubes. These suction tubes are dipped into the blood, and the baby takes the oxygen, minerals, and the proteins and the carbohydrates and the lipids. Everything is sucked in, just like that. The mother is just giving the blood, and the baby is put his, these sucking tubes into this. That is what is known as a villi. So villi, if you look at this, my hand, and look at the villi, is just like this. It's a syncytium. It's a net. The villi is just dipped into the blood, and this the these fronds, these are called the net which is dipped into the mother's blood. So this is known as the syncytiotrophoblasts, and this is lined by cells, cytotrophoblasts. So they will go into the tissues. So the trophoblast which is outside the villi, they are trophoblasts in the villi, cytotrophoblasts. Then they are the trophoblast which is outside the villi. So we call him the extravillous trophoblast. See this term here, the extravillous trophoblast. They will come and they will replace this smooth muscle. Can you see? The smooth muscle is slowly replaced by the trophoblast, and now there is no smooth muscle left. So as the pregnancy advances, see, early pregnancy, third trimester, there is a dilated blood vessel. There is no muscle. So that's why there is more blood into the placenta. Where there is more blood into the placenta, and that's what gives good perfusion in the placenta. This is what is normal. Now, if this is not proper, this is all the syncytoblasts and the cytoblast I told you is the villi, and then endovascular extravillous trophoblast. The trophoblast outside the villi will be replacing this. So that's what I taught you here. Now, if this is not happening properly, if this muscle, can you see this muscle here? If this muscle is not replaced properly and the old circulation persists, can you see the blood vessel is very narrow now? If you see this picture, the blood vessel in the early pregnancy is narrow. In the later pregnancy, dilated, more blood going to the placenta. But if it stays like this, the amount of blood going to the placenta is less. So the mother will increase her blood pressure to overcome this vasospasm. Mother will increase the contractility of her heart and increase the blood pressure, and that blood pressure will go through this and give nourishment to the baby. At the cost of increasing her blood pressure, mother gives nourishment to the baby. So yes, this vasospasm is the punchline of this chapter, hypertension pregnancy. I told you what is the cause of hypertension pregnancy? Poor placentation. If you know that, you've already passed your MBBS exam. but you want to get better marks in your MBBS exam, you have to say what is poor placentation. Poor placentation means vasospasm of the spiral arteries. Why vasospasm? Because the muscle is not replaced by the trophoblast. Getting complicated? You have to know this, guys. Do not get disinterested. If you're feeling that you did not understand, pause now, rewind and start again. I have not missed one line. So do not even think of dissociating from this topic. Hypertension pregnancy and diabetes in pregnancy, they are the only two cases which come regularly in your exam. Breach and coming in your clinical cases, long cases, unlikely. They'll ask you hypertension and diabetes, basics. And in your PG entrance also, these two will always come. So don't get disconnected. Go back, rewind and listen and come back to this stage again. All right, guys. So we are talking about poor placentation, basically vasospasm. To increase this, increase the flow across this, the mother increases the blood pressure. So stage 1 is the poor placentation, which I told you what it basically means. Inadequate replacement of the muscle layer by the trophoblast and persistence of primitive vasculature, persistence of the previous vasculature which was there in the spiral arteries before the plasma was formed. The same vasculature persists. So that's why there is vasospasm. And that vasospasm reason why the mother increases the blood pressure, more forcible increase to give nourishment to the baby. Now, when the blood pressure increases, it does not increase only in the placental area, isn't it? The blood pressure increases all over body. That same high blood pressure goes to the kidney, zigging. It just breaks the glomeruli and the patient will have proteinuria. It will go to the liver and the liver will have acina damage and they'll be bleeding in the liver. Subcapsular hematoma. Remember I told you epigastric pain? Epigastric pain is not because of gas. It is because of a subcapsular hematoma. High blood pressure goes to the eye. Retinal, blurring of vision will happen because of papilledema. There can be retinal detachment. High blood pressure going to the brain, causing release of glutamic acid and causing the patient to have convulsions. All of that is based upon the high blood pressure which is going, and that high blood pressure is detrimental to all the organs, not just to the kidney, all over the body. So that is what is the poor placentation. So in addition to that, now quickly we'll go through this part. This is a little complicated. Keep your attention going for another 2 minutes and then it'll become easier for you guys. So in addition to the poor placentation, the vasospasm, what else is contributing to the vasospasm? We are still with the stage 1. We are talking about the poor placentation. What else contributes to the poor placentation? Maternal syndrome I have not started explaining so far. I am talking about poor placentation. So role of immune factors in poor placentation is normally in all humans, the T helper 1 cells will mediate the secretion of the inflammatory cytokines, and T helper 2 is the humoral immunity. And in normal pregnancy, there is a T helper 2 cells bias. T helper 2 cells, these are the ones, the humoral immunity will be the major contribution of immunity in pregnancy. But what happens? There is a T helper 1 function increase in some patients, and this causes deficient vascular modification, and that results in vasospasm. How it results in vasospasm? Slightly complicated. We'll just leave that part. Just remember, T helper 2 function is more in pregnancy, but if T helper 1 function increases, it causes the deficient vascular formation. All those cytokines and those mediators of inflammation, they will increase and they will predispose to vasospasm. So T helper 1 function is what is going to increase, and that promotes to vasospasm. What else will promote to the contribution to all of this is the hypertension, is the maternal syndrome. Now we're getting into the second stage. I told you there are 2 stages of the hypertension pregnancy. One is the poor placentation and the second one is the maternal syndrome, that is the stage 2. So endothelial activation causes vasospasm. What is this now? Endothelial activation. Endothelium gets irritated, it gets in the blood vessel, goes into vasospasm. So basically what is happening? Poor placentation. What is poor placentation? Vasospasm. What is contributing to the vasospasm? Poor placentation, because of the muscles not getting replaced by trophoblast and the T helper 1 function increasing. Now there is something else, the endothelial activation causing vasospasm. So what is endothelial activation? Because of the vasospasm can be contributed by the increasing in the vasopressors, angiotensin 2, thromboxane A2, endothelin 1, they will all increase, but there will be reduction in the vasodilators like prostacyclin, prostacyclin is reduced, nitric acid is reduced. So all of these are reduced. So when this is reduced and this is increased, that will lead on to vasospasm again. So yes, there is a reduction in the ratios. That's what came in the INICET exam. So the prostacyclin and the thromboxane A2 ratio will be reduced, because if you say prostacyclin is here PGI2 and the thromboxane A2 is here, now this is constantly reducing and this is constantly increasing. So this ratio will reduce. So what happens to this prostacyclin thromboxane A2 ratio? That's what came in one of your exams, INICET exams. All right. So that's the reason for that. Now, in the etiopathogenesis, we are talking about the Mendel syndrome now, and Mendel syndrome, which is contributing to vasospasm, there is something else. Reduction in angiogenic factors and increase in the anti-angiogenic factors. This is what came in your INICET exam. So guys, don't even think of getting dissociated with the topic. Just keep holding the topic, guys. पकड़ के रखना topic को, छोड़ने मत देना, निकलना नहीं चाहिए हाथ से. Come on, guys, push yourself. We are talking about placenta forming properly. So there should be blood vessel formation. For the blood vessel formation, there is help by growth factors. Growth factors makes angiogenesis. So growth factors are like the transforming growth factor TGF, vascular endothelial growth factors, also the placental growth factor PLGF. All of this will bind to the receptors on the blood vessels and cause angiogenesis. But when you have some inhibitors of these growth factors, those inhibitors like the soluble endoglin here and the soluble FLT1, I'll tell you what is that. So soluble endoglin, soluble SFLT, they will inhibit. Soluble endoglin will inhibit the transforming growth factor to bind to the blood vessels. Soluble FLT1 will inhibit the vascular endothelial growth factors to bind with the blood vessels. So when this binding does not happen, the blood vessels do not dilate properly. So yes, endothelial dysfunction, impaired relaxation. When the angiogenesis is not proper, the blood vessels are narrow in diameter. So for the angiogenesis, you need what? Growth factors. What is inhibiting the growth factors? Soluble endoglin and soluble FLT1. So they will not allow the binding and there will be vasospasm, and that again is contributing to the poor placentation. So yes, please understand this same picture, the one picture which I showed you before, I am explaining that in a written manner here now. So angiogenic factors like the transforming growth factor, that transforming growth factor is reduced, and the vascular endothelial growth factor and the platelet, placental growth factor, all of these growth factors are reduced. How they reduce? The transforming growth factor is bound by the increase in the soluble endoglin. The vascular endothelial growth factor is bound by the soluble FLT1. What is FLT1? Soluble FMS-like tyrosine kinase 1, SFLT1. Soluble FMS-like tyrosine kinase 1. That will bind. Same what I showed in the picture, I'm telling you here. So these growth factors are inhibited by those anti-angiogenic factors, so blood vessels don't form. And that's what causes bad vessels, and that's what makes the mother increase the blood pressure. You're getting upset, I know. Too many words, too many names. Guys, you can just walk out of your rooms, go to the nearest path lab, and all you girls can go and get this test done. Even before you planning a family, you know. Yes, these values are high in early pregnancy for a lot of people. You can get this blood test done these days. This is commercially available, guys. Yes, commercially available test hai aaj ke liye. And you guys are thinking too much ho gaya. Please do not get dissociated. PIH is absolute must for you guys. Okay, remember we are talking about good formation of blood vessels, and if that is not forming because of anti-angiogenesis, that's what are the factors like soluble endoglin and soluble FLT1. Right. The other factors which are easy to remember are like this other factors I'm telling you, I'm just giving a summary, I forgot. So all these factors, poor placentation, endothelial activation and vasospasm, that's what causes bad blood vessel formation, and that's why the mother increases blood pressure to overcome the vasospasm. So I've told that many times, just that we are revising it here. Right. So other etiologies which contribute rest. Primary graders will have more chance of hypertension. Now we can do this part quickly. This is very easy to remember. And grand multigraders will have more problems. And also grand multigrader, you know, more than 5, more than equal to 5 pregnancy grand multigrader. Twins and molar pregnancy, anemia, malnutrition will contribute. And also what is going to contribute? Genetic diseases like thrombophilia, the affinity to make thrombus. So blood vessels are blocked, mother increases blood pressure. And those thrombophilias are APLA and dysfunction of the MTHFR gene and the factor V Leading deficiency. Please, with your medicine people, read thrombophilias, okay? Not the time to discuss thrombophilias in detail today. Pre-existing endothelial damage like in renal disease, diabetes mellitus and SLE. So diabetes is frequently correlated with hypertension. Yes, it happens many a times. And associated with IVF pregnancies, assisted reproductive technology pregnancies also will have more. So what is the pathology? The pathology is in the blood. First we'll see the hemolysis. Can you see these broken RBCs, the schistocytes? It is due to the microangiopathic hemolysis. Due to microangiopathic hemolysis, and that is going to cause anemia, increase in LDH because of hemolysis, and this hemoglobin which is free will be bound by the free hemoglobin is bound by the haptoglobin. So the haptoglobin is utilized to bind the free hemoglobin, so haptoglobin will be reduced. Schistocytes are these broken RBCs, they will increase. Then liver will have SNR damage. Liver will have SNR, the cell damage, and SNR damage will cause the increase in the enzymes. We call it the transaminitis, increase in SGPT, SGOT, okay, periportal hemorrhages, and that cause subcapsular hematoma. These subcapsular hematoma cause the epigastric pain like I told you earlier. And then liver function, remember, is essentially normal. Liver is having a strain. Liver is having increase in the enzymes, but it's doing its work properly. What happens sometimes that we get confused with acute fatty liver of pregnancy. Acute fatty liver of pregnancy is liver failure basically. There the things are totally damaged. Here the liver is having a hit, but it is still working normally. It is battered and bruised. It has got a hematoma also, bruised really, but it is still doing its work. So that's what is the basic thing you have to remember in hypertension pregnancy. Yes, eventually there can be a liver failure if you're not taking the means to correct it. There can be liver failure, but most of the time in hypertension pregnancy, the liver is working normally with a strain on it. Right, central nervous system, microscopically there will be fibrinoid necrosis. There is fibrinoid necrosis and there is this perivascular microinfarcts. So because this perivascular microinfarcts and the fibrinoid necrosis, if these are seen in the frontal cortex, there will be headaches. If these are seen in the occipital cortex, there will be scotoma and there will be blindness. This changes if they are seen in these areas of the brain. They can be in many other areas causing respective symptoms, but mostly we talk about these. And then there will be cortical and subcortical petechiae, intracerebral hemorrhages, and then there will be release of neuroexcitatory neurotransmitter. What is this neuroexcitatory neurotransmitter? Glutamate, glutamic acid. This glutamate which is released is going to cause the convulsion. That's the reason. Right. What happens to kidney? Kidney will have something called the endotheliosis, capillary glomerular endotheliosis. So with hypertension pregnancy, there is reduction in the glomerular filtration rate and the renal blood flow. Why? Because of capillary glomerular endotheliosis. This word has come in your NEET exam already. Now let me try and explain this to you. What happens in this one? The high blood pressure causes endothelial damage. So this is a normal glomeruli. See, this is the normal glomeruli. Can you see glomeruli will get blood supply and the endothelium has these small fenestrations which give nourishment to the glomeruli. Now there is endothelial swelling. When there is endothelial swelling, this blood vessels get swollen up like this. Blood vessels get swollen up. When the blood vessel gets swollen up, naturally these openings will get obstructed, they'll get closed. See, these openings are now getting closed. So these are the swollen fenestra, they will get closed. So when, can you see this picture? I'm sure you can understand. Look at this endothelial thickness here. Look at the endothelium thickness here. It's a thick endothelium. When it gets swollen, these fenestrations will get blocked, and when they get blocked, there is poor pumping to the kidney and kidney damage. So that's why acute renal injury, acute kidney injury, we keep saying, isn't it? So that's what is the capillary glomerular endotheliosis. If you did not understand that, remember this name. This is what is coming in exams, capillary glomerular endotheliosis. I am sure you understood this also. If you did not, then go ahead and replay this, guys. Fine. So there is this damage is due to increase in the renal afferent arteriolar resistance, and this will block the filtration. Capillary glomerular endotheliosis blocks the filtration and cause the renal damage. Then of course there will be the HELP syndrome, which you know is because of the the ongoing damage to the body. There will be hemolysis, elevated liver enzymes and low platelets. Hemolysis diagnosed by the Burr cells, schistocytes, bilirubin more than 1.2 milligrams per deciliter, low haptoglobin, which I explained to you. LDH is 2 times what is the normal value, it is twice that, so more than 600 units per liter. And then elevated liver enzymes, which I told you, more than twice the normal, low platelets. Now, impact on the eyes, they can be retinopathy, and that retinopathy is seen in almost 100 patients. Matlab, can be various degrees. It does not have to be, bad retinopathy with blurring and papilledema and detachment always. Mild, moderate, severe type of retinopathy is there. I'm sure the opthal teachers are going to tell you the retinopathy stages and all that also. But remember, retinopathy is seen in almost 100% patients with eclampsia. 100% patients of eclampsia will have some retinal changes, but in 30 to 40% patients of pre-eclampsia also will get the retinopathy. Symptoms can be blurring photopsia, scotomas, and there will be arterial narrowing, retinal hemorrhages, cotton wool spots, macular edema, and even papilledema. Right. So yes, I took a lot of time to explain you the etiology and pathology, but all of this is the impact, and let's get into the treatment. The treatment part is more important. Okay, retinal detachment also there, fine. Treatment of hypertension pregnancy. Look, OPD management, you know the drugs. The drug of choice is labetalol, and I'm just going to tell you the name of the drugs. Okay, please remember the pharmacology you read. We are trying to do a quick revision. Read the pharmacology, I'll just tell you the name of the drugs, but remember, gestational hypertension can be managed at home. Yes, just high blood pressure can be managed at home, but if there is proteinuria and the patient is having pre-eclampsia, then we tend to admit the patients. All right, so this can be managed at home. Antihypertensives can be given, but pre-eclampsia always admit. Evaluate the peripheral smear, the clotting profile, liver enzymes, give steroids, because in hypertension complicating with proteinuria, you may think in terms of doing an early delivery, so you may have to give steroids to get the lung mature. For the early maturity of the lung, we may have to deliver the baby by, let's say, 34, 35 weeks. So maybe even earlier because of hypertension, and she's going into preeclampsia. If you're having that, then you may have to give steroids for lung maturity. So maternal surveillance, 4-hourly blood pressure, and the weight gain you have to see not more than 500 grams of weight gain in a week. Okay, urine routine, uric acid, creatinine, LFT, LDH, all of that will help you diagnose the organ damage. And then very, very important, fetal surveillance. That is what is the most important topic of obstetrics, fetal surveillance. Any woman having pregnancy, we are very vigilant about pregnancy. So all women are seen in the antenatal OPDs. But when there are high risks, we increase our surveillance. So surveillance is what is obstetrics. Before we get into diabetes chapter, understand whether it is hypertension pregnancy, diabetes, twins, intrauterine growth restriction, heart diseases, any problem in obstetrics, we increase our surveillance. Surveillance, look, what is the drug of choice for hypertension pregnancy? Even before the lecture, you know it is labetalol. What is the drug of choice for diabetes in pregnancy? Insulin. That also you already know. Does that make you an obstetrician? No. You became an obstetrician only if you know surveillance. Because knowing the hypertension and knowing that you have to admit her and knowing that the kidney is getting damaged, you have to continue the pregnancy as far as possible. You have to take care of the mother. You have to take care of the baby also. So for the baby, you have to be very vigilant. So both mother and baby should be good and continue the pregnancy till as close as possible to term. And for that, you need your surveillance. And to do surveillance is what is obstetrics. You admit her, you check the movements of the baby, check whether the baby is having a reactive NST, and you check if the baby is having a good amount of liquor around him, and you check the movements, which is known as the biophysical profile. You see the blood flow to the baby, Doppler, and you buy 1 week. Then again you do all these tests, buy another 1 week. Slowly you're taking the pregnancy towards term. Surveillance is the only topic in obstetrics without which you cannot attempt any exam, be it your MBBS exam or your PG entrance or MCI exam, whichever one you're writing. Do not go out without surveillance. We are discussing surveillance in a few days from now, but remember, in every high risk the surveillance increases. So I'm just saying, see the mother, do these investigations, see the baby also. We'll discuss the details in a different day. So far we're talking about the treatment of hypertension. So let us see the drugs. We are talking about the hypertension management, OPD management. This is alpha plus beta blocker, and we avoid it in asthmatics because it's a non-selective beta blocker. But I'm telling you only this much. I'm not going to detail of pharmacology today. The other drug we can give is hydralazine. It's an arteriolar dilator, and that is going to reduce the afterload on the heart. It's a good drug, one of my favorite drugs. But yes, previously the drug of choice was methyl-dopa. Methyl-dopa is a prodrug. It gets converted into alpha-methyl norepinephrine. We give it 250 milligrams to 500 milligrams 4 times a day. It causes side effects of drowsiness, depression, and also a false positive indirect Coombs test. Again, we'll just move on. There are drugs, more drugs like nifedipine, prazosin, all those drugs are there. So we are just talking about the management of eclampsia, which is more important, those details. Rest you read the pharmacology. Now, what are the contraindicated drugs? Now, this is, you have to know this properly. Favorite exam question. Favorite means all, there are 5 entrance exams in a year. 2 of INICET, 1 of NEET, and 2 of MCI. And this will come in at least 3 exams, maybe sometimes in 4 exams. Contraindicated drugs in hypertension pregnancy. So furosemide should not be given. It causes intrauterine growth restriction. Furosemide reduces the circulatory volume of the woman. So what is the problem? Blood pressure will reduce, right? What is the etiology of hypertension, guys? Etiology of hypertension is what? I told you one punchline, poor placentation. Then I told you what is the meaning of poor placentation? Vasospasm. And when there is vasospasm, there is more perfusion or less perfusion? Less perfusion. So when there is less perfusion to the fetus, because of that, the mother is increasing the blood pressure and giving some nourishment to the baby. Now at that time, we must understand the circulatory volume of the mother is important to give some nourishment to the baby. So we need the circulating volume. The mother is not having hypervolemia. Please, once again, you and me, if we get hypertension, non-pregnant women, men, whenever we get hypertension, we are mostly having volume overload. So that's why furosemide can be given. But pregnant mothers have a problem of poor perfusion to the baby. And then you give her a diuretic, there will be still lesser volume in the mother and lesser perfusion to the baby. The baby will get intrauterine growth restriction. That's why hypertension etiology is totally different from hypertension pregnancy etiology is totally different from hypertension to normal humans. Yes, there is no volume overload in pregnancy induced hypertension. There is no volume overload. There is actually poor perfusion. You cannot take out more fluid from the mother. So that's why furosemide is contraindicated. I'm not going to write all of that, guys. Okay, so remember furosemide, IUGR, because this much you must remember, because pathology is vasospasm. Remember that. Then beta blockers, again, beta blockers if you give, they're going to cause intrauterine growth restriction. But what is the drug which they'll keep asking you many times, which is contraindicated? AAC inhibitors, because AAC inhibitors, enalapril, captopril, lisinopril, some example they'll give you. They're going to cause hypocalvaria, renal agenesis, oligoamnios, and limb contractures. So that's why AAC inhibitors are contraindicated in hypertension pregnancy. Now, hot shot part of the class is the treatment of eclampsia. Resuscitate, maintain airway, prevent injuries, any convulsion you'll do that. But what is the management of the medical management of this convulsion? That is what is coming. Any convulsion you have to manage the way general management we've told you. But what is the management of the eclampsia? So drug of choice is magnesium sulfate, and the regime of choice is the Pritchard regime. It is the Pritchard regime, okay, and that is given IV plus IM. Okay, so Pritchard regime, which is given IV plus IM, is that drug which we have to give. So the dose given is IV we give 4 grams and the IM dose is 10 grams. Mind you, the dose is in grams, not in milligrams. So 14 grams is the loading dose. Also, we can give 2 grams more, 2 grams extra if it is required. If the convulsion is not stopping, we can give 2 grams extra IV. 2 grams IV we can give extra. So yes, 4 grams is given IV, 10 grams is given IM. IM is split into both the buttocks, right and left. We give 5 grams in one buttock and 5 gram in the other buttock. And because each is actually in 10 ml, it is in 10 ml. That's why it's a big volume injection. That's why you have to split it. Sometimes we even add lignocaine to prevent the pain in the muscle because of such high volume injection which you're giving. So the level of Maxwell which is achieved is 4 to 7 milliequivalents per liter. That's the level we want to achieve when we're giving magnesium sulfate. So yes, next, what do you do? When the woman is having hypertension pregnancy, you're worried that she should not have preeclampsia. When she's having preeclampsia, we are worried that she should not have eclampsia. Now, when eclampsia happens, what is next? She's going to die. Remember, that's how the chain of events I told you. So, eclampsia is the time now nothing will continue. The delivery has to stop. So, you give the magnesium sulfate, but start the delivery process. You have to do that. You have to start the delivery process. Next, do the delivery. And that reduces the blood pressure to normal in 90% of patients in 1 week. That's why we call it the most definitive management. Yes, it is called the most definitive management of eclampsia. Very important MCQ here. Okay. The blood pressure is normal in 90% patients in 1 week. So continue Maxwell after that. Suppose she delivers at, let's say, 7 p.m. she delivers after the convulsion. We have done a cesarean or we've done a normal delivery. Look, I did not say that cesarean is a method of delivery. No, 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 no. Don't get me wrong. If a mother is in labor, let's say she is 38 weeks and she's in labor, and during labor she throws a convulsion. You know she's going to deliver. She's 4-5 centimeters. She's going to deliver. So you control the convulsion and make her deliver normally. Another 3-4 hours she'll deliver. And you control the convulsion. But suppose she throws a convulsion at 35 weeks and the cervix is tight, os closed, bishop is like 2 or 3, unfavorable bishops, less than 6. So if it is unfavorable bishops, even if you induce labor, she's going to deliver probably tomorrow or day after tomorrow. So then you can do a cesarean. So the mode of delivery is not important. What is important, you must understand that you have to deliver, whichever method is appropriate that time. Now continue magnesium sulfate, 5 grams 4 hourly for 24 hours. 5 grams 4 hourly for 24 hours. And remember, this is where you have to take care. When you're giving this, how do you manage? How do you monitor this? So monitoring the magnesium sulfate is coming because magnesium sulfate is a cerebral suppressant. It is going to suppress the brain. If it is suppress the brain, it is suppressing the brain to stop the convulsion. But the suppression can be so bad that she can even have a respiratory depression. So you must monitor 3 things. In addition to blood pressure, pulse rate, all that, you have to monitor 3 very important things. Knee jerk should be present, and the respiratory rate should be more than 14 per minute. And because magnesium sulfate is a cerebral suppressant, that's why these two should be at these values at least, and the urine output should be more than 100 ml every 4 hours. Why I'm saying every 4 hours? Because you have to give 5 grams 4 hourly. So when you're giving magnesium sulfate, it is stopping the convulsion. But if the max self is too much, you'll have respiratory arrest. So make sure the max self is getting washed out also from the body, and magnesium sulfate has renal excretion. the urine output should be more than 100 ml in the last 4 hours. So suppose I have seen the delivery of the woman happens at 7 p.m. Then 11 p.m. you have to give the next dose. 3 a.m. you have to give the next dose. 7 a.m. the next dose. 11 a.m. tomorrow. So when I'm going to give the dose, let's say at 11 a.m. tomorrow morning, at that time the renal output for this last 4 hours was only 70 ml. That means the magnesium sulfate is not going out of the body. This is what they'll ask you in your exams. Finally, at MBBS, this is the time when you should remember. We are doing detailed, even though I was told that I must just do a revision. Till your MCA exam, I'm making sure that you guys have lot of detailed discussions on the major topics, in addition to my final years getting an revision for their exams. So yes, you have to understand that urine output should be more than 100 ml in the last 4 hours, and they'll ask you that if it is less than 100 ml, then what do you do? Suppose tomorrow morning 11 o'clock I'm going to give the next injection. I have to give it for 24 hours after the delivery. 11 o'clock when I see the output is less than 100. If the output is less than 100, what happens? That means the clearance is not good. So withhold the next dose. I'm not going to stop the max self totally. I'm going to withhold the 11 o'clock dose. I'm going to see her again at 3 p.m. At 3 p.m. if the parameters are fine, I give the next dose. So for 24 hours after the delivery, we have to give the magnesium sulfate. All right. So yes, that is what is extremely important. Before I tell you about I'll see the questions. Wait, just I'll tell you more of this. If any of these are not met, then you have to withhold. That I told you already. Then magnesium sulfate toxicity. I'll just deal with this and then I'll see the app for the questions which you people are asking me. I know the display is here giving me a problem. I'll just put it on. Okay. I don't know, it's still not showing properly. There is a live chat on the YouTube, but I'm not showing it here. Maybe I'll see it in YouTube. Yes. Okay. I'll see your questions. Yeah, I'm on again, guys. I'm so sorry for the delay. All right. So we are talking about the magnesium sulfate toxicity, and we're talking about the magnesium sulfate toxicity. We are discussing that if the magnesium sulfate is too much, then we have to stop the next dose. We have to withhold the next dose. So how do I know? How do I know that the magnesium sulfate is getting into excess dose? So first sign of toxicity is at 8 to 10 milliequivalents, because normal what you require is 4 to 7 milliequivalents. So more 8 to 10 is going to cause knee jerk suppression. It's going to cause a knee jerk suppression, and 10 to 15 is going to cause a respiratory depression, and more than 15, see, more than 15 is going to cause a respiratory arrest, and if it is more than 25, it's going to cause a cardiac arrest. So that's the problem with magnesium sulfate. So if there is too much of magnesium sulfate circulating in the body, that is going to cause the patient to have the problems of even a respiratory arrest and cardiac arrest. So treatment is calcium gluconate. All of you know the dose, 1 gram intravenous over 10 minutes, and you give it in 10 ml solution. So this keeps coming in your exams. How much is the dose of calcium gluconate? So now maybe I'll see your questions. What is fenestration? Fenestration means a small hole in the blood vessels, small hole through which the nourishment is going. Fetal surveillance we are not going to discuss today. It's a long topic. We have a dedicated topic discussion of fetal surveillance, my friend. Fetal surveillance, I've told you the tests like NST, biophysical profile, Doppler, and all of these are the tests. But we'll get to that in a proper discussion later. All right. So, blood pressure control in the stage of eclampsia. Look, what we discuss in the outpatient department, that is hypertension is there, we give tablet labetalol, tablet methyl-dopa. Now we are talking about a woman who is convulsing. So, how do you control the blood pressure in a woman who is convulsing? You cannot give oral drugs. She may aspirate if she convulses again. So, we have to give IV labetalol. So, IV labetalol is given 20 milligrams and we can keep doubling it every 20 minutes if we do not get a control, that is. So, 20 milligrams IV we give, and then after 20 minutes we can give another 20, or we can make it 40, or we can make it 80. So, total in 24 hours we can give up to 220 milligrams in 24 hours, as much as this much, 220 milligrams to get a control of the blood pressure. So, we can predict hypertension by the rollover test from the supine position to the when the mother is lying down supine, and if you make her I'm so sorry, if the mother is lying down lateral position like this and you make her supine, so the weight of baby will press over the vena cava and the venous return will reduce, so the output will reduce. So what happens, the mother increases, a reactionary increase in the blood pressure is done. So that blood pressure increases only by 10 millimeters of mercury. So if that rollover increase the blood pressure more than 20, if the rise is more than 20 millimeters of mercury, that is a positive reduction, that around 20 to 32 weeks, if the blood pressure rise from the lateral to supine, if that is what is increasing the blood pressure more than 20 millimeters, that is going to predict that she is going to have hypertension. Isometric exercises, that is sustained hand grip, if that increase the blood pressure more than 15 millimeters of mercury, and then increase uric acid levels, all of this will predispose. Uric acid generally more than 6.5 is going to predispose that the woman is likely, more than anytime more than 5 is detrimental, more than 6.5 we are already thinking in terms of the woman that we have to terminate the pregnancy. So high uric acid levels, isometric exercises, rollover tests. And then how can you prevent? You can prevent having hypertension pregnancy by giving low dose aspirin, which is 75 milligrams or 150 milligrams, because the full dose is 300 milligrams of aspirin. We're giving low dose 75 or 150 milligrams. So that is one mechanism, and it reduces the platelet thromboxane production. That's why it is good. Platelet thromboxane production is reduced, and that's why thromboxane increase is going to cause vasospasm. So you can reduce that. Calcium supplementation reduces the membrane irritability. So calcium supplementation pregnancy is good. Then omega-3 fatty acids, fish oil has it. So this omega-3 fish oil, this is going to, the omega-3 fatty acids, this is going to replace the arachidonic acid in the formation of the steroids. So the arachidonic acids, if it is replaced by this, then the formation of prostaglandins is reduced, and that's why the vasospasm will be reduced. So arachidonic acid is replaced by the omega-3 fatty acids. This fish oil, it is having a lot of omega-3 fatty acids. That's why Japanese people who are mostly having fish-based diet, they have the least incidence of hypertension pregnancy in the world because of their diet. A lot of other fish-eating countries are there, but they eat all the other kind of food also, which is high in fat and all. But Japanese people have far more disciplined lives, and they are totally into fish. That's why they have the least incidence, because of this high amount of fish oil. And that is what is the omega-3 fatty acid is going to replace the arachidonic acid. So now let's get into diabetes, and from my plans, I'm going to, why not all topics are covered in MedEd, especially, why not all topics? You must ask the team. We are doing all the topics in MedEd, obviously. You're having the app also, and we are doing almost all the major topics for the revision. So That's all right. So what is a maternal syndrome? See, poor placentation is bad formation of the blood vessels and vasospasm. Maternal syndrome is increasing in the vasoconstrictors and reduction of the vasodilators, increasing in the anti-angiogenic factors and reduction in the angiogenic factors. So, if there is lesser angiogenesis because of anti-angiogenic factors, and if there are more vasoconstrictors and less vasodilators, that will also contribute to the vasospasm. So, one is the poor placentation, which I told you the blood vessels are not getting replaced by the trophoblast properly, and the other one is the maternal syndrome, which is predisposing to it. There are two things which predispose. So that is important for your theory exams, not for MCI and your PG entrance exams. But I mean, what is maternal syndrome and what is poor placentation? They'll not ask you to write things in MCQ exams, but you should know that what is the reason why is transforming growth factor and vascular endothelial growth factor not able to work, because they are inhibited by things like the soluble endoglin or soluble SFLT1, all of those. Okay, you must remember that is what is coming in your MCQ exams. But for theory exams, yes, like you asked, what is maternal syndrome? I revised once more. I'm sure you can just replay this. Okay, fine. Let's get into a discussion about diabetes in pregnancy. Now, diabetes in pregnancy, again, please remember the values when we talk. I'm just not going to start the discussion till you listen to this part of the class. The values of sugar in a pregnant mother with diabetes, whichever diabetes it is. I've already given you the introduction, whether it is pre-existing diabetes coming presenting in this woman who is pregnant, or she gets pregnant and has high sugars for the first time after 24 weeks, whichever sugar it is. The values are more strictly monitored because the mother can lose a baby. Do not come and ask me, sir, we've been told that fasting can be 126 and it is considered to be normal. That is in diabetes in you and me. You and me having diabetes, and I'm on, suppose on insulin, and my fasting is less than 126. Oh, very good control, Dr. Vij. You have done a very good control with your diet or with your insulin or whatever it is. It's a very good control. But that is in you and me. Pregnant mothers, the fasting has to be less than 100 when we are managing diabetes, and postprandial cannot be more than 120. So now itself, I must make you understand that if you are reading medicine, God bless you, you must be taught a very intensive course on diabetes. And please read it properly. That is what is going to come in all your life, whichever specialty you're going. But we are talking about diabetes in pregnancy. Please discuss the values in pertaining to pregnant mothers with high sugars, because high sugars can kill the baby. Sudden intrauterine death at term. That is that one line because of which this topic is going to be taught to you. Sudden death of the baby. To understand the punchlines, there's no point reading the whole theory and getting confused. The punchline here is that the baby can die because of high sugars. So sugar control in mothers who are pregnant, we admit them. Even today in my hospital, there's my patient who's having a early pregnancy and her glycosylated hemoglobin is 9.9. We have admitted her, and third day today, her insulin requirement is almost 100 units of the mixed-start and combination with regular insulin, almost 100 units she's on right now, because he was saying, sir, I'm feeling totally fine. It's just that I got pregnant, I got to you. I said, please go to the endocrine department. If you're not reaching, then I'm going to admit you in my obstetrics unit. Finally, I got my resident to go with that patient and escorted her to the endocrine department. And like I predicted, she's admitted in the hospital right now. Please come to St. Stephen Hospital and we can see that case together if you're around. So please, diabetes control is totally different. Be very, very strict about sugars in diabetes. Okay. So after that vehement, very emotional impetus on this, let's get into the topic, right? So diabetes in pregnancy, there's a White's classification. Priscilla White, she was a hepatologist who gave the classification of diabetes in pregnancy. Sugars can be high before she got pregnant. WHITE, I'm so sorry. Okay, White's classification, pre-gestation diabetes, that is she's diabetic before she got pregnant, or she's got high sugars in pregnancy. So the sugars are high after 24 weeks, that is gestation diabetes. It is called A1 if it is controlled by diet, A2 if it is controlled on insulin. And pre-gestation diabetes, the diabetes which is there for before 10 years she got pregnant. That means for 10 years she was a diabetic, or 10 to 19 years, C. More than 20 years, D. Associated with nephropathy, associated with retinopathy, associated with heart disease. This classification is not coming in your exams per se, because there are more newer methods of doing this classification, but White's name will still be asked. So NEET exam, they ask you once, who is the doctor who is credited for classified diabetes in pregnancy? So Priscilla White's name is very important. A lot of name things come in the NEET exam, especially. A lot of theory and MCQs will keep coming in all the exams, but names will come. Who got the Nobel Prize for IVF in 2012? 2012, the Nobel Prize was given to Dr. Robert Edwards, because 2011 it was announced in 2012. So Dr. Robert Edwards got the Nobel. That was asked in your NEET exam in 2013. Yes. So please remember these names, White's classification. Then GDM presence and pre-gestation diabetes presence. GDM presence after 24 weeks, and pre-gestation diabetes type 1 or type 2 is present beforehand. So when a person has high sugars after 24 weeks, what can be the problems? I'm not going to go into details till you tell me a few answers here. A woman is having high sugars after 24 weeks. It presents because of some reason. Something is going wrong in the body. I told you it is the placenta. What goes wrong, we'll discuss. So GDM presents after 24 weeks. Pre-existing diabetes is present. Type 1 or type 2 is present in early pregnancy already. I'm not discussing anything. I'm just stopping the class now. Just tell me. Guys, I'm holding the phone here, and now you're going to tell me. Tell me, guys, what is the problem? Look at this GDM I'm talking. What is the problem which can be seen in a newborn because of GDM? What are the problems? Can you just write, just punch in fatafat? What are the problems you can see in a baby born to mother with GDM, gestational diabetes mellitus? Come, punch in. I want to see what you guys are writing. Come. I'm going to wait. We're going to waste 1 minute here to wait and see answers. Problems in a newborn because of GDM. My question. I'm not getting the answers. Come on, guys. Okay. Okay. Now that I don't think or maybe you're not answering, or maybe I'm not getting the messages. Yeah. So guys, what is the problem of a baby born to mother with gestation diabetes mellitus? Please remember, when a baby is born with a mother with GDM, the sugars has increased after 24 weeks. It is increased after 24 weeks. The organogenesis is already complete. Baby's formation of the organs is completed by the first trimester. By 11 to 12 weeks, all the organogenesis completes. So if the sugars are high after 24 weeks, that will never cause anomalies. Please remember, there are no anomalies in GDM. This question has come even in your INICET exams twice. GDM never causes anomalies, but pre-gestation diabetes, the sugars which are high from the early pregnancy itself, that in the first trimester the sugars are high, those high sugars are going to cause the patient to have anomalies. This is directly proportional to the anomalies. Please understand this part first, then only the other things you have to understand in detail. Because remember, if you don't have this, these are the questions which come in exams. Which one of the problems is not seen? You know, they'll say hypoglycemia, hypocalcemia, hypomagnesemia is seen in the newborn. Then they'll say neural tube defects. Neural tube defects is not seen in a case with gestation diabetes, because the sugars increase only after 24 weeks. So that's what you have to understand. So yes, pre-gestation diabetes is directly responsible for the anomalies like I told you just now, and this is due to the toxic superoxide radicals. Free radical injury can cause the anomalies because the heart is forming, the gut is rotating, the diaphragm is forming, all these, and the brain is forming. All these problems can be there because of the pre-gestation diabetes. And expression, altered signaling pathways, and expression of certain genes by high sugars, all of these are going to cause anomalies, but GDM does not cause anomalies. So yes, anomalies are seen because of overt diabetes in pregnancy. So yes, what causes GDM? See, what causes pre-existing diabetes, type 1 and type 2, your medicine people have taught you very well. We are talking about gestation diabetes mellitus. So what is the reason? One is there is an increase in the insulin resistance after 24 weeks. And number two, there is increased insulin destruction by something called human placental lactogen. That is what I was trying to tell you. Placenta is the reason because of which there is hypertension. Placenta is the reason because of which there is gestation diabetes. So what is the reason in the placenta? The placenta makes more human placental lactogen, it makes more growth hormone, and it makes more cortisol. All of these will cause the destruction of insulin. That's what causes the GDM. All right. So how to screen for diabetes in pregnancy? Now, come. When we talk about diabetes in pregnancy, I told you there are two types of diabetes which can present in pregnancy. One can be the diabetes which is happening for the first time in pregnancy, gestation diabetes, which is coming after 24 weeks. Or she could be a diabetic when she comes to me in the first trimester. Which is that diabetes? Overt diabetes. So we have to screen for both of these diabetes. When she comes to me for the first time, she could be a diabetic without herself knowing. She could be a diabetic. So if she's a diabetic without herself knowing about it, we can do estimation of diabetes in the first trimester also. So how do you estimate the diabetes in the first trimester? Glycosylated hemoglobin HbA1c should be less than 6.5. That is the best screening test for pre-gestation diabetes or overt diabetes in the first trimester. Serum fructosamine can be 258 to 288 micromoles, and then fasting blood glucose should be less than 95 milligrams per deciliter. These are the screening methods, but the best is the glycosylated hemoglobin. Now, how do you screen for GDM? Now, GDM happens after 24 weeks. So, we do the one-step GTT, that is after 24 weeks, one-step GTT, and that's the only test you have to remember. So, fasting, you see, it should be less than 92. Give 75 grams of glucose, please. All those 50 grams of glucose for the challenge test and 100 grams of glucose for the diagnostics test, all those are not coming anymore in your exams at least. Yes, you can read about them in your free time, but right now, please remember the test which is coming in all the exams and which is done in most of the hospitals, government hospitals, and the ones which are commercially available, which is the free value GTT with 75 grams. So fasting should be less than 92, 1 hour should be less than 180, and 2 hours should be less than 153. And any one abnormal value is equal to diagnosis, yes, of gestation diabetes mellitus. There is also a DIPSI guideline which has never come in any of your exams at least, but yes, in your MBBS exam they may ask you this. So DIPSI guidelines are the Diabetes in Pregnancy Society or the study group in India. In the non-fasting woman, irrespective of her breakfast status, she has come to the hospital for the first time, but she's after 24 weeks, we do the test. But so she already had a breakfast, doesn't matter. Or she's had a breakfast, she's not had a breakfast. Irrespective of that status, we give her the sugars, and then we give her the sugars. After 2 hours, you check. If it is more than 120, it is called deranged gestational glucose tolerance. 75 grams you have to give. I forgot to tell you that. 75 grams. So if it is more than 120, deranged gestational glucose tolerance. If it is more than 140, we say it is gestation diabetes. If it is more than 200, we say it is diabetes mellitus. So that is the, it's a combination of the old test and the new test. With this one, they have combined with this and given us the DIPSI guidelines. But yes, you should know the first one. So the crux of the discussion so far, the complicated part of this topic, you must screen for diabetes in the first trimester for overt diabetes and in the second trimester for the gestation diabetes. Now, once you've done that, now let us see. The problems in diabetes are common. The treatment in diabetes, insulin, whichever diabetes it is. Only anomalies, that's where we are differently discussing. Only anomalies are seen in the overt diabetes. They are not seen in GDM. That's what is the punchline you have to remember. Right, guys. So let us see. Problems with diabetes in pregnancy, large baby related. If the baby is large, there will be more injuries at birth, there will be more postpartum hemorrhage, there will be more shoulder dystocia, and there will be also more cesarean sections because of the large baby. Of course, there will be more abortions, there will be associated PIH in 25% of cases, abruptio placentae, polyhydramnios, preterm labor, premature rupture of membranes, choriamnionitis, puerperal sepsis. All of these complications are more with patients with having the diabetes, any diabetes. It is not just for gestational or pre-existing. The problems are the same, I am telling you repeatedly. The problems are the same, the treatment is the same. Only anomalies are not seen in GDM. Just remember that part. Then what are the other problems? They can be a sudden IUD at term. Now this that one reason why I told you that you must treat diabetes properly. Any diabetes, high sugars can cause the baby to die at term. What are the reasons of that? That also we'll discuss. It is more with overt diabetes mellitus. Overt diabetes mellitus, pre-existing diabetes will cause more IUD at term. That's why this overt diabetes will deliver slightly earlier than gestation diabetes. And there will be a large for gestational age baby, LGA. So why this sudden IUD at term for bigger babies? So large for gestational age. So reason for this sudden IUD at term is the poor glycemic control, and then fetus having lactic acidosis, maternal ketoacidosis. Ketone bodies are bad for the babies, and then association of hypertension, diabetes mellitus, and then villus edema. That high sugars can cause edema of the villi, and that the swelling of the villi causes the blood supply to stop, and that can cause the baby to die. Okay, so sudden IUD at term, these are very important reasons because of which we are worried about high sugars in pregnancy. Then diabetic retinopathy, first and most commonly you will see the microaneurysms and blot hemorrhages. We call it that the diabetic retinopathy can be two types, the background and the proliferative. So this is what is called the background retinopathy. And then they can be retinal ischemia and infarcts, and they can cause the patient to have these soft exudates. And then neovascularization from retina onwards towards the vitreous, neovascularization can happen, and that will require photocoagulation sometimes, although I'm not supposed to be telling you the treatment. And this is what is known as the proliferative retinopathy. Now, this background and proliferative retinopathy, remember one thing, that background retinopathy is 80% of retinopathy, and proliferative retinopathy is 20% of the retinopathy. I'm not saying retinopathy will happen to everybody. I'm saying that retinopathy, if at all it happens, it is proliferative in 20% and background in 80%. And remember, no delivery, no normal delivery in proliferative retinopathy. Yes, because there is increase in intraocular pressure. Very important. Intraocular pressure, when the mother is straining in labor, that increase in the intraocular pressure when there is neovascularization can theoretically cause hemorrhage and maybe a detachment. So that's why we say that if it is a proliferative retinopathy, do not deliver normally. We'll have to do a cesarean section. Background retinopathy, 80% of the retinopathy, we can do a normal delivery. Neonatal problems, hypoglycemia, hypocalcemia, hypomagnesemia, polycythemia can happen because of high sugars, and that can lead on to hyperbilirubinemia. And please, we are talking about the anomalies later, but remember, neonatal problems can be respiratory distress syndrome, cardiomyopathies, and that newborn later in life can have type 1 diabetes 3 to 5% and type 2 diabetes 40%. Because of the mother being a diabetic, there can be inheritance of the diabetes. So that is the percentages. All right. So excuse me, anomalies. Now this is what is very important. anomalies which can be seen in a newborn are because of the overt diabetes. So what are the diabetes? What are the problems of a newborn because of overt diabetes? Remember, they are not seen in GDM. Once again, I am telling you, most common group of anomalies are the cardiac group of anomalies. Most common group are the cardiac group of anomalies. And then in that, the most common are the transmission of great arteries. Now, structural defects, you will see something called the sacral agenesis. Look, why I'm not telling you the other defects first. I'm just telling you two specific defects: transmission of great arteries and sacral agenesis. Both of these are specific defects. Both of these are specific defects. So what is the meaning of these specific defects? Suppose a baby is born with anencephaly. Mother could be a diabetic, correct? But the mother could be having phenytoin ingestion. She could be having rubella. She could be having so many other things. So if the baby is anencephalic, there can be so many reasons, including diabetes. But if the baby has transmission of great arteries, then the mother is definitely a diabetic. It is a specific defect. Similarly, if the baby is having sacral agenesis, we also call it the caudal regression syndrome, then the mother is definitely having diabetes. So these are both specific defects. What came in your INICET exam? Which one of this is the more common specific defect? So this is specific and this is specific, and this is the more common specific defect. Yes, transmission of great arteries is the more common specific defect. Okay, the other defects which you can see in the cardiac problems are the ventricular septal defect, patent ductus arteriosus. Then you can see the neural tube defects, you can see the abdominal wall defects like the gastroschisis and the omphalocele. You can see the facial clefts. There's so many defects. I'm just giving you the classification. They can be swallowing defects like the esophageal atresia and the duodenal atresia. So I'm just giving you a classification like swallowing defects, facial clefts, abdominal wall defects, neural tube defects. But the specific defect are sacral agenesis and transmission of great arteries. They can be cataract in the newborn also. Right. So management of any diabetes in pregnancy is to reduce the diet. So normal pregnant mothers, we give 35 to 40 kilocalories. In a diabetic mother, if the sugars are controlled, then we can give 25 to 30 kilocalories. If there are uncontrolled sugars, then we have to go down to 20 kilocalories per kg per day. So first is the medical nutrition therapy. You're going to reduce the diet, but not the nutrition. You have to keep the split going. Yes, 50% carbohydrates, 30% proteins, 20% fats. That split keeps going. But you reduce the calories, total calories, by fat, by the protein, and by the fats, by the carbohydrates. All of this will be reduced to these parameters. Then monitor sugars. Best is to do a profile. What is a profile of sugars? The profile means throughout the day you have to check the values. So profile method, you will see the fasting levels, 2 hours post breakfast, 2 hours post lunch, and 2 hours post dinner. And the target value, the fasting should always be less than 95 and postprandial should always be less than 120. I told you in the lecture that we keep it less than 100, and my endocrinologist friend is not very happy because of that. He says, no, you must keep it less than 95. And if it is around 96, 97, he is almost threatening to start insulin for the lady. More than 100 fasting, then we are not happy at all. So fasting should be less than 95, postprandial should be less than 120. These are the target values we have to keep. So admit the patient, get the sugar profile going. If the sugar profile is not good, after the diet, you start insulin. Once it is controlled, she goes home. And then we can do, after the control, she can go home, and then we can do the sugar profile on a daily basis from home itself. So once a weekly sugar profile is done for a follow-up. And surveillance again, the daily fetal movement count, the non-stress test, the biophysical profile, the Doppler, Sudha was asking me about the tests. I'm just naming the tests now. We'll discuss them a little while later. Steroids for lung maturity. You know, sometimes in diabetes, if the sugars are not too well controlled, we may have to deliver the baby a little earlier than term. So by around 30-32 weeks, we give the steroids so that whichever time the baby comes out with diabetes, if there's a preterm labor also for that matter, the baby will be mature. So that's why I give steroids for lung maturity. Drug of choice is insulin, and usually around 0.7 to 1 unit per kg per day. It is generally a split of 2/3 in the morning dose before breakfast, and 1/3 of that is given in the evening dose before dinner. Generally that is there. Of course, we keep titrating with the sugars which we see the values. And then oral hypoglycemic agents which we can give nowadays are the metformin. That is what is approved. It is approved. And then the glyburide. These are the approved 2 oral hypoglycemic agents. Glyburide is basically the glibenclamide in India. India and UK we call it glibenclamide. USA people call it glyburide. Same, it is synonymous. Glyburide is same as glibenclamide. Alright, so these are approved, but most people are not still using it because there is some hepatotoxicity which is still seen with them. So they're not very happy giving these drugs. It is approved, yes, but the drug of choice is insulin. Timing of delivery, gestation diabetes mellitus, if it is well controlled, deliver by around 39-40 weeks. GDM is different from diabetes. I told you over diabetes will have worse prognosis. So if it is gestation diabetes mellitus, control on diet, 39 to 40 weeks. We can go as up as 40 weeks also, GDM on diet. But GDM on drugs, GDM on tablets, then you have to deliver by 38-39 weeks. Don't wait too much. Generally by 38 weeks we deliver. But diabetes, over diabetes, which is controlled on insulin, definitely 37 weeks will deliver. But if it is not controlled with drugs also, then you deliver at 34 weeks. Moment the lung is mature. Lung maturity is 34 weeks. Moment the lung is mature, you will deliver. So yes, so when we're talking about contraception, guys, temporary or permanent methods to prevent a pregnancy, that is what is contraception. Now, what are the temporary methods? The ones which will be used for the time being, and we can move on. So those are the natural methods. Natural methods like, you know, the coitus interruptus, and abstinence is a method of contraception, and then trying to avoid intercourse around the time of ovulation, and have intercourse you know, before that fertile period, you know, around the time of ovulation, 11th to the 16th day, all of you know, is the fertile period. So have sex before the 11th day or after the 16th day, like we say the calendar method or the rhythm method. So those are the methods, the natural methods. Barrier methods, you know, are the male condoms and the female condoms. Then IUCDs like the copper devices or the levonorgestrel devices, hormonal contraception like the oral and the injectable. So these are the temporary methods of contraception, and then we have the permanent methods of contraception. Now when we have the permanent method of contraception, we have tubectomies and vasectomies, male and female sterilization. So how do we, you know, just get into some basics before we get into the individual topics? Look, wherever you are and whatever you're doing, guys, the transmission is going fine and I don't think anything is wrong today. So what I want you guys to do is, please concentrate, because today the main topic of the evening is the hormonal contraception and especially the combined oral contraceptive pills. So we'll understand that properly. So for that, I want your undivided attention, because I'll do a little bit revision of the menstrual cycle and then get into this. So I don't want you guys to miss out on anything about that. So please concentrate wherever you are, whatever you're doing, and please do not get into distractions in the house or wherever, whichever library you're sitting. So what is the failure rate of a contraceptive method? The failure rate of a contraceptive method is calculated by the number of accidental pregnancies into 1200, that is months in 100 years, over the number of women in study. That means the number of women who used the method of contraception, and multiplied by total number of exposure. So that is the Pearl index. So if you see the Pearl index of some common methods, so this is the Pearl index or the failure rate, right? This is the Pearl index or the failure rate of the common methods. So if you see the female and the male sterilization, that female and the male sterilization, which is supposed to be permanent method of sterilization, that should be the best effectiveness. So female methods are 0.5% failure chance, and the male methods are even better, 0.1% failure chance actually. But if you look at the top one, the implants are 0.05%. So actually, if you look at the implants, the progesterone implants, like all those Novels, the Jadel, or the implants with the Jadel implant which is used, or the Implanon implant which is used, all these implants are even better effective, and the levonorgestrel IUCDs, these are also very good, but the progesterone implants have the best effectiveness. That's why we say, don't say female and male sterilization are the best. Even better are the implants. The hormonal implants are even better. But why are we not giving that to everybody who want contraception? Because if you give hormonal implants, they will give contraception, but the endometrial lining will get atrophied because of the continuous amount of progesterones which are acting on the lining, and that will make the woman amenorrheic. She will not have periods. Most of these patients stop having periods, or they have a lot of spotting. So they are not very happy with this method. Yes, a woman who's getting regular periods and she's having a contraception, those methods are the ones which are the methods of choice. That's why we keep asking this question, that what is the best method for this condition. I'll try to do that also today itself, but let's see. So we are talking about the implants, they are the best, and the female sterilization and the male sterilization 0.5% and 0.1% respectively, and COCP is another hotshot topic. 0.3 to 8% can be the failure, but generally we don't say 8%, that is a little exaggeration, that's the range, but generally we say it's around 0.3 to 0.7% is the failure rate with the combined pills. Okay, and what is very interesting to see is the condoms. Condom starts itself from 2% failures to 18% failure. So if a person is following all the instructions that condom should be applied only on a fully erect penis, and then once the person has a fully erect penis, after applying the condom, the reservoir should not be pushed over the glands, and the reservoir should not be checked for patency because it may cause micro tears, and then in a fully erect penis he should have intercourse with his partner, and when ejaculation happens, then immediately at the time of ejaculation, after the ejaculation, he should hold the condom at the base of the penis and withdraw, and then discard the condom after rolling it out and take a wash before coming back to his partner. This kind of instructions when sex is happening, because sex happens generally in a hurry, it's a moment of passion, all of us understand that, isn't it? So people don't follow all the instructions so well. So when they don't follow the instructions so well, there can be failures in condoms, and a lot of people wear the condom only when they are about to ejaculate. What is the meaning of that? That they're having penetrative intercourse, and when the man feels that he's about to ejaculate, he withdraws and then wears a condom, and then he ejaculates into the condom when he's having intercourse. So what happens with that? The pre-ejaculate from the penis has already gone into the partner. So that pre-ejaculate will take the sperms, and that's why condoms fail so much. So nobody follows the instructions so well. That's why the failure of condoms can be 18%, up to 18%. In fact, some books will say 14 to 20% is the failure rate of condoms. So before I go into detail in the chapter of contraception, I don't want you to say condoms for any situation. Guys, listen to me properly. I am trying to tell you very important fact here today. Ideal contraception in this situation, that situation, I'll never say condoms. Look, condoms is that one answer which you people have a tendency of answering. If I ask you what is the best method of contraception for a woman who is following up after, let's say, vesicular mole evacuation, you'll think, and then you'll say, sir, barriers. Then I'll ask you about diabetes in a woman, sir, barriers. Then I'll ask you about, let's say, epilepsy, sir, barriers. So ultimately, you're going to say barriers for everything. Then why am I teaching all the other methods? Let me just tell you contraception is equal to condom and just close the chapter. Why am I giving you a cafeteria choice? We keep saying there's a cafeteria choice of contraception. Why am I giving you that cafeteria choice? Because condoms are not the best. Very important fact, that do not think of condoms as the best or the first management anywhere in contraception. Think of condoms to prevent infections only. That is the best use of condoms. Yes, it prevents pregnancies. Yes, we know that. But we always know that the condoms are the most commonly used contraception in the whole world. Condoms are sold in millions. Yes, because sex is happening across the continents. The sexual habits have changed so much. Even in our country, people are having casual sex much more than before. So for that kind of sex, thank God there are condoms to prevent infections, but not to prevent pregnancies. Pregnancies prevention is not so guaranteed with the condoms. So yes, condoms are the favorite contraception of the world. I agree with you. That much I can give you. But for the ideal situations, never say condoms first. Think of all the choices before you say condoms. So let me tell you now itself, The only place where I'm going to teach you condoms are the best are for prevention of HIV, STDs, all right, all those conditions. Genital infection prevention, I will be telling you condoms, okay. So that's what is a very important fact I've told you in the beginning of the class, right. So let me tell you something else. What is the medical eligibility criteria by WHO? So the medical eligibility criteria means that suppose I'm telling a woman is newly married and she wants to not have children for the next 2 years. Newly married couple, we say OCPs, combined oral contraceptive pills, are the best method of contraception. Correct. You know that answer already. So, young woman, let's say 25, no hypertension, diabetes, no cardiovascular diseases, no deep venous thrombosis, no lipid liver, no problems are there. That woman who is perfectly healthy, can she take OCPs at 25 years for conception? Perfect. So, this is no contraindication. She is a healthy woman and she can take COCP. So, that is medical eligibility criteria 1, no restriction for use. Let's go and see medical eligibility criteria 4. Let's say a woman is having active PID. She's having a vaginal discharge, foul smelling discharge. But she happens to come to you and say, sir, I don't want to have children. I have one child. I don't want to have any more children. I heard IUCD is a very good method of conception. Can you put an IUCD? You examine her and you see that she's got a foul smelling discharge. She's got active PID. Are you going to put a IUCD inside and flare up the PID? You irritate the uterus and cause her to have sepsis actually if you put an IUCD that time. Will you put an IUCD? No, sir. This is contraindicated in active PID. So that is MEC4. Absolute contraindication to put IUCD when the woman is having an active PID. So unacceptable. So not to give MEC4, can be given MEC1. In between is the MEC2 and MEC3. What is MEC2? That there is benefit of this method more than the risk. So the advantage outweigh the risk. That's the basic meaning of this. I've highlighted the things. And MEC3 means the risk outweigh the advantages. So it's better avoided. So they'll keep asking. I mean, it's a very big chapter of contraception. People who are reading contraception, there are 2-3 famous books which are quite thick, and it's a whole subject to be read, contraception. And every method in common situations, is it MEC1, MEC3, MEC4, like that, they can be asking, but mostly they'll ask you about the regular things which are coming in the exams. So we are discussing just that today. So MEC1 to MEC4 are the eligibility criteria. So if they ask you what is the medical eligibility criteria of OCPs for a newly married woman, it is MEC1, that kind of thing. Okay, chalo. With this basics, now let's get into the natural methods and then we'll get into the hormonal methods. So I hope all of you get into the mood and stop the distractions, because next is hormonal conception and I'll be trying to make sure that you understand the basics. So just after this, no more distractions, right guys? So natural methods are coitus interruptus, that when the person is having intercourse, when he's about to ejaculate, he witdraws the penis and he ejaculates outside the body of the lady. So that is what is coitus interruptus. What is rhythm method or the calendar method? That 11th day to the 16th day of the cycle, you don't have sex. Okay, this is banned. Sex is banned on this day, before this day, and after these days she can have sex. So that is known as the fertile period method, or also known as the safe period method. This is fertile period, after this and before this is safe period, and it is also known as the calendar method or the rhythm method. All right, fine. Then the cervical mucus method or the Billings method. When the cervical mucus is thin and watery, the sperms will go inside easily. All right, all of this has been discussed in the menstrual physiology chapter very nicely, but I'm just quickly revising also. So when there is a cervical mucus which is present in the cervix, it will allow the sperms to go inside nicely. It is thin around the time of ovulation and it is thick after ovulation. So when the cervical mucus is thin and watery, the woman feels somewhat moist in the vagina. There is some wetness in the vagina. So those days when she is feeling subjectively moist in the vagina, those days she will not have sex. So yes, cervical mucus method or the Billings method, wet days, no sex. That is one method the woman can herself understand and follow, because she knows that the day she is having subjective wetness, the doctor has said that this is the time when she is ovulating, because around the time of ovulation and before, the estrogen is high. Estrogen makes the cervical mucus thin, and that thin mucus makes the woman realize that she is having some amount of moisture in the vagina. So those days not to have sex. Dry days she can have sex. Ovulation detection method like the urine LH kits, she can use. Urine LH kits are there, or there is this basal body, yes, basal body temperature, the rise of 0.5 degree Fahrenheit, 0.5 degree Fahrenheit after the day of ovulation. That is also suggested that she's ovulated. So some home ovulation detection kits are there. With that, she can find out if she's ovulating. Around the time of ovulation, she avoids sex. Then lactation amenorrhea. Yes, you know that when the woman is lactating, there is high prolactin, and this high prolactin will inhibit, that will inhibit the pituitary basically by inhibiting the GnRH. So high prolactin inhibits the GnRH, and inhibition of GnRH will reduce the FSH and the LH. Both are reduced. So when there is no FSH and no LH, there is no ovulation. Now the problem with lactation amenorrhea is it is not a very reliable method because it is based on constant increase. Yes, there should be a constant increased prolactin, but that is impossible. For constant increase in the prolactin, the baby should be constantly breastfeed, something like 24 times in 24 hours. No mother in the world can breastfeed like that. So this mother will breastfeed, let's say 7-8 times during the day, and maybe when she sleeps, let's say at 10 o'clock and gets up in the morning at 6, so she slept for 8 hours or 9 hours. In the sleep, she may breastfeed the child once more if the baby cries in the night. So she is breastfed only 8-9 times or 10 times in a day. It is still much lesser than what is required to keep the prolactin constantly high. To understand this, guys, the continuous suckling on the breast by the child will increase the prolactin, and that prolactin inhibits the GnRH and stops the ovulation. But no mother can breastfeed such regularly. So there is no constant rise of prolactin after delivery. Yes, this is also an MCQ which has come in your NEET exam. There is episodic rise of prolactin when the baby breastfeeds. Episodic rise, and that episodic rise every time the baby suckles inhibits the GnRH. So continuous constant increase in the prolactin inhibits the GnRH and stops the ovulation. But that kind of breastfeeding nobody does. So that's why there can be occasional ovulation when the mother is breastfeeding also. So that's the reason. It's a somewhat long reason. Rewind and play again, guys, no problem. You must understand that lactation amenorrhea is not a foolproof method of contraception. That's why a lot of people, a lot of these women who delivered their first child, they'll come to me after 7-8 months and they'll say, sir, now I have breastfed, like you said, I must breastfeed the child exclusively for 6 months. Now it is 8 months, so I must talk to you about the other things I can give my child to eat and drink. Okay, fine, I give that advice. After that, sir, I also don't want to have another child for the next 2-3 years. So can you give me some methods of contraception? I said, why didn't you come to me? I told you to come within 6 weeks of your delivery for contraception. Why did you not come to me earlier? Sir, abhi to I was breastfeeding the child, so that is itself a protection. And anyway, I have not had periods. It's 8 months I have not had periods, so pregnancy kahan se hogi? I ask her the next question. Have you had sex in these 8 months? Oh, fairly regularly we are having sex, sir. They're continuously regularly having sex, and she's not had period for 8 months. I do the pregnancy test and comes positive for so many patients. And that's when I tell them, welcome to the antenatal clinic again. It happens so many times. Women take lactation amenorrhea to be, guarantee that she'll be not getting pregnant if she has sex. So please do not bank on lactation amenorrhea. Listen to this segment again, rewind and play again. Now, abstinence is also a method of contraception. You can advise, and if they can follow, great. Otherwise, that is the least popular method of contraception. I'm sure you can understand that. So those are the natural methods. Now let's get into the discussion of hormonal contraception and use of combined pills, progesterone-only pills. These are the hormonal contraception. And the first generation of oral contraceptive pills, where the estrogen alone pills, 50 micrograms or more was required, was given rather, 50 micrograms or more. This is that amount of estrogen which was decided it will go and suppress the FSH and the pituitary won't work and ovulation won't happen. So that's what was done. 50 to almost 75, sometimes 100 micrograms tablets were given. That is the first generation. The next generation pills were the 30 to 35 microgram, and the progestins were, progestins means artificial progesterones. They were like levonorgestrel and norgestimate. Now the third generation pills are the estradiol, which are low dose. Guys, the word of the evening, this has to enter your genome right now, 6:20 p.m. in your genome. We are giving low dose estrogens these days. There is a lot of significance to this low dose word, which I'm going to just be discussing in the next slide. Okay. So estradiol 20 to 30 microgram, and progestins are like the desogestrel and the gestodine. These are the newer progestins. These are the newer progestins. Okay. Then the fourth generation are the new third generation pills, which have they are actually called the fourth generation, but they're actually the new third generation pills. And there you have estradiol of again same 20 to 30 micrograms, but the progestins are like drospirenone. Now drospirenone is a progestin. It's a progestin which is given generally around 3 milligram dose along with the ethinyl estradiol. Plus it has got a anti-androgen action. We have discussed this in the chapter of PCOS also. And it has a anti-mineralocorticoid. It has got an anti-mineralocorticoid action also. So what is the benefit of this? You know, anti-androgen action will take care of the hirsutism in a lady. So we use this tablet a lot, this estrogen and the progestin called drospirenone. The combination available in the world is like Yasmin. Okay, it's a trade name. India, we have a Yamini kind of a tablet trade name which is there. So these tablets are good for the girls who have PCOS. So they help in the regularity of the cycle, because OCPs, you know, will make the cycles regular. And they also give the effect, added advantage of being anti-androgenic. So acne is also taken care of, hirsutism is also taken care of. So it's a wonderful new drug. Then what else? Anti-mineralocorticoid activity. So mineralocorticoids, yes, aldosterone, it's known to keep sodium and water inside the body. So anti-mineralocorticoid action means there will be some loss of fluids. What is the benefit of that? She does not have water retention. A lot of women, they say, I feel bloated, I feel some weight gain because of COCPs. I mean, weight gain ka to there are many other reasons, but they keep blaming my COCPs. So thank God for these new pills, that these new pills are actually known to help in weight reduction also, because water retention is not there. And this action, so that the water is less, they are also very good. They're very good for women who are having a lot of premenstrual syndrome. The premenstrual, very good for this one, because premenstrual syndrome is more with water retention. So this benefit, anti-mineralocorticoid action, is going to help the woman have a much better premenstrual time. So that's why these pills are the hotshot favorites. All right. So that's about the types of pills. Let me see what are you guys asking. Arya Kumar, hello. I'm Dari. Good evening for generation. All right, fine. So you're not asking me much. So let's get into the discussion of the hormones, the chapter of the evening. So when we're talking about the hormone contraception, all these pills I told you just now. So when we're talking about this, let's quickly see the basis of the menstrual physiology. And now concentrate. I see a few of you are watching this, and those who are watching this as a recording, please, this is the moment I've asked 3 times before. Concentrate now. No distractions. So hypothalamus from the mediobasal nucleus, known as the arcuate nucleus, is going to stimulate the pituitary by GnRH. It's a pulsatile release, and this pulsatile release is 1 in 60 minutes in the follicular phase and once in 90 minutes in the luteal phase. Faster in the follicular phase and longer in the luteal phase. So F for faster, L for longer. Okay, it's a pulsatile release, acts on the pituitary. Pituitary will get stimulated in the initial part of the month to make the FSH. Follicular stimulating hormone will make the follicle grow in size. Growing follicle makes estrogen. High estrogen acts on the uterus to cause the proliferation. I have written that. And then this high estrogen gives a message to the brain. Hey brain, stop sending me FSH. I have grown big enough. I'm mature enough. Please stop stimulating me anymore. So brain says, okay, fine. I'll stop the FSH. Now the follicle also gives the message to the brain. Hey brain, send me LH. I want to rupture and release the egg. Why should I send you? Why should I send you LH? How do I know that you are mature? Arey bhai, I'm sending you the required amount of estrogen. I'm sending you the required amount of estrogen, which is telling you that fine, the follicle is ready. Send me LH. So for the LH to come, there is a required amount of estrogen which gives a message to the brain. So this high estrogen gives a message to the brain to send the LH. So you must remember this, that this high estrogen is positive feedback for the LH and negative feedback for the FSH. So that LH comes out, it acts on the follicle, it ruptures the follicle, yes, to release the oocyte, and now the follicle will shrink and become the corpus luteum, which makes progesterone. And now corpus luteum makes the progesterone, which will act on the uterus to make the endometrium secretory. So yes, the endometrium becomes secretory because of the progesterones, and this high progesterone will give message to the brain, which will be reducing the LH. So I have always told you these two lines. Do not forget these two lines. The purpose of FSH acting on the ovary was to make estrogens. FSH is to make the estrogens, and the purpose of LH is to act on the ovary to rupture the follicle and make progesterones. The purpose of the LH is to make the progesterones. Outright basics of my classes. Punchline of gynecology. With this, you understand so many fundas. So those who have read before the app or have seen me somewhere otherwise, please remember these two punchlines. With this, we will be managing a lot of our gynecology. FSH for estrogen and LH for progesterone. That is the basic. All right. Now, let us see what happens when I do a quick revision. What happens when I give some tablets from outside? Okay, once more, repetition. FSH is going to act on the follicle is going to grow big, and that is going to make estrogens. That estrogen is going to act on the uterus to cause the proliferation of the endometrium. Now, the LH will increase, will act on the follicle and rupture the follicle to release the oocyte and become a corpus luteum, which is going to make progesterone. That is going to act on the uterus to cause the secretion. Quick revision, right guys? Now, suppose I give this woman a tablet of estrogen to eat. I give her one tablet of estrogen to eat. This estrogen, when it gets absorbed into her body by the gut, it goes into the circulation and it gives a message to the brain that there is estrogen. The brain gets a message, oh, there is estrogen. What's my need to send any more FSH? So this estrogen tablet which I give will give a message to the FSH. It will inhibit the FSH. There will be no follicular formation. So when there is no follicular formation, there will be no estrogen formation. So that means when there is no follicular formation, that means the woman is anovulatory. Consider it, guys. Topic ko pakad ke baitho, chhodna nahi hai. Idhar udhar nahi dekhna hai. No questions. Listen to me right now. No, I don't want any. I'm not looking at the chat. No questions. No, I don't want any questions. Listen. Very important part of the class. Pakad ke rakho topic ko. So when I'm saying the estrogen is high, it is going to give a message to the brain. It is going to suppress the FSH. And when there is no FSH, there is no ovulation. That means the woman is anovulatory. So now the woman has become anovulatory. Now, in addition to giving estrogen, I give this woman a tablet of progesterone. This progesterone tablet, when it goes into the body and gets absorbed in the circulation, this gives a message to the brain to stop the LH, because the purpose of LH is progesterone. So when I give this progesterone, it stops the LH. That means there is no corpus luteum formation. When there is no corpus luteum formation, of course, there will be no progesterone formation also, but if there was a follicle in the body, that will not rupture also, because you reduce the LH. You make sure that the woman is anovulatory. So when the woman is anovulatory, don't you think you have achieved contraception? Yes. And don't you think we can call this estrogen progesterone combination as combined oral contraceptive pill? So yes, guys, that is the basis of the COCPs. FSH for estrogen, LH for progesterone. I give this woman to eat the tablets of estrogen and progesterone from outside. The tablet of estrogen which I give stops the FSH. The tablet of progesterone which I give stops the LH. There's no FSH, LH, no gonadotropins. So gonad ovary will not work. That means there will be no follicle and there will be no pregnancy when she has intercourse. Also, when she does not ovulate, she'll not release much prostaglandins during the time of ovulation which are released. They'll be not released. So that's why the cycle will also be much less painful. Yes, the cycle will be much lesser painful. So anovulatory cycle contraception, you understood. I'm rubbing it off. But remember that the cycle will be much less painful. Dysmenorrhea will be released because anovulatory cycles are painless. Now, after understanding this part, can you just remind me what is the major source of estrogen production in the body of the woman? Any woman, the major source of estrogen production are the ovaries. The follicle on the ovary has the granulosa cells which are converting the androgens to estrogen to make the estrogens. So that estrogen is majorly made by the ovary in any woman. So what is happening in this woman who is on a combined pill? When I'm giving estrogen, the pituitary, FSH and LH, when I'm giving estrogen, FSH is not working. When I'm giving progesterone, LH is not working. So when I'm giving this COCP, it is inhibiting the pituitary, FSH and LH. When there is no FSH and LH, that means there is no follicular formation. So with this drug, the pituitary is sleeping, the ovary is sleeping. So what is the major source of estrogen in this woman now? Once again, what is the major source of estrogen in the woman? The follicle. Is the follicle working in a woman with COCP? No, sir. You've inhibited the pituitary. Pituitary is sleeping. The ovary is sleeping. So there is no follicle. So there is no estrogen production by the ovary. What is the only estrogen in this woman? My pill. My pill is the only estrogen in this woman. Yes. So that's what you have to understand. Think, guys, think properly and understand. When I give this estrogen progesterone and it is inhibited the FSH and LH from the pituitary, it is inhibited the follicular and the corpuscle formation, it is inhibited estrogen and progesterone formation. So what will stimulate the uterus to make the endometrium and periods? How will she have periods, guys? You are telling me the periods will be painless. Arey bhai, mujhe batao periods hoga kaise? How will she have periods? You have stopped the pituitary from working, you have stopped the ovary from working, there is no estrogen, there is no progesterone. How will she have periods? Yes, you have stopped the ovary from working and making estrogen progesterone, but what are you giving from outside? You're giving estrogen and progesterone from outside. So my tablet of estrogen causes proliferation, my tablet of progesterone causes the secretion, and when you stop this, she has menstruation. So she will have periods, but the periods are because of these pills. The periods are because of these pills, guys. Please understand this. It is a pill period. I often use the term artificial periods, and I'm so happy that sometimes when students join our postgraduate course, and in the rounds they will tell that, sir, you have given COCPs and you're making her have artificial periods. Yes, I'm so happy if you understand that. These are not natural periods. The periods are banked. They are based upon the pills which I'm giving. My pill is giving her the periods. So yes, this endometrial proliferation and secretion is due to the exogenous estrogen and progesterone. This exogenous estrogen progesterone is making the endometrium proliferate and secrete. And when you stop this, there is shedding. So that's why it is called the pill period or the artificial cycle. That is a term which is not there in the books. It is just something which I keep using to explain all of you. It's not a natural cycle. It's a pill period. It's an artificial cycle. Now, guys, again, what is the major source of estrogen production in the body of the woman? It is the ovary. Is the ovary working in this woman? No, sir, ovary is not working. So what is happening? My pill is suppressing the pituitary and the ovary to work. So my pill is the major source of estrogen in the woman. Wait a minute. My pill is the major source of estrogen in the woman. And that is what is giving her the periods. Right? You understand that? My pill is giving her the periods. So if my pill is giving her the periods, then I give my pill in a very smart method. If my pill is giving her the periods, I give this pill for 21 days. See what happens. I give her this pill for 21 days and I stop. By 27, 28 days, she gets periods. Wait a minute. I give the pill for 21 days, stop, she gets periods. 21, stop, periods. 21, stop, periods. 21, stop, periods. Is getting a very regular cycle, guys. Yes, this cycle is totally under my control. I am giving a estrogen progesterone which has suppressed the body's formation of estrogen progesterone. So my pill is giving her the endometrium proliferation. And when the endometrium proliferation is happening, it is because of my pill. I give for 21 days and stop. She gets periods on 28th day. So that's why the cycles are regular, because of COCPs. You guys know this so well. Even if I had not taught you this, I had just asked you, what is the method of making a woman's cycle regular? You would have said, sir, give OCPs. They are the drug of choice for irregular cycles. Correct. Now you know why do they work like that. Because the period is under my control. The period is totally under my control. That's why she's getting this regular cycles, right? So give COCPs for 21 days and then we stop. Then the withdrawal is by 28th day. That's why it is a much regular cycle. It is a much regular cycle. Wait a minute. Wait a minute. There is something more. If you understand that when I give her the tablets, that is the major source of estrogen production in the body of the woman. And when I stop the tablet, she gets a period. So I give them for 21 days and stop, she gets periods on 28th day. These are regular cycles. This much you understood? What is the dose of the estrogen which I am giving to suppress the FSH? Should I give the highest dose, a very high dose, which goes and suppresses the FSH? Or give it the least dose, which goes and suppresses the FSH? We give the least dose. We use the least dose, which is going to suppress the FSH. Yes, I'll tell you what is the benefit of that. Okay, so let's go and see. So when this FSH is not there, ovary is not working, estrogen production is not there, and when the LH is not there, corpuscle is not there, progesterone is not there, my estrogen tablet is causing the proliferation and my progesterone tablet is causing the secretion. Yes, quick revision, you understood that? Now, when I'm saying this, please tell me how much of estrogen I'm giving. I'm giving the least dose, which is going to suppress the FSH. So I'm giving ethinyl estradiol only 0.03 milligrams. All right, which is actually, sorry for the disarray, 0.3 means actually 30 micrograms, and 0.02 means 20 micrograms, and 0.01 means 10 micrograms. All right, this should have come here. I think I changed the slides and it moved away. Okay, I beg your pardon. Anyway, I am giving only 30 microgram, 0.03 milligram or 30 microgram. I am giving the least dose, which is going to suppress the FSH. So what is the net amount of estrogen in the body of the woman when I am giving her COCPs? If I am giving COCPs from outside, I am giving a tablet of estrogen progesterone from outside, COCPs, they are suppressing the pituitary and making the ovary not work. Am I using a highest dose or the least dose? I am using the least dose, which can cause the suppression. So when I am giving OCPs, that's the only estrogen source in the woman, and I am giving the least dose. So that's why the net amount of estrogen given to the woman is very low. So the net estrogen in the woman is low. Don't say if you give COCPs for 5 years, she'll have side effects of high amount of estrogens. No, man. If I'm giving her estrogens for a long time, this COCPs for a long time, let's say I'm giving her COCPs for, let's say, for 10 years. For 10 years, I'm giving her only 30 micrograms. So 10 years, she's going to have low estrogen in the body. Don't say if you give continuously COCPs, so estrogen is given for 10 years, that means high estrogen, so estrogen ka side effect ho jayega. Arey nahi yaar. Don't think that way. I'm giving a low dose. Look, you're used to eating, let's say, 4 chapatis a day, 2 for lunch and 2 for dinner. And you've been taking 4 chapatis all your, you're now intern, let's say you are around, finally an MBBS student, you are around 23 years of age. And 22, 23 years of age, you've been eating 4 chapatis daily. Now, I put you on 1 chapati a day, low dose. And I give you 1 chapati a day for 10 years. So what is happening now? You're having 1 chapati a day. Is it more or less than 4 chapatis? It is obviously lesser. So that kind of logic you have to understand here, man. I'm giving her estrogen at a very low dose for 10 years. So if I give for 10 years, for that the net amount of estrogen for the 10 years is low. Low estrogen situation when I'm giving COCPs. Please understand that. That's why you'll understand the benefits. You don't have to mug them up with a mnemonic anymore. You will understand them. Yes. When I'm giving her COCPs, the net amount of estrogen available in the body is low. So that's why we have a lot of benefits with COCPs in addition to getting the contraceptive benefits. So yes, when I give COCPs, it's a low estrogen situation of the body. Let's say I'm telling Mala N, it is the tablet which I was showing you there. So there is low estrogen, so endometrial proliferation every month will be less. That means there will be less bleeding and lesser anemia. Now, if there is proliferation less, then hyperplasia cases will be still lesser. So, there will be lesser hyperplasia and there will be lesser endometrial cancer. Now, when estrogen is lesser, it will also help in reduction of ovarian cysts and ovarian cancers. Less estrogen also means lesser colonic cancer. Hot shot, guys. Just put any number of stars and arrows and VIMP. It is coming. It came twice in the last year. I think it came, once in INICET, it came once in MCI. That yes, in the last July MCI it came. Which of the following benefits are there because of COCPs? Which cancer is reduced? Colorectal cancer is reduced. Estrogen pills will bind the secondary bile acids in the gut. So when the secondary bile acids are lesser in the gut, so that is lesser teratogenic for the gut. And also they also are known to this, estrogens are known to inhibit the cancer cell lines. When we are the colonic cancer cell lines are inhibited in vitro, if we say in vitro, when we seen, they are known to inhibit the cancer cell line proliferation of colonic cancer cells. That's why colon is lesser with COCPs. Also, the other benefits are the reduction of benign breast diseases. But this is that very important thing. We are going to come back and discuss fibroid and endometriosis later sometimes in this Furray series. So when we are talking about fibroids and endometriosis, they are classically in hyperestrogenic women. Classically, these two diseases in gynae are because of high estrogen. So both these conditions, when you read, I'll be telling you the treatment is to reduce this disease by giving COCPs. So if you give COCPs, they are going to reduce the incidence of fibroids and endometriosis. It reduces hirsutism and acne, like I told you earlier. It reduces PID because of reduction in the congestion of the pelvis, and also benefit in rheumatoid arthritis. So these are the benefits. These are the non-contraceptive benefits of low-dose combined pills. Now maybe I'll see your questions. Yes. What if not give pills, no periods? I didn't understand your question, Tanisha. You'll have to ask me better. 7 to 14 day fertile. Why low is preferred? Why not high dose? High dose, Sudha Prasmanta, will cause side effects of high estrogens. I want to reduce estrogens for all these benefits. Na? And when I can give suppression of the pituitary by low dose, why give high dose? And I get so many benefits. That's why low dose. All right. But later the body will stop making progesterone estrogen because of pills mutation. Then what? What is that? I don't know what is pills mutation, my dear Tanisha. I have not heard of that. Maybe I have to start reading better. There's nothing called that. Pills will not cause any problems like that. There's nothing like a periods because of COCP. She'll not have periods or she'll not ovulate at all. No. 95% women recover within 3 months. Most women recover within the first 84 to 85% recover within the first month. And 95% recover within 3 months of stopping the COCPs, the ovulation. So the rare problems of pill amenorrhea, that is something like 3-4 months she doesn't get periods. Post pill amenorrhea is described, but that is not common. I've yet to see more than one case. I think maybe one, and the second one maybe had some other problem of endometrial destruction. So it's a doubtful case which I saw. The post pill amenorrhea is described, but not like what you're discussing. Please know the core basics first, Tanisha. Let's not worry about the rare complications. Okay, less chance of this will come later. High increased chance of clotting factors. Yes, you are right. I'm coming to the disadvantages. Yes, we are coming to that, my friend. How common those things are, we are discussing that. I'm just telling you so far what are your doubts. So please ask me about these things. Yes. How many months normally OCPs for PCOD? Now, Sutta Prasamanta. This is that one question. Yes. Thank you for asking me this question, Sutta. Lot of people say give COCPs, the periods will be regular. Right? And if you are interns, and some of you, if you are first PG and you are watching this, you have been taught that give COCPs for 6 months, periods regular ho jayega. Arey, it will be regular only for the 6 months when you give. How will you treat PCOS with just giving COCPs? If you give COCPs, the period will be regular because you're giving an artificial cycle. PCOS का treatment OCPs नहीं है, please. OCPs are not going to treat PCOS. It is going to suppress her natural, whatever is the method of her periods, it's going to suppress a pituitary, and you're going to give artificial cycles. So as long as you give the COCP, she'll have regular cycles. Moment you stop the pills, she'll go back to irregular cycles. So whenever you're taught this, so many of you know this line. So give COCPs for 6 months and the cycles will be regular for life. Nonsense, man. It never happens that way. If it is PCOS, it will not get corrected by COCPs. COCPs will give regular cycles only as long as you give these COCPs. Now, this has to be understood. You're going to become gynecologists, man. And my students, you will understand better than what the whole world is talking. That OCPs, if you give 6 months, will cause regular cycles for the rest of her menstrual life. Nonsense. It never happens that way. It's only for the time when you give this, she'll have regular cycles. So yes, if she wants regular cycles, she better take this pill regularly as long as she wants regular cycles. That's how it is. That's how it is. Yes. So lifestyle modification will help in PCOS, but not treat PCOS. PCOS is not, there's nothing like I give this tablet and everything about PCOS is over. No, PCOS is a syndrome. See the app. It's a very interesting chapter. Okay, fine. So let's move on. So these are the benefits of the COCPs, and let's move on and see other things. What are the rare side effects? Very rare side effects. Okay, now I'm going to speak with a lot of my experience also. In addition to, I've been in gynecology. I got into my PG in 1996. Ever since, it's now 30 years, and God bless, God forbid, this is what I've been doing all my life. So please, these side effects are theoretical before I tell you also. You're worried that it's going to cause deep venous thrombosis. It is to people who are having a predisposing cause. They will have these side effects more than healthy young women. So yes, let me just tell you that the adverse effects which are very rare is adenocarcinoma of the cervix, but not the squamous cell carcinoma. Please, the CA cervix which you see in the OPD, all your final year students and the MBBS students and the interns, that is squamous cell carcinoma of the cervix. The adenocarcinoma of the cervix very rarely can happen because of COCPs. Not because, do not say COCPs cause CA cervix or the squamous cell carcinoma. They can cause adenocarcinoma rarely. What is the most common CA cervix which we see in our country? Squamous cell carcinoma. Rarely because of this, there will be adenocarcinoma. There will be more gallstones, but not gallbladder stones. Gallbladder cancer, I'm sorry. There will be more gallbladder stones, but not gallbladder cancer. There will be more hepatic adenoma, but not hepatocellular cancer. And there will be more chlamydial PIDs. Look, I told you in the previous screen that there will be lesser PID, but chlamydial PID will be more. So what is the meaning of chlamydial PID? Indolent PID, or also we call it the symptomless PID. All right, and then thromboembolism will be more, and there will be more deep venous thrombosis. Theoretical risk, all right, when they are predisposed. So yes, if there are those thrombophilia kind of patients, and if you don't know and you've given them, then maybe they will have. Not for any normal woman. I've yet to see a normal woman having these side effects. Okay, I'm teaching you this, but they are not common at all. So thromboembolism, the venous thromboembolism is because of the progesterone component of the pill, and the arterial thrombosis is because of the estrogen component of the pill. Then the usage of this pill, how do we give this pill? So usage. So in addition to having this understanding, we should know how do we start the pill. So ideally started, the pills are ideally started on first day to the 5th day of the menstrual cycle. So the girl gets her periods, suppose on 1st of Jan till 4th or 5th of Jan, anytime she can take the tablet, start the tablet. So yes, remember, it takes 7 days for the effect to establish. It takes 7 days. So when it takes 7 days for effect to establish, that is the basis of many things coming later. So suppose a woman says, I'm going to get married, and I'm going to get married on 3rd of Jan, and I'm going to be sexually active, let's say 4th of Jan onwards. So I want to start a pill. My period came on 1st of Jan. So I tell her that you take the pill, but till 7th of Jan, if you have intercourse, you must use some other method, because the effect of the pill has not yet established. But that's only for January. Next time when you take the pill, let's say for Feb, that time you're already protected. Now for that first 7 days of Feb and the first 7 days of March, first 7 days of April, you don't have to follow that protection. Only for the first time when you start the pill, this rules last. Then there is something called the quick start protocol or the random start protocol. Any time of the month when the woman comes to me, I started the pill. This is generally reserved for people who are not reliable. They're not going to come to you for follow-ups of contraception, especially our the uneducated strata of the society, the low socioeconomic status, and even the teenagers, because teenagers who are sexually active, they might be having a lot of sexual exposure, and they come to you for infection management. Even as recent as yesterday and today, we saw some teenagers in the OPD, and those people, we told them that to advise them to stop having sex, they may not follow, but at least be careful not to get pregnant and don't have infection. This is the advice you must give these youngsters who have intercourse early in life. So yes, we give them COCPs even if they're on the 10th day of the cycle or the 15th day of the cycle. Pakad mein to aayi, be patient, so that she's at least under some COCP. No sir, if you start on the 10th day, then the pill is for 21 days. That means 10 plus 21 is 31 day ho gaya, and period will come on the 38th day. Yes, for the first time it will come like that. It will come delayed, yes, because I started after 10th day of the cycle, correct? Hoga. Once only, na? Next time she'll be following the pill properly. Then she'll have regular cycles. But at least I caught her, and I'm preventing unwanted pregnancy. So that is start any time of the menstrual cycle. The advisable mainly for the low socioeconomic status and the teenagers who are not compliant. Now, very important part of the class. missed pills. If the person who is regularly taking the pills, let's say for 3 years, she missed one pill, so take 2 today. If she misses 2 pills, then also take 2 tablets today. Now, what happens if she misses 3 pills? Please don't say take 4 today. Don't say that if she misses 6 pills, she takes 7 today. There's no such law, okay? If she misses 1 tablet, she takes 2 today. She misses 2 tablets, again she takes only 2 tablets today. If she misses 3 tablets or more, oh hello, she is not taking estrogen progesterone tablet from outside, and that estrogen progesterone tablet is going to cause the suppression of the pituitary and suppress the ovulation. If you do not take the tablet, if the woman is not taking the tablet for 3 days, then the pituitary wakes up from the separation and it gives a rebound high FSH, and she may actually ovulate very early. So yes, that is the cause of the failure of the pill now. So if 3 days or more are missed, the effect is lost. That is what is very important to understand. So 1 day missed, take 2 today. 2 days missed, take 2 today, not 3. 1 or 2 day missed, take 2 today. If it is 3 and more, first remember the contraceptive effect is lost. So what do you do now? Tell her to take 1 pill, the day's pill. She's not taken for the last 3 days. She comes to me on 21st of Jan. I tell her, okay, fine, take today's 1 tablet. Now don't miss the pill. Continuously take the pill, okay? No more missing. So, okay, I will remember, sir. But remember, now the contraceptive effect is lost. So, it will take again 7 days for the effect to establish. So, for the next 7 days, use another method of contraception, because it takes 7 days for the effect to establish. But if she misses 3 or more in the 3rd week, now that is what is, if 1st week, 2nd week and the 3rd week. And then there is 7 days of ferrous sulfate. So that is how we keep the month of a patient with PCOS. This is the time when we're giving her the active principle, that is a COCP, and the last 7 days there is only ferrous sulfate tablets. Now, if she misses on the 1st week, 2nd week, follow this protocol, this one. If she misses in the last 7 days, you tell her that she's missed the pill. How many days you miss? Sir, I missed for 3 days. Okay, take 1 tablet today. Do not give a gap, because now when you're taking it in this last, suppose she's missed it here. She comes to me, let's say on the 18th day of the cycle, saying I've missed for the last 3 days. I tell you, take 1 pill today. She takes 1. Now continue the tablet. She takes it on 18th day, 19th day, 20th day and the 21st day. But she says, sir, after 21 day, I'm supposed to take a gap of 7 days, that ferrous sulfate. No, now don't take a gap, because the effect will establish only in 7 days. And then you again give a 7-day gap, again the effect will be lost. So if you miss the pill in the last 7 days, then the gap of those 7 days, that ferrous sulfate days, that is not given. Okay, so if she misses in the last 7 days, she takes 1 tablet, she continues the pack and she discards those extra iron sulfate tablets, and she continues for 21 days without a gap, so that the effect is established and there are no breaks. Okay, so take 1 pill today, next 7 days use alternative method just like this, but since it is the last 7 days, avoid 7 days break. Okay, avoid the 7 days break. All right, so let's first 7 days out of the way, then another method also along with. Yes, first 7 days, first time when you start. Yes. Mother had some problem, leg spots on the legs. Yes, those can be because of any drugs. Leg spot, what was the etiology, my dear? Fixed drug eruptions. There can be so many other drug reactions to any tablet in the world. Yes, I'm not saying OCPs are without any side effects. Even if you take crocin, it will have side effects, my dear. So, hypersensitive reactions can be there to so many things. So, if the person has taken for some time, she had some spots and then you stopped, they went away, it is an allergic manifestation. That can happen to it. I am talking about long-term use of OC pills, and if they have any side effects, they are very rare. I mean, there are no immediate hypersensitive reactions. Now, the person is having a protection. COCPs, no pregnancy is happening. Now, she's continued taking for 3, 4 years, 5 years, 10 years, and the side effects are very less. Hypersensitive reactions can happen to any tablet. Even ranitidine can cause. We take it for gastritis, like, you know, we keep popping in ranitidine because we have this gas ka problem, isn't it? And then that can also have side effects. Any drug can have a side effect. Iron sulfate can have side effects. Folic acid is known to cause side effects. Hypersensitivity alag hai yaar. Side effects of OCPs given for a long time, those are different, right? Okay, now wait, let's not get distracted. The very important part coming. Okay, don't stop. Wait. Missed one pill, take one or two. Sorry, missed one day or 2 days, take 2 tablets today. Missed for 3 days or more, I explained everything to you. What if she has missed for 3 days and she's had sex in these missed pill days? The contraceptive effect is actually lost because she's missed for 3 days and she had sex and comes to me, sir, I didn't take the pill for 3 days. There was a family function going on and I was very busy at home, so I forgot to take the pill. But they managed to have a physical relation, missed the pill, had physical relation. What happens? She is not protected and she had sex. So now, in addition to giving all of this, you have to give emergency contraception. So if 3 or more days are missed and she had intercourse on the missed pill days, then give emergency contraception also to prevent a pregnancy from happening. Okay, so emergency contraception is also given. That's extremely important part of the discussion. All right, chalo, let's move on and see contraindication to COCPs. I've given you first itself, age more than 35 years and she's a smoker. No, what happens that any woman who is, let's say around 40 years and more, we don't give COCPs because the theoretical risk of coronary artery disease will increase, and also the risk of side effects will increase more. So after 40, COCPs are generally not given for contraception. We generally avoid. But if a woman is a smoker, she's as it is increase the risk of coronary artery diseases. So we don't give smokers OCPs after 35 years. All right, excuse me. Then what are the other contraindications? Pregnancy you won't give. Breastfeeding you will not give. The estrogen component, yes, estrogens will reduce the prolactin. So breast milk formation won't happen. Also they cause mammary. There's a mammary gland involution. There's a mammary gland involution which can happen because of these estrogens. So the shrinking of the mammary glands can happen. So that's why it's avoided. So estrogens are classically not given. If at all you want to give oral pills, we give them progesterone only pills, right? Then we have the deep venous thrombosis, which can happen, pulmonary embolism. So that's why it's a contraindication. Now liver diseases will not give any estrogens because estrogens are metabolized in the liver. So that's why in liver diseases. And then hypertension, that is blood pressure more than 160/100. So MEC2 if it is 159/99 like that, and MEC4 if it is more than 160/100 like that. So there are these sub classifications are there, but roughly mild hypertensive can be given, but the hypertensive which is more than this should not be given. Mild hypertension is not a contraindication. Then right, active breast cancer we cannot give because any type of estrogens are not given in a woman who's got breast cancer because most breast cancers are estrogenic. So in a follow-up of breast cancer after treatment also COCPs are not given. Uncontrolled diabetes with nephropathy and neuropathy, uncontrolled lipids also you don't give, and ischemic heart disease with stroke, migraine with aura, these are all the contraindications. So remember, diabetics who are controlled I can give. Yes, COCPs are safe in diabetics. Controlled diabetes safe है, कोई problem नहीं. Uncontrolled diabetes, uncontrolled lipids we don't give. Okay, now what is not a contraindication is your MCQ. Not a contraindication for use are the STD, PID and HIV. This is absolutely nothing to do with the use of COCPs. Nothing. In STDs, HIV, you can go ahead and give COCPs. Right. I didn't understand this question, Sutta. So, to prevent fertility due to intercourse, how many months? I mean, you're trying to say that, huh? I mean, like, the effect established in 7 days. That's it. And you continue giving COCPs as long as she doesn't want to have children. She got married at, let's say, 25 years and she says, I don't want to have a child till I'm 32. So she can take COCPs for 7 years. You can maybe, ask me this question somewhat better. All right. Chalo. So we'll see, we have many more things to discuss. So I don't want this to become a very long class. Let's see what else we can discuss. So Saheli, yes, that is Syncroman. Somebody wrote Saheli. Tanisha, did you see my presentation? How did you guess that I'm going to teach Saheli next? I didn't run the slide early. Good. So yes, Saheli Syncroman. It is developed by the Center for Center for Drug Research Institute, that is Lucknow, and that is known as ormeloxifene. It's a selective estrogen receptor modulator. So the salt is ormeloxifene. It is Syncroman. It is sold as Saheli by in the country. It is given many places. In some setups, it is given free of charge also. So it makes the endometrium out of, but ask the PSM people, they were the best people to tell you whether it is free of charge or not. Because in my hospital, we used to give it for free of charge. I'm talking about it's not a government hospital where I work for a missionary hospital. So we used to give it free of charge for some time. Of course, now we don't give any pills because we have to have a different kind of a setup for that. So this is mostly available in the market. But whether it is free or not, that is for the PSM people to tell you. So remember, it makes the endometrium out of phase for the endometrium. Endometrium is too secretory for the embryo. So embryo comes to a very fluffy endometrium for an implantation. So it doesn't implant. So there is an embryo uterine asynchrony with the ormeloxifene or Saheli. So we generally give it for twice a week for 3 months for the effect to establish, and then we give it once a week till as long as she wants to take contraception. But the side effect is that there could be some delayed cycles. Some of my patients, most of my patients who say that they used to get periods in 28-30 days, they generally get around 35 to 40 days periods when they give ormeloxifene, but it's a very effective drug. Yes, it's a very effective drug. So what are the permanent methods? So permanent methods are the sterilization methods, like the male sterilization, the female sterilization. I thought in addition to COCPs, I'll discuss the more important methods which generally come in the exams. So I'll just get into the sterilization surgery. And remember that mostly the sterilizations are done when a woman has 2 children. Now, there is no contraindication to have a sterilization done after 1 child. There is no such contraindication. A woman has delivered a first child. She says, sir, I don't want to have any more children. I want a tubectomy. Or a man says, I want a vasectomy. Can do. Advisable. Journal. Sound advice kya hai? You have your 2 children. Okay, we can do sterilization. Well, let's wait for the younger child to become 3 years old, because neonatal mortality is still quite high in the country. Some fever happens. Let the child get to be around 3-4 years, and then you can come for a permanent method. Till then you can take IUCTs, like that we say. Permanent sound advice is after 2 children, wait for the second child to become 3 years and then do the permanent sterilization. But nobody listens to this. People come to us after the, the 4th delivery also. We tell them to get a sterilization done. They say, okay, fine, aayenge sir, 6 hafte ke baad aayenge. And then they come to us only when they're delivering again. So yes, that's a problem in our country. The biggest problem which I feel, I am not supposed to speak about social causes on this education forum, but then all you students, MBBS students and interns, you'll all become administrators. Some of you will become the head of departments and the directors of the institute, and you'll also become maybe into political posts, maybe the Director General of Health Services one day. You are the youngsters who are going to, so I feel that I'm doing my bit to push the 1 child norm in the levels where I'm working. You're happy to have 2, you can have 6 or 7 children also. But my country, I feel, now we should reduce the population, so that once we reduce the population, the resources are shared by limited number of people. And the sheer number of us is becoming a problem ever since independence. So if we are taking this seriously, it'll be great, right? So I want you guys to push reduction in size of the family. Okay, let's not get very political. I don't want to get into any more serious discussion about that. Okay, so all of us should take care of that. So permanent methods should be used with 2 children or afterwards. That's a sound advice, but not a guideline. Okay, it's a sound advice. So let us talk about female sterilization first. And when we talk about female sterilization, yes, Jessica, I'm so happy what you wrote. Very good. So female sterilization is where we do a tubectomy, which is tubal ligation or tubectomy. Look, I want you to understand the terms. Tubectomy means we just cut a segment of the tube like this. Salpingectomy means we cut the whole tube. So we are not cutting the whole tube, okay? We are cutting only the segment of the tube which we want to cut, so that we keep a window open for a reanastomosis later in life. Yes, that's what is the reason. We cut only a segment. Look, there is a woman who has, let's say, 3 children. And she says, sir, enough, I don't want to have any more children. My husband is not happy using condoms, and I will not remember taking any tablets. So, sir, why don't you just do a tubectomy? Ye kaat do, nas kaat do, like that they'll see in Hindi. I'll say, okay, fine, we'll cut your tube. But I cut the tube in a way that later, if she suddenly decides to have more children, so I can reanastomose. So I cut it only very small segment, and I cut it in a place where the reanastomosis is common, because suppose she lose the children unfortunately for whatever accident in life, or the woman has a divorce and the husband gets the custody of the children. She wants to have more children then. So we have done so many reanastomoses. It's a common surgery done in gynecology departments. So yes, tubectomy is just cutting the segment. Salpingectomy is cutting the whole tube. So for sterilization, we don't do salpingectomy. The only place where you guys have to know salpingectomy, total cutting of the tube, is rupture of an ectopic pregnancy. So please see the difference. So we are going to do a tubectomy, tubal ligation. So site of ligation is the isthmus. It is the isthmus. When we do the isthmic sterilization, okay, it's already written here. It is because it is of uniform diameter. So let me draw that to you so that you can understand. Uterus, vagina, and the fallopian tube. So this is the ampulla and this is the isthmus. So I will cut the tube at the level of the isthmus. When I cut the tube at the level of the isthmus, how is it useful? So when I cut the tube, suppose here, so the two cut ends are like this. They are of uniform diameter. So when the two cut ends are of uniform diameter like this, then for me to do a reanastomosis later in life for her, if I do the sterilization and the reanastomosis has to be done by somebody else, suppose, that reanastomosis is much more easier at the site of the isthmus, because the cut ends are uniform. Suppose somebody cuts at the isthmo-ampullary junction, suppose it is cut here. So then the isthmus is like this and the ampulla is like this. So the reanastomosis is not very uniform. So that's why we say always do a isthmic sterilization. All right, uniform diameter. So isthmic reanastomosis is more successful. So it is up to 80% success if it is done at the isthmus. Okay. Oh God, that is also written. Never mind. So what is the timing? Yes. What are you asking me? You're not asking me anything. The timing, but just watching because studying medicine gave me happiness and satisfaction. Tanisha. All right, Tanisha. Welcome. Welcome. Okay, please tell more people who should be looking at these kind of lectures. I'm not trying to make it very tough. Yes, this is a medical lecture, but if you listen to us, you're most welcome. All right, and the others who are seeing it as a recording, you're more welcome. So timing of a tubectomy, when all we can do a tubectomy. So the most common time of doing a tubectomy in my country is the postpartum sterilization. Now, postpartum ligation or postpartum sterilization. See, when the woman delivers the uterus, look here, in pregnancy, pubic symphysis, normal uterus is say this size, and in pregnancy, the uterus is something like this. In fact, the flanks are full. See, these flanks get full. So that's the uterus inside the mother's abdomen. Now, what happens after delivery? So, after delivery, the uterus is just below the level of the umbilicus. The baby goes out and the uterus is just below the level of the umbilicus here. So, if it is just below the level of the umbilicus, let's say I'll try to show you. Okay, see here, it's like this. I'm trying to show you through my shirt. I've put my pen and showing you. So, you can put a hand on the mother's tummy like this and you can feel the uterus. Yes, you can feel the uterus here. So, what happens when you feel the uterus after delivery? It's just delivered yesterday, and today you go through rounds and you can feel it. So, if you can feel the uterus so easily in the abdomen, you can make a small cut here and go and take this side and this side tubes and do a very easy ligation of the tube, because uterus is an abdominal organ after delivery. So that's why We always keep asking you this question in your exams. Any exam you write, whether you're writing the final MBBS exam or you're writing your entrance exam, where is the uterus immediately after delivery? Immediately after delivery, it is just below the level of the umbilicus here. So we can make a small incision, mini laparotomy we call it, small incision, and we can cut this tube and we can cut this tube with the same incision. So that is why we will do more postpartum sterilization in our country than any other sterilization, because women come to the government hospitals for a free delivery. In fact, most of the women who deliver in the hospital, we give them some money. In spite of, in addition to free treatment, we give them some money. If a girl child is born, we give them more money. Isn't it? The government is very magnanimous and trying to help women deliver in the hospital so that they don't deliver in the villages and have PPH and die, or come to us very sick when much more resources are required to take care of a woman who have PPH and she's close to dying and she's in the ICU. Much more resources are required than her to deliver in the hospital, and we give her 5,000 rupees or 10,000 rupees after delivery if she's delivered a girl child. So, government is coming out with a lot of proactive schemes so that all mothers deliver in the hospital. That's why, when I was intern, when I was working, when I MBBS in MD from, yes, my MBBS in Japan, I'm telling you, 1994-95, when I was doing my internship, that time the maternal mortality rate was around 556. Then when I was doing my post-graduation, it came down to something like 330. Till last 2 years back, it was 97, came back to 93. Now it is 88. So yes, we are pushing women to deliver in the hospitals. So when they deliver in the hospitals, the chance of them having severe complication is lesser. So when they deliver in the hospital, the next advantage is that I can go for the rounds and I can see her uterus is felt and ask her, which delivery was this? She said, it is my third child. Okay, so how about I do a tubectomy for you? Dr. Saab, I don't want to come back after going home because I have got 2 more children. I have a lot of work. All right, we can do it today itself. It's a small incision under local anesthesia I'll do, and you'll not even see the cut after a few days. And it's a very easy time because the uterus is not inside deep into the pelvis. It is high in the abdomen. I can do a very easy tubectomy. I convince her, and then we give them some money, 500 to 600 rupees. I think the PSM people say now it has become 600 for the women who get sterilization, and it's around 1300 for the men. 1100 for the men who gets the vasectomy, 200 for the motivator who brings the man for a vasectomy. So we give them some money more. More money is given so that they get a tubectomy done. So uterus is just below the level of the umbilicus. Postpartum sterilization is the most common time. All these questions which I discussed are coming in the vivas. All right. Finally, yes, be careful. Huh? Then uterus is abdominal organ, and at this time, hence it's an easy surgery. Now the next question is, how long can you do this? I'm removing it now. How long can you do this? Only as long the uterus is the abdominal organ. So how long can you do? How long can you do a postpartum sterilization or a puerperal sterilization? As long as the uterus is in the abdomen. So how long is the uterus an abdominal organ? Only for 2 weeks, because in 2 weeks it becomes a pelvic organ. Don't say 6 weeks. We keep answering wrong this answer. So it becomes a pelvic organ in 2 weeks. So that's why around 7 to 10 days only we can do postpartum sterilization. Mostly we do today she's delivered, tomorrow morning or day after we do the postpartum sterilization. We can do maximum for around 2 weeks. Basically it is 7 to 10 days, but we say roughly 2 weeks. Why? Because in 2 weeks it becomes a pelvic organ. When does it become a normal organ? It becomes a normal organ in 6 weeks. 4 to 6 weeks it becomes a normal organ. All right. So yes, I think these colors you're not able to see too well. I'll go back to black. So we can do this only for up to 7 to 10 days. So best done within the first 2-3 days of delivery, maximum up to 7 to 10 days. Why? Because in 2 weeks it becomes a pelvic organ. So both the questions come in your vivas. When does the uterus become a pelvic organ? 2 weeks. So how long can you do puerperal sterilization? Maximum 2 weeks. Okay, or 7 to 10 days as written here. Then what is the other method? I told you sterilization. Just now I told you which method? Postpartum sterilization, also called the puerperal. I'm telling you the timing of sterilization. Then we can also have interval sterilization, which is done after the 6 weeks of delivery, after the puerperium. It is commonly done by laparoscopy because it's a pelvic organ. It's deep into the pelvis. So we can approach only by this uterus can be approached only by a laparoscope. So it is done after 6 weeks of delivery, and it is commonly done by laparoscopy. Now, concurrent sterilization, this is done along with MTPs or a cesarean section, or even some other, let's say somebody is getting an appendicectomy done She says, sir, I have 2 children, now I have this pain abdomen, you're doing a laparoscopic appendectomy. She'll tell the surgeon friend to call the gynecologist. Along with that, we do a tubectomy also. So concurrent means along with any surgery. Mostly it is along with an MTP or a cesarean section, concurrent. So these are the 3 types of sterilization surgeries. One is puerperal, one is interval, and the other one is concurrent. Now, entry into the abdomen can be by laparoscopy or a laparotomy. In our country, laparoscopy has increased substantially. There are camps of laparoscopy across the country where surgeons will go, laparoscopic surgeons, gynecologists will go, or trained doctors who are MBBS, but they are with the they are the SMOs who are working for the government, and they go and do. So they are trained doctors who go and do these laparoscopic camps, but still the most common time women get the tubectomy done is postpartum. So laparotomy is still the major method in our country, and laparoscopy is increasing much higher, but still laparotomy is the more common method. So mini laparotomy, we say, we don't say cutting the whole abdomen, we make a small incision like I told you. So it is a mini lap surgery, 1.5 to 2 inch incision. So this is what they'll ask you, write a short note on mini lap, or they'll ask you in the viva, what is a mini lap? Mini laparotomy, 1.5 to 2 inch incision. With that, you get into the abdomen, take out the tube, and after checking that you're cutting the tube, how do you check? You see the femoral end. You pull out the tube, check the femoral end, do the ligation, push it back inside with a mini lap. Laparoscopy also is a method of entry, but laparoscopy is not done in the puerperium because there's a high chance of failure because the tube is edematous. So we generally put a ring on the tube. When you put a ring on the tube, that ring on the tube will slip out because of the edema of the tube. All right, so that's why the laparoscopy procedures are not done for puerperal methods. Also, there's a high chance of injury. Right. So what are the techniques of tubectomy? Tubectomy techniques, the most common technique done even now in the country is the Pomeroy's, but you have to know it is called the modified Pomeroy's. Nobody does the original Pomeroy's. Like there was this question about Shirotkar's circlage. So it is not called Shirotkar anymore. It is called the modified Shirotkar. The great Dr. Shirotkar did a procedure, but the modification was found to have lesser infections. So most people do the modification. So it is called the modified Shirotkar now. So we'll never ask you in the exam difference between Shirotkar and modified Shirotkar. Not at least in a MCI exam, PG entrance exam, or the the exam which you're writing, the final year MBBS exam. We'll definitely not ask you there. So you have to know modified Pomeroy is the most common method in the country. So single ligate is used and both the ends are cut. So you see we use this forceps, Babcock forceps, to pick the tube and make a loop like this, and then we tie the tubes together and then we cut them. So what happens? These tubes are cut and they are tied together. Can you see this? They are tied together, and when the sutures dissolve, they'll get separated. But what is the problem? That they are together for a few days. So when they are together, there can be a theoretical spontaneous recanalization. That's why this modified Pomeroy's, it's not my favorite method. A lot of people also don't do this because of this theoretical chance. So the cut ends are together can lead to fistula formation leading to failure. Theoretical chance, okay? So let's not say that it's a bad thing to do Pomeroy's, but it has a theoretical risk of a spontaneous recanalization. Then what is a Parkland technique? That's my favorite technique. Why? Because what I do in that, when you make a loop of the tube, you cut both the tube and you tie them separately. They are not together. From the day of surgery, they are separate. See, Pomeroy's, they were tied together on the day of surgery itself. So there was a chance of recanalization. In Parkland, they are separate from the day of surgery. All right. So tubes are ligated separately in this one. Postpartum ligation can give permanent sterility. Obviously, yes, definitely. Permanent sterilization to karna hai. Method is permanent is Suta. The method is permanent, so it is for permanent sterilization. Yes, you can do a reanasmosis if she so desires, but that has to be done surgically. It is a reanasmosis, a major surgery. So till that is done, she will not conceive. Failure of a tubectomy, that is a side effect of any procedure. Like anything you do in surgery, there can be failure. The purpose is to give permanent sterilization, Sutta. Don't get confused. So that is the Parklands. Pomeroy's and Parkland are the two techniques which are coming in your exam generally. But in MCQ exams, the other techniques also have to be known. I'll just tell you a few other techniques. I'm not telling you all of them. All right. So Irving's procedure is, that show-off procedure when you want to tell your PGs that you can do something very nice, So what we do is we cut the tube and one end is buried you know, the one end of the tube is buried into the musculature, uterine musculature, another end is buried into the mesosalpinx. So see here, the tube is cut, one end has been buried into the uterine muscle, the other end goes into the, there is a mesosalpinx, you know, basically the top end of the broad ligament. The mesentery of the tube is known as the mesosalpinx. So we bury it into the mesosalpinx. So in addition to cutting the tube, we bury it also. There's another method called the Uchida's method, subserosal dissection. It's all right. It's that under the serosa we do the dissection so that the top of the tube looks continuous, but inside it is cut. That is Uchida's. They are not asking you all those vague names, but Irving's comes as a choice. Then Madeliner's method and another method is the Kronos method. There are two methods which are taught to you only to condemn. Don't do these two methods. So what are those two methods which are not to be done? One is Madeliner's method. What is happening in the Madeliner's method? You're just crushing the tube. You're not cutting it. See, tubes are only crushed, not resected. So if you just crush them, there's a high chance of failure. So that's why Madeliner's is not done. This is not to be done. We don't do because high chance of failure, high failure rates. Then what is the Kronos? Kronos is the fimbrectomy. This is a favorite PG entrance question. What is the name of the fimbrectomy surgery? Just the name they'll ask. Why? Because you're cutting off the fimbria. See, the fimbria is gone. You throw the fimbria off. So even if she comes for a reanastomosis later, there's nothing to hold the egg later on. There's no fimbria. So you'll have to do a neofimbriostomy, which is a 5% success kind of a thing. That's why Kronos fimbrectomy is also not done. So these are the methods of tubectomy which I thought to tell you. We can also do laparoscopic rings and laparoscopic clips. So let's see, if it is not there, then I'll tell you otherwise. So steps to avoid ligating other structures. Yes. So when we're doing a tubectomy and you made an incision and you're taking out the fallopian tube, so sometimes you can actually pull out the round ligament and ligate it. You can pull out the bowel also. So how do you make sure you're ligating only the tube? So when you pull out the tube, you pull it out so much so that the fimbria also comes out of the abdomen. When the fimbria comes out, that structure has to be ligated. That's the best way to make out. Again, question. All you finally MBBS students, these are the questions they'll ask you in tubectomy. How do you make sure that you're cutting only the tube? You pull out the tube. You can, whichever tubal organ you are going to ligate, you try to pull it out completely. So only the tube can come out completely. If it is a round ligament, it will never come out completely because it is going into the inguinal canal and going to the labia majora in front. The round ligament will not come out. It will come out only minimal. You will not be able to see any end of the round ligament because it cannot come out. You will tear it, but it will not come out. Similarly, if you pull out the bowel will keep coming out. It will not stop coming out. So whatever structure you are ligating, try to pull it out so that you can see the femoral end. Once you see the femoral end, then you ligate. Okay, so the method by which you pull it out is by the Babcock's forceps. Babcock's forceps. That is the atraumatic forceps, and that is what instrument test will come. You know, the tip of this forceps is blunt so that when you pull the tube, it will not tear and it will not get crushed and not bleed. Babcock is also a favorite instrument of the surgeons for handling bowel because it is atraumatic. Okay, structures ligated by mistake when you're doing a tubectomy. What are the structures you can ligate by mistake? You can ligate the round ligament, which is the most commonly wrong ligated structure. You can ligate the small bowel. You can ligate the ovarian ligament. Appendix has been ligated a few times, many times actually, but some of the time we'll tell you those stories informally, all right, not on a formal forum like this. But yes, ureter, can that be ligated or has it been ligated while doing a tubectomy? Watch it, guys. This is the favorite. MBBS students, watch it. This is the favorite question your examiner is going to ask you. When you're telling about tubectomy, they'll say, okay, what are the structures you can ligate by mistake? They'll try to make you do this mistake. You'll say, sir, while doing a tubectomy, I can ligate the round ligament. Okay, okay, और क्या है? Sir, bowel ovarian ligament you can ligate by mistake. नहीं और भी कुछ है, एक और ट्यूबल स्ट्रक्चर है, जो नीचे से जाता है और वो ट्यूबल स्ट्रक्चर जो पीछे से आगे जाता है, that you can ligate by mistake, you know, and you'll say, sir, ureter. And then they'll fire you. How can you ligate the ureter? Arey bhai, you cannot ligate the ureter. Why you cannot ligate the ureter? Because ureter is not in the abdomen. Ureter is behind the abdomen. It is a retroperitoneal structure. So they will ask you this. They'll try to elicit this mistake out of you. And when they say ureter, they'll start firing you because you don't know your anatomy well. So that is a favorite Viva question. Can you ligate the ureter? Please Never say. In fact, it happened with one of my, I remember long back when I was in my MBBS, they asked me in a table viva. It was not the final exam. It was, we used to have a send-up exam pre-final. And my professor asked me, so he kept giving me that hint. Can you like it that one tubal structure is there, one tubal structure going from the side coming in? I said, sir, I will not like it the ureter. And he started smiling because he knew that somebody who had given the exam had already told me before. So yes, I said, sir, I will not ligate the ureter. So please do not say that you ligate the ureter. Also, don't say that you ligate the uterine artery. Uterine artery is not freely hanging, okay? Uterine artery is next to the uterus and you have to dissect out the round ligament, uterine artery from the leaves of the broad ligament. You cannot ligate the uterine artery also. So don't say artery, don't say ureter. What you can easily say and pass exam, round ligament and small bowel. These are the commonly ligated wrong structures. So enough about these wrong ligated structures. Let's move on and see some other things. Why it's not? Yeah. So ureter cannot be ligated even by mistake because they are retroperitoneal structures. Yes, just completion of the notes. And uterine artery also cannot be ligated. I told you these two. Please, those of you are seeing late, please remember this cannot be ligated. All right. Chalo. So failure of rate of tubectomy is more than vasectomy. That's why vasectomy is the more preferred method when we do permanent installation. Tubectomy, as you know, a lot of women have died in tubectomy in our country. Yes, unfortunate truth, but it has happened. Vasectomy, I have not heard. Yes, side effects to any injections like lignocaine given for a local block can cause anaphylactic reaction and the patient can go into a shock and the hypersensitive reaction and can die. But I have not seen that happening. In touch wood, I don't want to see that in my life. We have done quite a few vasectomies in our life, but tubectomies, a lot of people have lost their lives also. So yes, it's a much safer surgery to do a vasectomy. So failure rate is less than tubectomies, and non-scalpel vasectomy can be done. We stabilize the vas with the ring forceps, pull out, and a sharp artery forceps is used to dissect it. I'll show you the instrument. It's easier for the understanding. A T bandage is tied. Surgeons will teach you how to put a T bandage for the scrotal support and avoid lifting heavy weights for 5 days, we say, because there is some congestion in the scrotum because of this surgery. So yes, this is the instrument. So there is a sharp dissecting forceps. Yes, that's what I want to tell you. A sharp dissecting forceps. This sharp dissecting forceps, can you see the tip of this one? This is by, this is of course which commercially available kits. So in this, you use this sharp instrument to make a stab wound in the scrotum. So we first obviously give the local anesthesia, and at the base of the scrotum somewhere here we make the incision. With that one incision, just one stab incision, because if you tell a man that I'm going to make a cut in the scrotum and go and ligate your vas, and men are very sensitive about their privates, and they don't want any surgery to be happening. Okay, any small knock on the testis also is very painful. So what happens that men are not very happy getting the surgery done. So we tell them, okay, see, I'm not doing any cut. I'm just giving you local anesthesia. Under anesthesia, I'll just make a small incision, and that is not even going to be seen after the surgery is over. So that's how men get convinced, and we give them more money than we give it to women. Okay, the money given by the government is much higher. In fact, if a layman, a man who just walks in and says, I want a vasectomy, we give them 1100. The motivator, we give 200 rupees more. But the government servants, if they come, suppose there's a, I think I'm correct, PSM people again, if they are listening, they can correct me if I'm wrong. But there is a one increment in the salary given by the government. That if suppose there's a lower division clerk who comes to me after having 2 children, he comes to me and says, sir, I want a vasectomy. So if I do a vasectomy this month, he gets the senior division clerk, the higher salary for 1 month, one incentive. Like if a major gets it done, he gets a colonel salary like that, or a lower soldier, a soldier gets it, he gets a Nike's salary for a month. That one increment is given. So government servants will generally get this done easily. So you make a small incision with this, a stab wound, you make a small incision, open, go and hold this vas, take out, go and hold this vas and take out. So how do you stabilize it? You stabilize it with a ring forceps. The ring forceps is used to stabilize the vas, and then we ligate the vas. And when you do the ligation, I'll come to your questions. I've gone into vasectomy. I'll come to your questions. So when you're doing this ligation of the vas, suppose you do the ligation of the vas somewhere here. You've done the vasectomy here. So the part which is distilled, see this part. This part will have sperms. Yes, this part will have sperms for almost 3 months. Some sperms will be there for almost 3 months distal to the ligature. So that's why we tell them that even after I do a vasectomy, you're not sterile immediately. You will take 3 months to get sterile. So for the next 3 months, you must take some alternative method of contraception. So post vasectomy, use alternative method for contraception, and that is for 3 months. For 3 months or 20 ejaculates. It takes 3 months for this part distal to it to get emptied, or it takes 20 ejaculates for this part to get emptied. Look, your PSM book says 30 ejaculates, but my Williams Obstetrics says 20 ejaculates. So I will have to quote Williams Obstetrics because that's the book of reference. And if they're asking you in your final MBBS exam, so whichever exam you're writing, please ask your PSM people what they want, and please ask your gynae people what they want to write if you're writing the MBBS exam. Those who are writing the entrance exam, go ahead and write 20, because Williams Obstetrics is the book of reference for anything about contraception and obstetrics. So if that book writes 20, you will have to answer 20 in your exams. Okay. Anyway, they are not going to give a choice between 10, 20, 30, 40. No. Between 20 and 30, they are not going to give a choice, because they also know the doctors who are making the MCQs are seniors. They are all professors of major institutes. So they also know that two books give different values. So they don't give both the values together. All right. So yes, 20 or 30, depending on the college where you're working, you can modify. Be smart. All right. This much you can know. All right. Why alternate method is used? I told you, Sudha, that there are sperms. There are sperms in this part. So these sperms can be there every time he has sex for next 3 months, or at least 20 ejaculates. So these sperms can make this man's partner pregnant. So for the next 3 months or 20 ejaculates, whichever gets over earlier, because some people will have sex almost on a daily basis. So the 20 ejaculates get over earlier also. So whichever is earlier, that time is used, is a warning that that time please use some other method of contraception. Mostly they'll use barriers for that time. All right. Then after this 20 ejaculates, 3 months is over, also do a semen analysis. Also do a semen analysis and prove azoospermia. You must do a semen analysis, because if you cut a wrong structure, if you've not done a proper ligation, then the man may still have sperms. So till you do not prove azoospermia, we do not give the certificate. Once he gets the certificate from me that yes, he is azoospermic now, then he approaches the government, and the government gives him that 1100 rupees which is promised. All right. In high focus states like UP and Bihar, those high focus means where the population control is a problem, there we give almost 2000 rupees. But in non-focus states like Kerala and Punjab, non-focus states, we give them 1100 rupees. All right. So semen analysis is also done. So what are the complications seen after you do a vasectomy? Once you do a vasectomy, there can be a any surgery. I did not tell you about the tubectomy, same complications there, but there are some peculiar things in vasectomy, so I'm giving you the list. The complications can be hematoma formation in the scrotum, infections can happen, a spermatic cyst can form because you block things. So spermatic cyst can form, and they can be anti-sperm antibody formation. Why can that happen? Anti-sperm antibodies. Sudha, please listen to this one. Anti-sperm antibodies happen because there is something called the blood testis barrier. So sperms are never in contact with the blood of the man. Yes, sperms are never in contact. But when you do a surgery, and if there is some bleeding and some ligation or some extensive procedure is done, if the sperms come in contact with the circulation, then the body treats these sperms as foreign antigens and starts making antibodies against these foreign antigens. So eventually, even later, if you do a reanastomosis, they may not be able to have children because of the anti-sperm antibodies which are formed in the body. So the sperms keep getting progressively destroyed because of that. Right. What are the other complications? Yes. In addition to these complications which you see after a vasectomy, what are the other complications? Loss of libido, cannot have sex. Loss of strength, cannot lift things, cannot do work. He cannot work in the field anymore. and he's so weak after the vasectomy that he cannot work with the animals, the cattle which he has to use for the plowing of the fields, and he's totally invalid after the vasectomy. All of these complications can happen. Yes, what do you say? So please, none of these complications happen. Okay, I've mentioned them only to criticize the beliefs we have in our society. Yes, vasectomy is hardly done in the villages, hardly done by the people. The laymen will never get it done. Only the educated class, which I mentioned, the government officers and the army and the soldiers and the officers and the IS officers, yes, doctors, they get vasectomies done. People who are uneducated, they are very scared of vasectomies because, sir, how will I have sex? I'll have no strength. You have cut the power supply for me. These are the kind of things they say. So please, they can have sex, they will have an ejaculate, they'll be totally fine. But the sperms will not come out. The seminal vesicle, see, please understand, the semen is not just sperm. Semen, see what is coming here. Can you see this passage? There is this seminal vesicle secretion, there is this prostatic secretions, bulbourethral gland secretions. So all of that will make the semen volume. What is the major component of the semen volume? Seminal vesicle secretion. 70% of semen is the seminal vesicle secretion. So those secretions will keep coming. So please, he will have an ejaculate. He will be able to have erection, everything, but he will not have sperms. The only thing missing is the sperms. So he will have sex, he will be able to do work, and he'll have no deficiency in his performance anywhere in the life. Okay, so that's what about vasectomy is. This is endometriosis. This is how endometriosis looks like. When you look at the uterus and the ovaries, I'll show you normal ovaries and videos about them. So this is the uterus here, these are the ovaries here. Both the ovaries are having the chocolate cyst. So we are discussing endometriosis first, and in this you will see this chocolate cyst, and these two ovaries are so heavy in the pouch that they are kissing each other. That's why you see kissing ovaries. Yes, you see kissing ovaries in cases of endometriosis. The ovaries are so heavy and full of endometriotic fluid, which is basically brownish in color, which is menstrual blood basically. So that's why we call them chocolate cysts, which are both sticking to each other, kissing ovaries. See this? Yes. Look at the the uh, adhesions here. I want you to concentrate on the adhesions and look at the tubes here. Look at the tube here. See, the tube is so badly kinked. So if a tube is so badly kinked, it is like this. It is supposed to pick up an egg. So if the tube is kinked somewhere behind like that, you saw the angulation in that tube. If the tube is so badly kinked, you think it is going to catch the egg properly? See, the egg is supposed to be here. Sorry. See, the egg is supposed to come out from the ovary and the tube is supposed to pick it up. Ovulation and pick up. But the tube is so badly kinked. How do you think it's going to pick up an egg? That's why infertility in endometriosis. So yes, let us see about endometriosis. Endometriosis basically is ectopic endometrium, and the main etiology is the Sampson's implantation theory of retrograde menstruation. So if you see the uterus and the fallopian tube here, so what happens every month? Every month the woman menstruates and the blood has to come out from the cervix. So when the uterus is trying to push this blood out by contractions, I'm trying to show you my hand like the uterus and the cavity and this part is the cavity of the uterus. So when the blood sheds because of the progesterone withdrawal, the shedding of the endometrium has happened. Now uterus will try to push this blood out. Then only the cervix will open. The contraction of the uterus will open the cervix. Now those contractions will take some time to open the cervix. Before that happens, some blood will go ulta, retrograde, and deposit over the ovary. Yes, and then it will deposit over the bowel. It will deposit over the ligaments. So these deposits, all these deposits, these are the deposits of endometrial glands. The endometrial blood is not RBCs alone, isn't it? It has got endometrial glands. So those glands go out and they get implanted in the pouch of Douglas, on the ovaries, bowel, and the ligaments. Now what happens next month? This month the implantation happened. Now next month what happens? She's going to menstruate again. So let's see. She's going to proliferate. She's Now she's going to proliferate every month. Next one, when she proliferates here, she's going to proliferate here also. She's going to make the endometrium secretory here. The same endometrium which was here in the ligament will become secretory. This will have shedding and this will also have shedding. But this has a place to go out and cause menstruation. But this has no place to go out. So this becomes a bigger and a bigger deposit. So this on the ligaments or on the bowel surface, on the tubal surface, on the on the surface of the ovary, all of these places, these deposits go on collecting more and more endometrial endometrial secretions. That is basically the endometrial blood. So that is what is going to cause a lot of pain also to her. So that is what I showed you just now. The first thing I showed you was the look of the endometriosis. So that's how it happens. The implantation of these glands outside the uterus because of retrograde menstruation by the Sampson's theory. All right, and then these places become, all these places will become ectopic uterine, ectopic uteruses. Yes, they'll become ectopic uterus. So that's why she's not only menstruating here, she's menstruating in all these deposits also. That is what is endometriosis. Very painful condition and also causes severe dysmenorrhea, causes infertility. It's a big problem. All right. Most confusing part is endometriosis and endometrial cancer. Please give clear concept. There's nothing to get confused about this. If you have to understand between endometriosis and endometrial cancer, these are totally outright different. It is like, what is the difference between oral cavity cancer and rectal cancer? That kind of question you've asked me. So good you asked me. This is the place. Please, endometrial cancer is in the endometrium. Ectopic endometrium outside the uterus is endometriosis. That's all. Endometriosis कोई कैंसर नहीं है. एंडोमेट्रोसिस में कोई कैंसर नहीं है. तो जो डाउट आता है जरूर पूछो यार. हमेशा याद रखो कि never a doubt is bad, because if you have a doubt, it will stay till the exam and you will get into a problem. So very good. Understand, endometrial cancer is cancer of the uterine cavity. We are talking about that in somewhat more detail later when we discuss about C cervix and C endometrium in another session of array. Right now we are just discussing endometriosis. So endometriosis is ectopic endometrium. Endometrial glands outside the uterus. Bas itna yaad rakho. And they start behaving, all these places start behaving like a uterus. To understand that, and then things become easier for us. So endometrium also goes through these tubes, retrograde, all that I told you just now. So now let's see, 70% to 90% all women have retrograde menstruation. You know what? That when we discuss about this retrograde menstruation, which is the cause, the Sampson's theory, which is the cause of the endometriosis. You know how many women have this blood going ulta? How many women in this world have this retrograde menstruation? Almost 90% women have this blood going ulta and getting deposited in this pouch of Douglas or on the ovary. So 90% women have endometriosis. No, the blood goes retrograde and it deposits in all these places. But in a few women who have more estrogens, they will make these areas grow in size and become endometriosis. Look, estrogen and progesterone in the body, it is present not only in the ovary and not only in the uterus. Estrogen and progesterone, which is coming from, I'll make another diagram for you to understand this. Ovary. Every month the ovary is making a follicle. Follicle is first making estrogen, then making progesterone. You know that. E and P. E plus P. It is coming from the ovary. Now this doesn't go straight to the uterus like this. No, it doesn't do like that. The estrogen progesterone from the ovary goes into the circulation. So from the circulation all over the body, the estrogen progesterone is present. It comes and acts onto the uterus. Now that estrogen progesterone will also act all over the body. And in the body, there are glands of endometrium outside the uterus. So these places also will be acted upon by the estrogen and progesterone. That's what is endometriosis. The blood goes ulta, glands get deposited, and in these places they start to grow. That is what is endometriosis. Now, how many women have this blood going ulta, retrograde? It is there in 90% women in the world. But not 90% women have endometriosis. Only 10% women in the world have endometriosis. Those women who have high amount of estrogens, they will proliferate these deposits, and when they grow they become endometriosis. Yes, those 10% women who have high estrogen and poor immunity. Two lines. High estrogen, poor immunity. High estrogen, poor immunity. Remember that. High estrogen will proliferate these deposits. Poor immunity cannot clear these deposits. That is what is the basis of endometriosis, right? So we are talking about that only, that 70 to 90% of all women have retrograde menstruation, but 10% of women who have poor immunity and increased estrogenicity. Remember these two words, the punchlines: poor immunity and increased estrogenicity, that is increased estrogen in the body. So poor immunity does not clear these deposits which have happened, and poor immunity poor immunity does not clear these deposits, and increased estrogen will proliferate these deposits more. All right, so 10% women have endometriosis. Okay. Look, can we just do the adenomyosis part a little bit later? We are doing endometriosis right now. A lot of people don't know this first. Okay. So, adenomyosis is something else. First, you understand this. So, when we have this endometriosis, it's basically, we'll quickly go through the basics and then I'll take your doubts. Okay, we'll do that. We'll go through the basics. That's what we have to do first. So, we are not going to do a detailed class. We are going to prepare you for the exam. So, what you have to write in the exam, what is coming in the vivas, all that we have to do. And spotters will come in endometriosis. Chocolate cyst pictures will come. They'll have a ovary with a cut section showing endometriosis. All that will be there. Okay. So, sites of presentation, most common site is the ovary, and the second most common site is the pouch of Douglas and peritoneal surface of abdominal organs. Now, deep endometriosis, lesion which is at least 5 millimeter beneath the peritoneum. That deep endometriosis is the reason why there is so much of pain. A lot of women have deep endometriosis. The lesion which is sitting over the bowel, suppose it is penetrating through the rectum and going into the rectal lining. So, she bleeds in the uterus 5 days a month. She bleeds through the rectum also 5 days a month because of deep endometriosis. This question came in MCI exam just now, 17th, 1 week back. Yes, exactly last week on Saturday this exam question came. What is deep endometriosis? It is already there in your app. Okay. So, yes, deep endometriosis is a lesion which is 5 millimeter deeper into the peritoneal surface, and it can present as nodule in the cul-de-sac, that is the pouch of Douglas known as cul-de-sac, rectosigmoid, and even the bladder, this deep endometriosis. Then rare cytodeposits, these deposits can be there in the lung also. Yes, the endometrial glands can go through the uterine circulation, through the veins. The endometrial glands can happen and find the way through the veins into the lung and deposit in the lung. So, she menstruates 5 days. She menstruates 5 days through the uterus. But that time when she is menstruating, there is a gland in the lung also, which is endometrial gland. So, she proliferates and secretes in the lung also. The day there is shedding in the uterus, there is shedding in the lung. She bleeds in the uterus, she bleeds in the lung. 5 days a month, she bleeds through in the bronchus, and she will have hemoptysis. She may have a deposit on the nose. So, 5 days in a month, she will have epistaxis. 5 days in a month, she may even have subconjunctival hemorrhage. So, these are the places: lung, eye, nose, and intestines, sometimes even in nipples. So, these are the places where there could be this implantation of glands outside the uterus, apart from the regular places like the bowel and the pouch of Douglas and the ovary. Apart from that also, there might be some areas like this where implantations can happen. So, these implantations which can happen, these will behave like uterus 5 days a month. These are known as the vicarious menstruation. This is known as the vicarious, vicarious menstruation. Now, sometimes these deposits can be found on the scars also, scars of the cesarean section, the abdominal scar of the cesarean, not the uterine scar, abdominal scar of the cesarean section. It may be there in the episiotomies also. So, scar endometriosis, cesarean section scar and the episiotomy. There also you can see this endometriosis. So, basically what are the color of the deposits? I will be showing you a lot of pictures, but remember the first thing which I showed you in the lecture was the video of endometriosis. So all those deposits, what do they look like? That is what is the pathology. So they look like powder burn lesions. What do you mean by powder burn lesions? Gunpowder. Gunpowder, when it gets burned. You see the matchsticks in your house, when you burn them, the tip is brown. When you burn it, it is bluish blackish in color. So that is the powder burn lesion. So powder burn lesions or blue spots, we call them. Powder means gunpowder, okay, not just talcum powder, it is gunpowder. And chocolate cyst of the ovary, that is within the ovary's endometriosis, there is chocolate colored fluid. And this body will try to heal these deposits which are present. The body will try to heal them. Some healing will be there, although it is not as perfect as other women. That healing with adhesions, now that is also a very big problem of the endometriosis, because these adhesions, I was trying to show you in the beginning of the chapter that the ovary which is supposed to be under the fimbria, the ovary is stuck behind somewhere here because of the adhesions. So there is altering of the tubo-ovarian relations, and adhesions can also cause a lot of pain because bowel may get stuck somewhere, and the the bowel movements also could be getting inhibited because there is extensive adhesion sometimes. So adhesions are a cause of that chronic pelvic pain in endometriosis. I've shown you those adhesions the first thing in the video. All right. So yes, let us see this normal pelvic anatomy first. I'll just try to help you with these videos now for you to understand. But before that, I want to see your doubts, because otherwise you will not understand. Endometriosis and adenomyosis, will come to it. Rishi Karan, hi, how are you? Sadhu, all of that is done. Yes, you are. They are just, the team is just finalizing the video, so don't worry about that. March 5th se pehle you will be able to have all the videos. By the time, the videos which are there, if you see them, you will already pass your exams. Don't worry, Dadu. Okay, can we just stick to the topic now, guys, everybody? So yes, this is the normal pelvic anatomy I'm showing you here. Normal pelvic anatomy first. Dadu, pay attention here. So this is the round ovarian ligament with the ovary, fallopian tube. This is the round ligament going into the deep inguinal ring. Lovely deep inguinal ring you can see here. So this is the normal pelvic anatomy. Now let us see a endometriotic cyst and tubal adhesion. See, this is the uterus, that is the round ligament there. The tube you're not able to see at all. There are so many. The round ligament is shortened because of adhesions. This round ligament is also shortened because of adhesions. Now can you see the right tube, the left tube? There are so many adhesions. See, barely you're able to see the tube. I am not able to see the tube properly at all. Look at this cyst. This is the ovarian cyst here on the left side, which has totally destroyed the anatomy here. See here, the tube I have to take out from the adhesions. Can you see this? It took me almost 2 hours to correct the anatomy of this patient. This was around 2 years back, this video. So can you see the tube is in such adhesions? Can you see this tube here and see these adhesions? That is all endometriosis. And look at this ovarian cyst here, that is the other one. So that cyst I'll show you now. Now these are the adhesions again. The endometriosis causing all these adhesions. And this is the ureter in the adhesion. See the peristalsis of the ureter I'm trying to show you here. So look at this tube here. This tube which was supposed to be on the ovary. This tube is somewhere in the side in the pelvis. This tube, that's what I was trying to show you here. See this tube. This tube is not over the ovary. This tube is supposed to be on the ovary and pick up the eggs. Now tube is somewhere in adhesions here. That's why infertility is also a problem. Now these are the kissing ovaries. This video I had showed you in the introduction to this chapter. And look at these adhesions. Look at the king tube, altered tube ovarian relations. So I'm in the middle of the surgery. I'm just making a video for my students so that they can understand what is the severity of endometriosis. Now this I'm trying to show you, I'm opening this one ovarian cyst I've taken out from the left ovary. See, I've done laparoscopic surgery, so all that it looking black to you because of me having done the cautery. Now look at this side. I want to show you the chocolate pouring out of the right ovary. Can you see that? Chocolate coming out of the ovary. That is the chocolate cyst. Of course, it will bleed when you're doing the surgery. So along with the chocolate, you're also seeing some strawberry forming, isn't it? Strawberry syrup also you're seeing. But yes, classically we say chocolate cyst of the ovary. Now see this, that cyst when I showed you, I'm bursting it to show you what is happening here. Yes, yeah, the chocolate fluid. Of course, when you do the draining of the chocolate fluid, after that you have to take out the cyst wall. Now this is what I want to understand here with this practical video, that when you're doing this treatment of endometriosis, basically endometriosis happens to young women. You cannot remove the ovary. So I have decompressed the cyst. You see this again. I've decompressed the cyst. See, the cyst is getting decompressed. I'm taking out the chocolate fluid. But I have to save the ovary. She's only 25. So she needs the ovary for her menstrual function and for having pregnancy. So that is the crux of endometriosis. That it is because of high estrogen she's having this. She's going to have this cyst. And when I take out the cyst, I leave the ovary behind because she needs the ovary for a normal estrogen. But she has the tendency of endometriosis. She is going to make a cyst again. Recurrence in endometriosis is the biggest nuisance. So what is the practical aspect of this chapter? The recurrence of endometriosis. That's what you have to understand. Endometriosis can go on recurring till the woman is having menstruation, because it is retrograde menstruation which makes deposits, and these deposits, you are taking out the menstrual blood to give her pain relief because the ovary is so big and cystic. You're taking out the menstrual blood. You will take out the cyst wall. After 6 months or 1 year later, she'll make another new cyst. Again, you will take out only the cyst. So that's what is endometriosis. It has a lot of recurrence till the time she is 50 and menopausal. Ultimately, menopause is the final treatment. Till then, she comes to me at 25 and she's here with me till 50 years of age. For 25 years, she'll be my patient. But yes, we can give her a normal life with surgical treatment and medical treatment. She can have a normal life, but she has to come and show me at least once a year. That's what is endometriosis. The recurrence is the biggest problem. To understand this topic, very interesting topic, condition which is there in 10% of women. So many young girls have endometriosis, and you have to tell them that I cannot remove your ovaries. Somewhere I was hearing treatment was given by some, I saw some students showing me a lot of sources where the treatment of endometriosis has been given for a 35-year-old woman to do a hysterectomy. Arey nahi yaar, hysterectomy won't be enough. The ovary is having the estrogen formation. So you have to do oophorectomy also. And at 35, if you do oophorectomy and hysterectomy, the woman will be menopausal and have all the side effects of menopause at 35 years itself. So hysterectomy is not the answer in endometriosis. Please understand. This surgery here itself, you understand, we will try to remove the disease but not the ovaries. You have to give her a normal life till 50 years. So this is what is endometriosis, right guys? So do they always need surgery? No. Surgery is not the every time management, but it is mostly the primary management for getting my diagnosis done. We are coming to that part, okay? And LADES, I'm not talking about that, okay? Tajik Khatun, Tajik Khatun, okay? Please teach in English. Okay, Shubham, Shubham Made, all right? So we will try to incorporate all the languages. Okay, so see the cyst, I'm taking out only the fluid and the cyst wall, but I'm not taking out the ovary. See, I'm saving the ovary. That's what you have to understand. Chalo, now there will be a lot of peritoneal deposits also. The peritoneal, you look, the, oh, yes. See, the omentum is also having all these deposits. See these brown deposits in the omentum. I'm showing you at the liver. On the liver surface also there are deposits, but I don't think in the video you're able to see. Yeah, there's a deposit here. Right. So because of this, I think you understood the problem a little bit at least, because endometriosis is something you read a lot of theory, but till you see all these videos, one of these days, I don't know where you are, if you're interns and if you are medicos, if you're coming to Delhi, just give me a call and you can come to my hospital. If I'm doing the surgery, you're most welcome to come and see. So yes, symptoms are chronic pain, acute monthly exacerbation, present as severe congestive dysmenorrhea and dyspareunia. Now, dyspareunia is painful sex, and this is classically deep dyspareunia. Deep dyspareunia. That is, one is penetration dyspareunia, that is while starting sex, while insertion, there is pain. That is because basically some women have vaginitis. But what is deep dyspareunia? Intercourse is established and the uterus and the cervix and the ligaments move with sex, and those ligaments and the uterus has endometriotic deposits. So that's why it's extremely painful intercourse. Deep dyspareunia and menorrhagia. So dysmenorrhea of the congestive type, and then dyspareunia and menorrhagia. Now infertility, I already told you, I gave you enough hints. Now we are just writing down altered tube ovum relation, the ovary and the tube are not together, and there is decreased frequency of intercourse because of the dyspareunia, and poor ovulation. You saw the ovaries condition, poor ovulation, poor oocyte quality. So embryotoxic endometrial deposits, these deposits which are there, first of all they'll make bad quality oocytes. If at all an embryo forms, that embryo will be affected by these by this endometriotic deposits. So poor quality embryos, reduce implantation and increase risk of abortion. All of these will contribute to the infertility in this woman. And the best diagnosis can be done by laparoscopy, but other things which will help us, a race CA125 will help us in understanding, because it is not always diagnostic, but because CA125 increases also in CA ovary, but a high CA125 gives us an indication that she could be having endometriosis. Ultrasound is generally the best initial investigation to see that there is a ovarian cyst, and there is let's say sometimes a hematosalpinx. All of that you can see. Best initial workup, but not the overall best. Initially it is a good thing to do, and you can see in the ultrasound, yes, this is the transvaginal ultrasound. I had already made this the probe, the ultrasound probe is here, the TVS probe. This is the probe which is there and is showing us a view, and here you see the chocolate cyst. So this is what is known as the ground glass. This is what is known as the ground glass appearing cyst. Yes, ground glass. Now what happens? Ground glass, you must be seeing a lot of glass panes around all of you. Through the glass pane you can see outside of your rooms, but there are some glass panes in the offices. You can see the glass, but they are foggy, you cannot see through them. You can see that vaguely somebody is walking, you can see the shadow, but you cannot see who is walking. That is what is a ground glass. So this is that ground glass appearance. Clear cyst, something like this will be this black color you're seeing, the clear cyst will be like that. But when there is blood inside the cyst, that is what is a chocolate cyst. It is a ground glass cyst. All right. So on the MRI, also you can get a very good imaging. So MRI is the best imaging. Always remember, in radiology, nowadays we don't say radiology, we say imaging, department of imaging, because radiology में क्या है यार, अगर आप अल्ट्रासाउंड करते तो उसमें भी इमेज है, और CT scan, MRI सब में imaging है, isn't it? So this is best imaging is MRI. In gynae generally we say MRI better than CT. Mostly we are happy with MRI, not as a absolute rule, but mostly what I say that MRI is the better investigation in radiology for gynae. So MRI. So that also will tell me, but the laparoscopy is the gold standard. Laparoscopy is the gold standard of diagnosing endometriosis, and this is what you have to write in your exams and even in your NEET PG and INICET exams. So ideally what we say, you do the laparoscopy. I have shown you many laparoscopy videos. Do the laparoscopy, and with the laparoscopy you see this cyst and the lesion. Then the cyst you are treating. Before that, the cyst which you take out, you send it for the histopathology. So laparoscopy and histological confirmation. Actually this is basically histopathological examination, the biopsy of the lesion. The histopathological confirmation is done. So laparoscopy and histopathology is even better than simply laparoscopy. Okay, I said laparoscopy and histopathology, that is laparoscopy and biopsy, is better than simple laparoscopy. So this is what I've shown you earlier also. Let's move on. So surgical treatment we've already discussed. I'm just now enumerating that. Chocolate cyst, you do a cystectomy. Adhesions, you do a adhesiolysis. And powder-burn lesions, those small lesions. Now those lesions you cannot, there might be 100 such lesions. You cannot cut 100 lesions on the bowel or on the uterus or on the the diaphragmatic surface. You cannot cut at 100 places or 50 places, but those places you can burn. So that is what is known as the fulguration. Fulguration of these lesions we can do. When we do the fulguration, we can do the fulguration by laser methods and by the thermal method. Laser and thermal methods, you can do that. Okay, now post surgery, I told you that she may come back to you with within 6 months to 1 year with another cyst and the recurrence of the problems, because she's a young lady. 25 to 35 is the peak age of endometriosis occurring, young woman. All right. So she may have endometriosis as early as 1 year or 6 months also. So what do? You have to make sure that she does not form these things again. So what is the reason she is forming endometriosis? Because of the high estrogen. So you can reduce the estrogen amount, and that is the medical management of endometriosis. So surgical management you understood very easily. Cyst है तो काट दो, adhesion है तो निकाल दो, और अगर powder burn lesion है तो जला दो. This you understand very well. But surgery is only the initial part. The biggest treatment of endometriosis is to maintain the state of normal ovaries and normal uterus with your medical treatment. And in this, you have to suppress the estrogens so that you will have lesser menstruation and lesser endometriosis. And lesser estrogen means all these deposits in the pouch, in the ovary, in the bowel surface, all these deposits get lesser estrogen to proliferate. Sometimes we don't say lesser estrogen, we make her no estrogen kind of a patient. We reduce her estrogen so much, there is hardly any estrogen in the body, so she gets even much more better with the endometriosis. That is the medical treatment. So that is what is coming next. All right, guys, there's 60 to 70% recurrence. So medical management is basically to reduce the estrogens. Where is that? Yes, medical management is basically to reduce the estrogens. So we'll come to that, but let us first talk about the pain relief, medical management. NSAID is for the pain. To reduce the pain, we can give combined oral contraceptive pills will make the cycle anovulatory. So it reduces pain by anovulation, because anovulatory cycle is painless. First chapter, guys, menstrual physiology, first chapter, please see the app. Always I remember that is the core of gynecology. The first chapter, menstrual physiology 1, menstrual physiology 2. All right. So combined oral contraceptive pills will reduce pain, and they will also reduce the estrogen. Okay, so the disease also limited. So annual cycles are painless, and also it limits the estrogen because it has got, the patient has lesser estrogen in the body because of the OC pills. All right. Right. So that is the basis, that you reduce the estrogen as the medical management. So I have told you only one drug so far. One is the painkiller, other one is the COCP. Giving COCPs on a 21-day regime, or sometimes we give continuous COCPs for 4 months and then only give a gap. So she gets periods once in 3 months, once in 4 months, like that also we do. But COCPs is that one very good drug which we can help the girls with. But what are the better methods, even better than COCPs, to reduce the estrogen? I'm just giving you an outline of treatment, guys. We are not going into detail. Actually, this is the basic outline of endometriosis. So yes, the other management is to oppose the action of estrogen. How do you oppose the action of estrogen? Give progesterone. So progesterone causes secretion of the endometrium and stabilization of the endometrium. So when you give this progesterone for a long time, it causes the atrophy of the endometrium. Continuous use of progesterone causes atrophy. The endometrium won't grow at all. So when the endometrium doesn't grow at all, because there is so much of secretion that there is no proliferation possible, constantly give progesterone, so endometrium becomes atrophy. So the punchline of the evening, remember guys, this is that punchline of the evening: atrophy of the endometrium in endometriosis. The word you're learning today with me, endometriosis. You need to reduce the estrogens. COCPs reduce estrogen, but better drugs are there like progesterone, androgens, GnRH analogs. They will stop the estrogen function altogether. So when there is no estrogen function, there is obviously no glands growing. When there are no glands growing, that means atrophy of the endometrium. So where all does the atrophy happen? Atrophy happens not only just in the uterus. See, the endometrium will be atrophic. There is no gland growing. I'm just making a lining. There is no growth of the gland. Okay. And the pouch of Douglas, these glands will become atrophic. Ovarian glands, they will become atrophic. Wherever there is endometrial glands, they need estrogen every month to proliferate. Endometriosis needs estrogen to proliferate. You make them lesser estrogenic places by COCPs, or inhibit the action altogether by giving high dose of progesterones. atrophy will happen. Again, I'll tell you atrophy in the next slides, okay? So, progesterone causes atrophy of the endometrium. So, the method of giving progesterone is by the depot-medroxyprogesterone estate, that DMPA, which you heard in the chapter of contraception also. So, DMPA 150 milligrams once in 3 months you can give, or you can give tablets of Dynogest. That is this new exciting drug which is now used. A lot of people don't like the injections given on a 3-monthly basis. You can give Dynogest. Both of these will cause atrophy of the endometrium. Can estrogen cause problem? We are coming to that, my friend. Yes, the whole chapter is about that. So hold your guns, listen to me. Okay. Momin Liaquat, welcome here. Speak in Hindi. Yadav, Priyanshu, look guys, I'm so sorry. The exam is going to come in English यार. तो मैं हिंदी बोल सकता हूँ, मैं चाहता हूँ कि आप हिंदी सुने, बट यहाँ पे बहुत सारे मेरे दोस्त साउथ के भी हैं, उनको फिर तमिल चाहिए होगी, किसी को बंगाली चाहिए होगी, तो कि আমি বাংলা বলুন কি আপনার কি কিনতে চান আপনি, how much do you want guys? So we have to speak in English guys, so that is the medium of instruction. ठीक है, कुछ समझ में नहीं आएगा तो पूछ लीजिए मुझसे, मैं हिंदी में जो पार्ट समझ में नहीं आया मैं हिंदी में एक्सप्लेन कर दूंगा. ठीक है, चले आगे बढ़ते हैं. तो डायनोजेस्ट प्रोजेस्टेरोन देने से एट्रोफी हो जाता है. और आगे बढ़ते हैं. अब हमें ईस्ट्रोजन, वी आर ट्राइंग टू रिड्यूस द ईस्ट्रोजन कम करना है. तो ईस्ट्रोजन कम करने के लिए, एंटी ईस्ट्रोजन एक्शन करने के लिए हमने बताया यू कैन रिड्यूस बाय COCPs, यू कैन रिड्यूस बाय द प्रोजेस्टेरोन्स, एंड यू कैन गिव एंड्रोजन्स. Androgens are anti-estrogenic, so they cause much faster atrophy. Androgen have an anti-estrogenic action, so that's why when you give danazole will be, it's a tablet which is having an androgenic action. It has got a high androgen action and it makes a low estrogen environment. It suppresses the GnRH and the gonadotropin secretion, so it does not allow the ovulation also to happen. Ovulation is the one which is making estrogen and progesterone, all right, and it directly inhibits steroidogenesis, so also causes increased clearance of estradiol and progesterone. So this mode of action of danazole keeps coming in your exams. How does danazole help? It basically is a anti-estrogen kind of action because it's an androgen. And how does this act? It reduces the androgenic environment by the suppression of the estrogen. It reduces the estrogenic action by increasing the androgenic action and also suppression of the steroidogenesis. Okay, but yes, androgens will have side effects. So you can give it for a year or so, maybe 2 years, but by the end of this first year, 1.5 years, she will have the side effects of hirsutism. And the hirsutism, you know, is the male type of baldness, facial hair and acne. But they can be worse. Hirsutism is male pattern baldness in a lady, facial hair, acne. But what is virilization? Virilization is hoarseness of voice. The voice of the girl starts sounding like a boy, hoarse voice, and breast atrophy and clitomegaly. Now, why did I make them separate headings? Guys, concentrate. Why did I make them separate headings? Because virilization is irreversible. Yes, virilization is irreversible. If you stop androgens, if you stop the androgens, then the patient will have reversal of the hirsutism. The acne will clear up. Okay, the acne will clear up. The facial coarseness will clear up. But if you stop the danazole, the virilization won't get treated. Virilization is lifelong. Yes, these are permanent. It is irreversible. That is what is the difference between hirsutism and virilization. So when there is virilization, you cannot reverse it. So that's why we always ask you, what are the indications of stopping the treatment by danazole? The first sign of stopping treatment by danazole is the hoarseness of voice, MCQ. That stop the treatment by danazole if the woman starts having hoarseness, because next she's going to have a clitomegaly. I've seen a girl with a clitomegaly. It was so bad, not because of this. I mean, she had some androgenic tumors. It was like a small penis in a lady, and it was a 2 centimeter long clitoris. So that's why clitomegaly can be an extremely worrisome condition for a lady. And if you stop the androgens, the clitomegaly does not shrink back. Yes, it will persist. The clitomegaly will persist for life. You will have to do surgical management. So that is why we must understand the difference between hirsutism and virilization. That's why we are impressing upon the outright basics which my students from PW should understand, right? So next, what we can give the GnRH analogues. Now GnRH analogues, before giving that, मैं समझाना चाहता हूं कि जीएनआरएच नॉर्मली क्यों कैसे काम करता है और जीएनआरएच एनालॉग्स क्या होते हैं। तो जीएनआरएच क्या होता है, ये एक पल्सेटाइल रिलीज है। आपको पता है कि एक पल्सेटाइल रिलीज होता है विच इज वंस इन 90 मिनट्स। और ये जीएनआरएच गोनाडोट्रोपिन रिलीजिंग हार्मोन पिट्यूटरी पे एक्ट करेगा और वो गोनाडोट्रोपिन्स को निकालेगा। गोनाडोट्रोपिन्स मतलब एफएसएच एंड एलएच। तो गोनाडोट्रोपिन रिलीजिंग हार्मोन पिट्यूटरी, एफएसएच, एलएच, ओवरी makes a follicle estrogen, ruptures the follicle, the same follicle becomes cooperative, makes the progesterone. So estrogen and progesterone in the ovary because of the stimulation of the pituitary by the GnRH. ये हमारा normal menstrual cycle है। ये मैंने हमेशा बोला है, do not come to any hormonal chapter without reading the menstrual physiology chapter. That is the core of my classes. Once you understand those two chapters which are there, you've already been given the notes on the online sources. So please read the menstrual physiology chapter. That is extremely important. So once you understand that, now GnRH analogs क्या होता है? GnRH analogs. Analogs means drugs which are like GnRH. Drugs which are like GnRH. So like GnRH मतलब GnRH is stimulating the pituitary. Like GnRH will also stimulate the pituitary. Correct? Correct. Analogs are the same drugs like GnRH. They will also stimulate the pituitary. ध्यान दीजिए यहाँ पे, please do not get distracted. Any one of you thinking of anything else, if you not understood the chapter endometriosis, ठीक है. If you joined just now, understand GnRH analogs, especially my MBBS students. The interns and the post interns, PGs have understood this part. But my MBBS students are the major concentration for this class. And understand that GnRH analogs are the same as the native GnRH in the body. GnRH analogs, same action hai. So same action if you do the same action like the GnRH, the same action is the GnRH analogs. So don't you think you'll stimulate the pituitary too much? And the pituitary will make more FSH, and more FSH will make more ovarian follicles and more estrogen? Yes, GnRH analogs will do that only, correct? So we change the method of giving. Remember, the drug is given in a different manner. Normally, the GnRH is pulsatile once in 90 minutes, but we give continuous GnRH analogs. So when you give this GnRH analogs continuously in a continuous infusion or in a depot form, we give a high dose of GnRH analogs into the muscle of the lady, and it works for 1 month. Some injections work for 3 months. So continuously you give this in a daily inhalation form or an injection form or a depot form you give. Either way, you're constantly giving GnRH, not in a pulsatile form. देखो पिट्यूटरी को आदत होती है कि once in 90 minutes में उसे स्टिमुलेशन मिलता है, तो 90 minutes में एक बार वो काम करती है पिट्यूटरी. That is what is the basis about the pituitary function. 90 minutes में एक बार काम करना है मुझे. But now what do? You give it continuous stimulation. Stimulate, 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 and stimulate, stimulate, stimulate. आप उसको ब्रेक ही नहीं दे रहे हो पिट्यूटरी को. पिट्यूटरी बोलेगी भाड़ में जाओ, मैं काम ही नहीं करूंगी. Yes, पिट्यूटरी will say I will not work. You're stimulating me so much, I cannot work so much. I work once in 90 minutes. So yes, ये pituitary, you stimulate it so much that it cannot respond to the stimulus anymore. Pituitary थक जाती है काम करते करते. So when you give it so much of stimulation, it'll work. It'll try to work up to the stimulation for 1 day or 2 days, and then the pituitary gets suppressed. So yes, this causes something called down regulation. The word, all these receptors get down regulated. They cannot respond to the stimulation anymore. So yes, there is down regulation or desensitization, down regulation of pituitary. So pituitary is now sleeping. Pituitary is now sleeping, and that pituitary which is sleeping, that means there is no FSH and LH. That means the ovary is also sleeping. That means there is no estrogen and no progesterone. That means there is atrophy again. Yes, there is atrophy again. So we cause atrophy by this. Then we had caused atrophy by the androgens. They will also cause atrophy of the endometrium, faster atrophy. Then we discussed about the progesterone. They cause the atrophy. And then we discussed about the estrogens. Estrogens cause the limitation. They cause the limitation of the endometriosis. So, medical management, I am trying to be very repetitive here. Medical management aims at causing limitation of the endometriosis by OCPs, atrophy by progesterones, atrophy by androgens, and atrophy by GnRH analogues. What are the names of the GnRH analogues? Leuprolin, naferlin, goserlin. There are many lins, okay, GnRH analogues. Yes, so all of these will cause the woman to have a good relief in endometriosis. This GnRH analogues is supposed to be the best medical management, of endometriosis. Okay, remember that. So yes, now the problem is, somebody is already asking me, if you suppress the estrogens for a long time, what will happen? So yes, I'm giving GnRH analogues. It's giving me very good results. The patient is fine. It has got atrophy of the endometrium, so she has no pain in the pelvic pain. There is no dyspareunia, and she's having much relief from the disease. But she's also not having periods because there's no estrogen. Okay, I'm saying this is for your treatment. As long as the drug is given, you will have no periods. Correct. But your disease also won't trouble you. So you have to live with that you're not having periods for some time. Okay, sir, you're healing me. Thank you so much. But if you do not give estrogens for more than 6 months, then the bones will miss the estrogens maximum. The bones will miss the estrogen very badly because estrogen is required for the bone formation. Yes. Please see the HRT chapter, all right? The PW, all the app, we have given all these important chapters. Please see the HRT chapter. Estrogen is paramount for the woman. That estrogen is not there for this woman. If you stop the estrogen production for more than 6 months, it can cause osteoporosis. If given for more than 6 months, can cause osteoporosis. But that does not mean that I will stop my treatment. Very important fundamental here. I know if you give GnRH analogues for more than 6 months, it can cause osteoporosis. But I can continue the treatment with GnRH analogues and give her a little bit estrogen, which is required for the management, for prevention of the osteoporosis. So yes, after 6 months, look, there are many women we give GnRH analogues continuously, 3-4 years we've given. Excuse me. But after 6 months, we give some low dose estrogens to prevent the osteoporosis, and that is what is given by the add back therapy. That is what is known as the add back therapy. This is what is the pharmacology question which keeps coming. What is the meaning of add back therapy when you're giving GnRH analogues? So that estrogen reduction is good for the treatment of endometriosis, bad for the bones. It causes osteoporosis. So continue the GnRH, but give a low dose estrogens. So we can give this tibolone. Tibolone is a synthetic estrogen. HRT chapter, okay, please see that synthetic estrogen, and it has got a progestation action. Norethistron can also help in the osteoporosis, and conjugate equine estrogens with medroxyprogesterone acetate. Okay, equine estrogens with medroxyprogesterone acetate. We can give these also. So this is what is known as the add back therapy. Continue giving those drugs, and one of these drugs, generally I give this tibolone, or I give a low dose of estrogen tablets. We have estrogen tablets like Primarin, low dose of Primarin I will add. Okay, so all these drugs will help the osteoporosis. That's about endometriosis. I actually got very emotional about this chapter because we see so many young girls. Which book? PW, the app of OBS and Gynae. Man, that is the app to read. All right, come on. So what about the other hormones which are secreted? So pituitary is not totally suppressed. Good question. I like that question so much, future doctor. The problem is when you give GnRH analogues, that is going to tire out the pituitary. Which part? The gonadotropin releasing hormone agonists, they are going to stimulate the pituitary's FSH and LH making parts. Those parts get they get so much downregulated. Not the entire pituitary. Yes, You are not suppressing the entire pituitary. So pituitary is, it's the master gland. You know about that. So it is going to help in so many other functions. Only LHFSA production is reduced. Good question. Good. That means you're listening. Good. Chalo aage badhte hain, guys. If you don't have any other questions, which book you are referring to? Again, the PW app is the best book. Yes, you guys are here with me because you are doing the best kind of education with the best teachers. You're trying to understand the basics with us. Outright core basics. That's what we always teach you in our classes. All right. Chalo aage badhte hain. To prevent osteoporosis, what is given? Once again, it's there. It's there. We're still in that same screen. Sudha, we are in the same screen still. Okay, let's move on, guys. And Sudha, you can see this. Let's get into fibroids. Okay, fibroids or leiomyoma. Here, yours truly, I'm holding a fibroid after a myomectomy. This is one of the 23 fibroids I took out in this patient. Long surgery. This was done during the Corona days. So, in addition to wearing a mask and then wearing a shield and then having another shield in front of me, there were some days, man, doing surgery during the Corona days. And there was no AC. It Corona started in the time of March, April, and it was peak heat summers, and the ACs were put off because the ducts are all connected. So in big hospitals, so if there is a Corona patient you're operating and the aerosols, it was assumed that all of that is going to take the virus all across the hospital. So that's how it was. Anyway, so let's see about fibroids. Now, fibroids, also known as leiomyoma. So when you talk about leiomyoma, you must understand it is the most common tumor of women. Yes, let me just stop this and give you the understanding. What is the most common cancer of women? You always say CA breast. Most common gynecological cancer of women, CA cervix. Correct. But that is cancers, malignancies. When I say tumors, tumors can be benign and malignant. If you see a woman, okay, one woman standing in front of you, the woman top to toe, there are so many bodily organs. They can all have benign tumors and malignant tumors. So tumor, if I say head to toe, all organs included, the commonest tumor in a woman is the fibroid uterus. Okay, commonest tumor in the woman. Malignancy, CA breast, CA ovary, you know very well. Commonest tumor in a woman is a fibroid. 30% women in the world have fibroids. All right. So as many as 30% all women, and it is 2.5 times more likely to happen if a relative has fibroid, and this woman has 2.5 times more chance. It is associated with chromosomal abnormalities also, and it is seen more in nulliparous women. And again, it is increased estrogens that is associated with fibroids. So that's the quick revision of the etiology. It is also associated with increased growth factors like the transforming growth factor and the platelet derived growth factor, PDGF rather, platelet derived growth factor, epidermal growth factor, and the vascular endothelial growth factor, right? So fibroids are monoclonal tumors, and these are smooth cell tumors. You will see these whorls. Can you see, if you just concentrate on this part of the histopathology, can you see there are whorls, circular arrangement of spindle muscles, whorls of smooth muscle cells you see in fibroids, spindle shaped cells, eosinophilic cytoplasm, oval nuclei with a blunt end. The pathology teachers will tell you all of this much better, but I thought I'll just tell you that it's a monoclonal smooth muscle tumor, and these are surrounded by a pseudo capsule. So can you see this uterus, which is the normal muscle here? I'm trying to show you with shading. Now this is the whorls of smooth muscle cells, and this red line is there to show you that it is an encapsulated area here. It's an encapsulated area here. So we say it is an area of smooth muscles, whorl shaped arrangement of smooth muscle fibers. So you can see in the uterus, you will see an area of a fibroid. You can see it easily. Now, here I'm going to take a break and make you understand a few more things. So, concentrate, guys. So, fibroid uterus, the fibroid may be like this, the fibroid may become bigger also like this. Again, in a whorl, circular arrangement, गोलाई में रहता है, whorls of tissue, गोलाई में रहने वाला ऐसे. तो फाइब्रॉइड ऐसे ऐसे भी बढ़ता जाएगा, ठीक है. So, fibroid will be a circular arrangement of smooth muscle fibers. So, fibroid is an irregular enlargement of the uterus. Irregular enlargement of the uterus most of the time. I'll show you many pictures also just now. irregular enlargement. But there is something called adenomyosis. Adenomyosis is different. Adenomyosis has uniform enlargement of uterus. Wait, I can show that to you immediately now so that we don't keep imagining things. Let's see if I have my. See this, guys. This is the regular enlargement of the uterus here. See, this is adenomyosis. Fibroids, I'll be showing a lot of pictures in this lecture. This is adenomyosis. Now, there are three things now we're discussing together. Okay, so don't get confused. Concentrate. No left, right. Okay, only center. इधर उधर की बातें नहीं करनी. When we're talking about endometriosis, blood going outside the uterus and getting deposited over the ovary, ectopic endometrium in the pouch of Douglas in the ovary. Sometimes the blood goes out from the uterine cavity here. See, this is the compressed cavity and it goes only into the muscle of the uterus. So there is blood which is ectopic again. यूट्रस से बाहर ग्लैंड चले गए. कहां गए? यूट्राइन मसल के अंदर. The glands have gone outside the uterine cavity. Now they are within the muscle of the uterus. That is what is known as the adenomyosis. If the glands go out and they are present in the pouch of Douglas, on the ovary, on the bowel, in the diaphragm, endometriosis. Glands go outside the uterus, are present in the muscle of the uterus, adenomyosis. Look, the adenomyosis uterus is uniformly enlarged. This is uniformly enlarged. Okay. And now we're talking about fibroids. Fibroids are nothing to do with ectopic endometrium. Fibroids are smooth muscle tumors. All right. So that is a different etiology. But I'm comparing all of these because you asked me in the beginning of the chapter the difference between that. And endometrial cancer will be in the uterine cavity. Okay. So that some of the time we'll discuss. So abhi I'll get out of this. Back to my lecture. Yes. क्या पूछ क्या रहे हो तुम लोग? मैं वहां पे चले जाता हूँ. All right, same things. Okay, Fahad, thank you. Okay, let's move on. Fibroids are monoclonal tumors, and I told you about this already. Yes, so there will be this irregular enlargement of the uterus in a fibroid. Okay, now let's move on and see what is the morphology of fibroids. A lot of questions are coming on this these days, especially for the NEET exam students. Okay, so what happens? Fibroids will always start in the muscle of the uterus. Basic. Fibroid शुरू कहाँ होता है? हमेशा uterus की muscle में शुरू होगा. So fibroids start in the muscle of the uterus, and that is treated as a foreign body by the uterus. There is a muscle, whirl of smooth muscle here. Now, suppose I'll try to show you with my hand here. Yes, I have a better example. I'll show you with this. Yeah, here. Look, the same thing I'm trying to show you with my hand here. See? Yeah, see, there's a fibroid here in this uterus. Can you see? Just that I'm reproducing here. Can you see this black dot? Yes, it is there. You can see. Now, this uterine muscle does not like this fibroid. Fibroid is treated as a foreign body by the uterus. The uterus goes on contracting. It goes on contracting to push this fibroid away from this uterine muscle. So the fibroid starts in the muscle, in the intramural area. Uterus tries to push it out. So this fibroid gets pushed outside and becomes subserosal. Sometimes it gets pushed inside and it becomes submucosal. That is what is the part of fibroid which is never understood. When we keep reading such big books, we don't understand the outright concept. The concept is fibroid will start here and move on. So it is treated as a foreign body by the uterus. So uterus responds by contracting on the fibroid to push it, and it can be pushed outwards and it can become a subserosal. See, this is a subserosal fibroid. Subserosal. Okay, it may get pushed outwards or it may get pushed inwards and may become a submucosal fibroid here. So subserosal, and this is submucosal fibroid. Okay, so this is what happens to the fibroid. And many other places in between. Concentrate, nothing else. Sit straight, no left, right, only center. Fibroid muscle में शुरू होता है. With the contraction, it can go outside, it can go inside. Inside is called submucosal, mucosa cavity में coming, it is known as mucosal. Then goes to the serosa surface, subserosal, and many other places in between. That is what is the classification of fibroids which is coming in your exams. So that is the basis of the classification of fibroids. So now I am showing you type 4 पे consider करेंगे हमेशा. Type 4 is the most common type, intramuscular fibroid. From there it can move towards the cavity. See, type 3, it is touching the cavity. It can come into the cavity, type 2. It is more in the cavity and less in the muscle, type 1. It is totally in the cavity. See, it is hanging in the cavity by a stalk, type 0. Or it may go outwards. From 4, it may go outwards. See, it has become, from 4, it has become a 5. That is going towards the serosa, but mostly in the muscle, somewhat in the serosa. Now it becomes a 6. It is very less in the muscle, mostly in the serosa. Type 7, only in the serosa and hanging. Hanging means pedunculated, something hanging. Look here, see, something hanging with a stalk. Let's say if you imagine this head as a ball, okay? So this is hanging, this is hanging. Suppose it is hanging like this. This is pedunculated. Something is hanging. You have bulbs hanging with long metal poles, pedunculated. Our fans are hanging with those poles, pedunculated, okay? Something hanging. So let us see this. So that is the basis of the FIGO classification. So we always start with the type 4. Once you see the type 4, intramuscular, okay, I'll stand on the side, okay. Type 4 is intramural here, within the muscle. Then it goes towards the cavity. So 100%, see the type 3, it is 100% intramural, but it is touching the cavity. Now, it is more than 50% in the muscle. Look at type 2, please. 50% in the muscle, but partly in the cavity. Now, type 1, less than 50% in the muscle, but rest is in the cavity. So, type 1 is less than 50%. So, type 2 is more than 50%, type 1 is less than 50%. And type 0, pedunculated, intracavity fibroid, hanging. Look, what I want you to consider here is that in all this nomenclature, I have said the intramural part first. I've always mentioned the intramural part first so that you don't have confusion in understanding. So it starts in the muscle and it is going towards the cavity, type 3, partly in the cavity, type 1, more in the cavity, type 2, and totally in partly in the cavity, type 2, more in the cavity, type 1, and totally in the cavity, type 0. So that is the classification. Now you have to see the other way. From 4, it becomes a 5. More than 50% in the muscle, but it is partly in the serosa. See, subserosal, type 5. Type 6, less than 50% in the muscle, but mostly in the serosa. See, 6. I showed you earlier also, now I have written this here. And type 7, subserosal, pedunculated, hanging. Now, these are the basics. Now, there is another type of fibroid which is found only in the cervix. So, that is what is a type 8 or the parasitic fibroid. Also, there is another one. So, type 8 which is in the cervix. A fibroid in the cervix is known as type 8. Okay. But type 8 is also a fibroid which is, let's say, which has detached and is somewhere else in the peritoneal cavity. So, there is a fibroid like type 7, it gets detached and now it is sitting in the pouch of Douglas. So, we say it is type 8, or it might be detached from there and it might be lodged under the diaphragm. That also becomes a type 8. So, cervical fibroid, here any fibroid of the cervix is type 8. Any fibroid of the cervix is type 8. There we don't say muscle mein jyada, muscle mein kam, all that doesn't come there. Any fibroid in the cervix is type 8. And fibroid which is in the pouch, which is away from the uterus, we say it is somewhere else. The fibroid was starting in the uterus, but now it is found in the pouch and it is growing there. It is formed in the diaphragm, it is formed in the omentum. That is what is known as the type 8 also. All right. So, type 2-5. Now, this came only once in the INICET, so I have to teach you that. Part of the fibroid is partly, see the 2-5. Part of the fibroid is coming into the cavity here, see? Yeah, but part of the fibroid is also coming to the serosa here. So, one fibroid has a cavity ka part and the same fibroid also has a serosa ka part. It has got two parts, this fibroid. this part, this side it is coming to the mucosa, that part it is going to the serosa also. That is what is a 2-5 fibroid. It's a hybrid. It has got two connotations. दो जगह से, मतलब एक जगह से वो म्यूकोसा में आ रहा है, दूसरी जगह से सीरोसा में भी जा रहा है. So that is a 2-5 hybrid fibroid. All right, so that is the FIGO classification. Now tell me, what is this fibroid? Yes, I have marked an arrow here, and tell me, what is this fibroid? This she's got many other fibroids here. She's got a tube and the ovary. See the altered tube over relation. Can you see this altered tube over relation here? And that's why infertility in fibroids also. But tell me, what is this fibroid, which is having a stalk here and a big fibroid which is small stalk on the surface? Yes, this is a type 7 fibroid, isn't it? That's a type 7 fibroid. And this, when there's a stalk, they can get twisted on their stalks. All right, what is this fibroid? See, I've cut open the uterus to show you the fibroids. This is a fibroid which is mostly in the muscle, and it is just touching the cavity. So I'll say it looks like a type 3. And here there's a fibroid here which is mostly in the muscle but partly in the cavity. So this looks like a type 2 fibroid. This here looks more like a type 50-50 type लग रहा है, type 6 लग रहा है मुझे अभी ये. So these are the types of fibroid you can be asked. This is a little borderline kind of case, but yes, they are fibroids. They will give you a section and ask you what type of fibroid it is. या फिर they'll not give you a picture, they'll just draw and ask you what type of fibroid is this. And this is a fibroid inside the cavity. This is a fibroid inside the cavity which is hanging. This is a hysteroscopic view. So can you see a nice round structure which is hanging? This is a pedunculated type 0 fibroid. What is this fibroid, guys? This is my favorite picture, one of the hysterectomy specimens. So you look at this and think that this is the fibroid. Some of you thought that. Don't lie to me. You thought that, isn't it? This is not the fibroid. This is the uterus. ये यहाँ पे tube है. This is the tube. This is the hysterectomy specimen. We've taken out the uterus, and this whole thing here is the fibroid. Look, this is the mouth of the cervix. You're seeing the opening of the cervix here, and the cervix is involved in the fibroid here. So any fibroid in the cervix is type 8. This is a type 8 fibroid. Okay, type 8 fibroid. It's got a very interesting name. लालटेन ऑन द डोम ऑफ सेंट पॉल्स कैथीड्रल. सेंट पॉल्स कैथीड्रल लंदन में एक चर्च है. चर्च के ऊपर एक लालटेन है. उस लालटेन के जैसा ये दिखता है. तो पहले हमें जनरल नॉलेज भी पता करनी पड़ेगी टू अंडरस्टैंड द appearance of this fibroid in the cervix. If you know, you have passed your exam. But it is called the Lalton on the dome of St. Paul's Cathedral. All right, that is what is the St. Paul's Cathedral here. ये जो यहाँ पे दिख रहा है ना, Lalton on the dome of St. Paul's Cathedral, वो वाली look है ये. Thanks to Google, I have also seen it. Of course, when I finally reached London and saw that, इतना बड़ा चर्च है, उसके ऊपर आपको दिखता भी नहीं है. कैसे उनको पता चला ये Lalton is like that? But हम लोग अपने बचपन से, मतलब right from my third year of MBBS, my professor has been, all our professors have been telling about the cervical fibroids, Lalton on the dome of St. Paul's Cathedral. All right, so that is a very, traditional gynecologists love to hear these things. Okay, चलो आगे करते हैं ये symptoms की बात. There is pain, abdomen, dysmenorrhea, and compression because of fibroid of vital organs such as the ureter may also cause hydronephrosis. These fibroids can become very big, and torsion can happen. Fibroids can get turned. So this patient here, see the fibroid which I showed you earlier, this actually came to me with a torsion, severe pain abdomen. So we had to do an emergency hysterectomy. She was an older woman, so we could do a hysterectomy. Anyway, there were so many fibroids in this patient. So this area can undergo a torsion. So that's what is one of the problems. But that is very rare. Huh? Torsion is not the commonest. Don't say torsion is the commonest. No. Pain abdomen, menorrhagia, and dysmenorrhea, these are the major symptoms. All right. So what is the other problem with fibroids? The fibroids can have, apart from pain and increased bleeding, the fibroids can undergo a degeneration. These fibroids can undergo a degeneration. So these tissues, these extra tissues, when they get degenerated, there are multiple types of degeneration. So this becomes a short note in your exams. What are the types of degeneration you see in fibroids? So most common degeneration is the hyaline degeneration, and the rarest degeneration is the sarcomatous degeneration. I try to make you understand the core basics. So commonest is the hyaline, and the rarest is the malignant degeneration or the sarcomatous degeneration, which is, they've asked you less than 1% cases, you see this. All right. Then there is the calcific degeneration. They can be, that is a womb stone, cystic degeneration, fluid type of collection, lipoid degeneration, fatty collection, necrotic or infectious degeneration, but most common is hyaline and rarest is sarcomatous. But there's another degeneration which I have not even mentioned here, that is the red degeneration, and red degeneration seen in the pregnancy. So that's why I have given you another slide for that, a more dedicated part for this red degeneration. So most common in pregnancy is the red degeneration. This is the solid MCQ. Red degeneration seen in pregnancy, and this starts in the second trimester, and it presents with pain abdomen and uterine tenderness and fever. The treatment is conservative. Purple, red due to thrombosis of the veins, all right, more description. Conservative management, that is painkiller de do, उसे sedation de do, आराम करा दो. She is pregnant and having a fibroid. So याद रखो, the biggest problem with fibroid surgery, is that a fibroid surgery will bleed a lot, even in a non-pregnant woman. Biggest problem. The chapter now will turn towards that, कि fibroid में bleeding कैसे कम करनी है. That's the only discussion after this introduction. So now the woman is pregnant. In addition to having a fibroid, she is pregnant. She's got this pregnancy. Now, when there is pregnancy, along with that, there is a fibroid. This is an extremely vascular time, extremely vascular surgery. It will be, I mean, the area will be so vascular that if you make an incision on a pregnant uterus, I don't know, some of you are interns if you're watching this, and those final year students who have seen cesarean sections. Any cesarean bleeds a lot. So that's why we do a lower segment cesarean, and the resident is busy making sure that the lower segment doesn't bleed. If that uterus can bleed so much, suppose you're trying to do a fibroid removal in a pregnant uterus, that can bleed like crazy. So bleeding in fibroids is a major problem, and fibroids bleeding in pregnancy is still bigger. So no surgery, conservative management, painkillers and rest and sedation. So NSAIDs we give her in pregnancy, we give her sedation and we give her rest, but we give no surgery, okay? No surgery of fibroid in pregnancy. Remember that basic, all right? Chalo. Now this is a menorrhagia as the most common symptom. I'm trying to show you what is the cause of bleeding in fibroids. Now this is where they want to ask you a lot of questions. So let me try and show you with this example, simple example here. Look here. Why do fibroids bleed so much? What is the most common presentation of a fibroid? Excessive bleeding. Don't forget that. Pain bata diya, dysmenorrhea bata diya, degeneration bata diya, and compression of other organs I told you. But overall, the core understanding, fibroids bleed a lot. Menorrhagia is the most common presentation, excessive bleeding. What is the mechanism of excessive bleeding? So normally, you know, when the uterus, okay, there is a fibroid here. I'll show you with a normal uterus here. This is a normal uterus, and in this normal uterus, you're seeing that the lining will shed every month, and the base of the uterine muscle, the glands here, these glands, when they shed, the base of the glands, the blood vessels are going through the muscle of the uterus. Those glands, when they shed, the base of those glands will bleed. That's why when shedding happens, glands will come out and blood also comes out. So lot of women will have bleeding in periods, and that bleeding is 5 days, 3 days, 4 days normal. So to reduce the bleeding, what does the uterus do? All these blood vessels which are bleeding, the uterus undergoes a contraction. Uterus contracts to stop the bleeding. That's a normal mechanism for any woman who is having menstruation. But what happens when there is a fibroid in the uterus? Look, I'm making a uterus with a big fibroid now. Can you see this? There's a uterus with such a big fibroid. So now she sheds the endometrium, she has bleeding little bit, but the uterus is not able to close totally. See, it is not able to contract and close totally. So uterus is contracting, it is trying to close, but the fibroid is acting like a foreign body and not allowing the uterus to totally contract. So uterus wants to contract and stop the bleeding, but the fibroid is in the way. So this is the reason why the uterus cannot contract completely. Ineffective contractions. So contractions stop the bleeding. Remember, in PPH also we say contractions stop the bleeding. In a normal uterus also, uterus closes the blood vessels by contraction. That is not able to happen because of this foreign body. So that is one reason. Number two, the glands of the uterus, They are formed over the lining here, they are formed over the lining here, but they're also formed all over the fibroid, below the fibroid and behind the fibroid. All over the glands will be formed. So number of glands is more in a case of fibroids uterus. All right. So this is what you have to understand. So increased endometrial surface, ineffective contractions, and increased congestion because of increased vasodilator prostaglandins. These three things are the reason why there is more bleeding. Remember these causes, guys. Also, there are other patterns like there is progressive menorrhagia, that is more with the intramural and submucosal fibroids, and menometorrhagia due to submucosal fibroids. These are the patterns. So menorrhagia, progressive menorrhagia, and menometorrhagia. These are the fancy names which are associated, but basically you have to say menorrhagia. If you say that part, you have passed your MBBS exam and you passed your entrance exams. If that you know, I'm happy. These are the other fancy terms. Yes, it is progressive menorrhagia, that the menorrhagia goes on increasing. Next month she'll have more, and the month after she'll have still more bleeding. And menometorrhagia means irregular acyclic bleeding. So because of submucosal fibroids. Infertility because of the altered tube-ovarian relations, which I told you already, but in addition to that, increased uterine contraction will not allow the embryo to implant. That is simple. Associated PID and endometriosis can happen, distortion of the cavity can happen because of the fibroids, and then blocked tubes, especially at the cornua, and also due to the stretching of the tubes. The tubes which are so badly stretched, I showed you a couple of pictures. The tube which are so badly stretched, those stretched tubes will obviously get blocked, and also because of the compression by the fibroids, the tubes can get blocked. And bowel and bladder symptoms can happen. You see this fibroid at the top. I'm trying to show you a woman like this, like the way I'm standing. I'm trying to show you a woman from the front to the back. So you can see the pubic symphysis. This is the anterior part of the lady, and then this is the bladder, this is the uterus. Now there is a fibroid on the uterus. It is pressing on the bladder, so it will cause her to have more frequency. First there will be hesitancy, then with the fibroid increasing size, there will be more compression on the bladder, there will be more frequency. Then eventually the fibroid becomes very big, there could be retention of urine. Now retention of urine is more because the posterior, see, posterior cervical fibroid. This posterior cervical fibroid, it becomes so big. See this? Look at my hand and look at this cap, which I'm trying to show as a posterior cervical fibroid. So this posterior cervical fibroid will press the uterus forward. See, it will press the uterus forwards. It will press the uterus forwards, and that will compress the urethra, and that compression will cause retention of urine also. So yes, posterior fibroids can cause constipation, they can cause retention of urine. So initially there is increased frequency, hesitation, and then there can be urinary retention by the posterior cervical fibroid, like I told you. All right, so diagnosis can be done by ultrasound, but the best diagnosis of the fibroid is done by the MRI, fibroid mapping, where the fibroids are present. That is best done by the MRI. Okay, before we say that I have to do a myomectomy, I have to take out the fibroid of this lady, make sure that you assess the endometrium also. A lot of times the fibroid might be just present in the body, not doing much, but she may be having an endometrial hyperplasia. That could be the cause of bleeding. So always rule out other causes of bleeding. Apart from the obvious cause, rule out the other causes. So rule out an endometrial hyperplasia. So before you do the major surgery of the fibroid, always look into the endometrium, the lining of the uterus. That one biopsy should be taken to make sure there is no hyperplasia or, God forbid, a cancer of the endometrium. Right. So what are the principles of treatment of fibroids? So before I rush into that, because we are revising our understanding of fibroids, but now what are your questions before I go into that? Menorrhagia is more than 80 ml of bleed, and can it cause cancers? Yes, I told you. Yes, Sudha, I told you that it can have a malignant degeneration. Yes, so that is what is a cancer. Malignant degeneration is what is a cancer. Can cause, not so common. Rarest, less than 1%. I told you that, right? Why no surgeries? Pregnancy fibroid? Please repeat. Because a lot of bleeding. Uterus is a very congested uterus, lot of blood in the uterus. So if you do a cesarean also, that muscle bleeds so much during a cesarean. So a fibroid in pregnancy, if you operate, she can bleed to her death. That's why we don't do. All right. Infertility because of the all the parts you want again. I think you can revise by doing a rewind and play. But I can help you quickly. Infertility because of the altering tube ovarian relation. The tube gets here and the ovulation is here. Right from the beginning of the chapter, I'm telling you, altered tube ovarian relation, and reduced implantation because the uterus is contracting. It will push the embryo out when the embryo comes for implantation. So that is one thing. alter tubal relation, then reduce implantation because of the uterus pushing out the embryo, and also because of blocked tubes. It's there, you can revise once more. And bowel and bladder because of the shear compression by the fibroids. Okay, so what are the principles of treatment? What are the mechanism of treatment, that is methods of treatment, that is you can do a myomectomy or you can do medical management, all of that we'll discuss. But whom will you treat and whom will you not treat? That is also one question which keeps coming in the exam. This is the only question which came in the INICET and the MCA exam 1 year. Only question was which will you treat and which you will not treat. What is the treatment, most of you know, but which one requires a treatment, which one doesn't require treatment. So that's why we have made this kind of table is not there in any of your theory books, but this is what is accepted protocols across most of the practicing surgeons, right? More or less these are the accepted protocols. So if there's a small fibroid and there are no symptoms, there is no pain, no bleeding and no infertility, three main symptoms of fibroids. Most common is pain, most common is bleeding, but pain and infertility also are the symptoms. No PBI, no pain, no bleeding, no infertility, no symptoms are there, because the fibroid is a very small fibroid and it is, let's say, somewhere here. One chota sa subserosal fibroid is there, only 2 centimeters, and it is just like 30% women have fibroids. Not everybody will have any symptoms. So it is like a small mole on the face. Sometimes we have a mole on the arm. We don't know anything about it, isn't it? So that is a small fibroid. It is doing nothing. No pain, no bleeding, no infertility, no treatment required. No treatment required. All right. Small means less than 5 centimeters in size. Now, small fibroid less than 5 centimeters, but patient has pain, bleeding or infertility. One of these symptoms are there. Because the fibroid is here, it is again 2 centimeters only, but it is, let's say, a submucosal fibroid. A fibroid which is in the cavity like this will have more endometrial glands growing, will have menorrhagia, will also interfere in the contraction, will have menorrhagia, will have a lot of pain also. So pain and bleeding will be there, and this fibroid will also cause infertility. So any of these symptoms will be the reason I'll have to do treatment even for a small fibroid. Treatment is required. Then large fibroid more than 10 centimeters. Suppose the fibroid is as big as 10 centimeters and has pain, bleeding, infertility. Obviously, treatment will be required. What is the treatment? We'll see. I'll tell you. Depends on the age, family, that is number of children, all that. We are discussing that next. But treatment karna hai ki nahi karna? We are just staying there. All right. Then large fibroids more than 10 centimeters, but has no pain, no bleeding and no infertility. Now this is the MCQ which has come in the exams. Large fibroid which is asymptomatic. Please remember, this is an MCQ. Large fibroid which is asymptomatic. What do you do? Think. It's a large fibroid. She is, let's say, 51 years. She's had menopause. No periods. She's not having menorrhagia. And menopause, there is no chance of her saying I'm infertile, because she's already in menopause. She already has the children which she wants to have. There is no pain. There is no bleeding. Definitely there is no infertility. She is 51 years. She came to me for a health checkup. Sir, I am 51 and my family wanted me to come for a health checkup because I got into menopause. So, mera full body checkup kar lo. I do a full body checkup and I do the investigation and all. Well, any doctor can write all those basic health checkup kind of things. And I do a general physical examination. Blood pressure and CVSRS, pulse rate and anemia, breast, thyroid, everything. Then I am doing a per abdominal examination. I see, you have a big tumor in your tummy. I do the ultrasound and see it's a 12 centimeter fibroid she has. Sir, mujhe to kuch problem hi nahi. I don't have any pain, nothing. I don't know that I have a fibroid. Totally asymptomatic. What do you do for that fibroid, guys? Come on, tell me. That was your question. So yes. What do you do? So yes, this is that one question. Large fibroid without any symptoms is still a reason for you to treat it. It is still a reason for you to treat it because it is asymptomatic now, but it is large, and large fibroids can have all those deep degenerations, which I told you. They can have degenerations, they can have a torsion, and they can have also malignant transformation. Malignant degeneration can happen. Like Sudha was asking me, can cancer happen? Although it is rare, but it can happen. So large fibroids cannot be left alone. Treatment is required. Again, treatment is required. So there is only one fibroid where no treatment is required, and that one is the small asymptomatic fibroid. Small with symptoms, large with symptoms, and large without symptoms. All these fibroids will do the treatment. All right, guys. So yes, try and understand this. Extremely important. All right. Okay. So now we'll get into what are the methods of treatment. Before that, what are you asking me? More than 80 infertility, please. Okay, all that we discuss. The blood solid small fibroid less than 5, so will it fall off? Can it grow in future? Yes, it depends on the location, future doctor. It depends. If it is in the muscle, if it is a 5 centimeter fibroid, कितना लिखा तुमने? 5 centimeter. If it is a 5 centimeter fibroid here, this will grow. It will become very big. यही तो है. पहले 1 होता है, फिर 5 होता है, फिर 15 भी हो सकता है. But if it is here, who knows? It may just degenerate and it may fall off. Correct. If it is here in the mucosa, she will not quietly go off from the OPD. She'll have a lot of symptoms. So depending on the location, the fibroids may become bigger. Correct. They can become bigger or they can shrink also. If they are subserosal, the blood supply may actually reduce. But if they are subserosal, they can undergo torsion and come with acute emergencies. So fibroid, every fibroid I open. You know, the number of fibroids I have removed in my life, and touch wood, all of them have gone home well, and I keep thanking the Almighty. But every time I open a fibroid, like while I'm teaching you today, yes, 24th of January 2026. Next week, I have a major fibroid removal in my hospital, and I'm already on the back of my mind. I'm thinking, सब कुछ ठीक हो जाए उसके साथ. And I'm pretty senior now. And even I may try to act very confident, but अंदर से मुझे भी डर अभी भी लगता है. There's a famous ad, no? डर सबको लगता है. अभी भी डर लगता है. Because fibroid can bleed like crazy. सबसे बड़ी प्रॉब्लम है फाइब्रॉइड में. So we always hope that our experience helps the patient and she has a favorable result at the end of the surgery, and we are able to give her the best results, because a lot of time we have to remove only the fibroid and save the uterus. A lot of time you have to take out a big uterus away because it's a big fibroid. You have to do a hysterectomy. Anytime this fibroid surgery can bleed a lot. So yes, treatment is required, and it is only one place where treatment is not required, which is a small asymptomatic fibroid. Majavir Singh, what did you ask me? Oh, can you do this in Pakistan? I'm sure we can do this in Pakistan. Why not? I think you'll have to, I'm sure somebody is reading this. My team is reading this, and they will get back to you. Why don't you just send a hi to me? My number is there all over. A lot of your Pakistani friends have my number, man. All of the groups where I am. So you can just send me a message and I'll send it forward. Anyway, I'll ask okay, I'll do that. I'll ask my team to get in touch with you through this. You can just write. Okay. So let's move on and see the other things. Principles of treatment, large fibroid, all this I've written, all of that I've written. Large fibroid, if it is asymptomatic, what I told you, it can require treatment. So it is all mentioned here as notes. So let's, yes. So to save time, I wrote some notes for you already. So medical management of fibroids, surgical management and medical management. Medical management aims at reducing the bleeding and reducing the size of the fibroid, and also reducing the bleeding during surgery. So reduce pain and bleeding, you can give tranexamic acid. GnRH Enlox is the best medical management. It causes downregulation of the pituitary. Same, I told you in the beginning of the class today. If you start today's Farre chapter, the first thing I said, estrogens are the cause of fibroids and of endometriosis. So basic treatment is reduce the estrogen. That's the first line I said when I started today's chapter. Okay, so we can reduce the congestion of the uterus and the bleeding by GnRH Enlox, again by downregulation of the pituitary. All of that I've given you. So reduce the menstruation, that is the medical management aim. The aim of medical management, reduce the menstrual bleeding, reduce the size of fibroids, reduce congestion and intraoperative bleeding. All right. And tranexamic acid will cause the menstrual bleeding to reduce. Okay. So that's what is the. Now, apart from GnRH Enlox, we also have something called the GnRH antagonist. GnRH analogs work on a principle कि pituitary को इतना stimulate कर दो कि pituitary थक जाए. Go on stimulating the pituitary, pituitary gets tired and pituitary doesn't work. So pituitary is not working. We have happy results. GnRH antagonists भी हैं. They will directly inhibit the pituitary action by antagonizing the GnRH action. So there's a GnRH antagonist also can be used to suppress the pituitary. Then we can use mifepristone. It's an anti-progestin. It has an anti-growth action. All right, and mifepristone also can be given. Ulipristal estate, selective progesterone receptor modulator. It's a pure antagonist action, and that also is given for fibroid management. I'm just quickly running down the medical management, and we can use Mirena, intrauterine progesterone devices, that IUCD, Mirena. What is basically Mirena? It is progesterone. So what happens? This progesterone in the IUCD, this will act on the endometrium, and you know that high dose progesterone will cause atrophy. High dose progesterone will cause atrophy of the endometrium. So endometrium gets atrophied. Although there's a fibroid here, but the endometrium, this endometrium gets totally atrophied. So yes, fibroid cause increase in bleeding from the endometrium. That endometrium have caused it to become atrophic by the IUCD having progesterones. So you can give progesterones to it, they can cause atrophy, which I told you earlier in the discussion with endometriosis. Now I am telling you the same progesterones in the uterus we can give by IUCDs, the impregnated with progesterones, and they can cause atrophy. So I told you atrophy is the new word which I introduced in your lexicon this evening. We have introduced a new word, एक नया word सिखाया था मैंने आपको, atrophy. एंडोमेट्रियम की एट्रोफी करके हमें फाइब्रॉइड्स और एंडोमेट्रियोसिस दोनों में मदद मिलेगी. शुरू में मैंने बता दिया कि फाइब्रॉइड्स एंडोमेट्रियोसिस इज बिकॉज ऑफ हाई ईस्ट्रोजन. दोनों को ट्रीटमेंट कैसे करते हैं? रिड्यूस द ईस्ट्रोजन. दैट्स व्हाई ये दोनों चैप्टर्स हमने साथ में पढ़ाए आपको. ये आपको याद होना चाहिए था. व्हाट इज द मोस्ट इफेक्टिव ड्रग? आई टोल्ड यू ऑलरेडी द बेस्ट मेडिकल मैनेजमेंट of fibroid is GnRH analogs. That's what I showed you in the previous screen. New methods is uterine artery embolization, preferably after 35 years. You can embolize the uterine artery, so the blood supply to this uterus will reduce, and to the blood supply to the fibroids will reduce. Medical management you can do, and menorrhagia also will be reduced by this. Then surgical management. So medical management is what I told you. It is to prepare the woman sometimes for the surgical management also. So hysterectomy can be done for the surgical management of a fibroid. Hysterectomy can be done generally when women have completed family. So mostly we keep it for women after 40 years. Women after 40 years generally, and those who have completed their family. All right. Now younger women, myomectomy will do. So myomectomy, that is removal only of the fibroid, removal of fibroid only. That is what is a myomectomy. Now when we are trying to remove the fibroid, that myomectomy can be an extremely bloody surgery, can bleed a lot. All right. Now that removal can be done by open surgery, open the abdomen, do it, or can be done by laparoscopy. So सबके अलग अलग criteria हैं. Gross criteria I'll tell you. So laparotomy can be done for all sizes. Laparotomy can be done for all sizes, all fibroids, all sides. पेट काट के तो कोई भी फाइब्रॉइड कहीं पे भी हम निकाल सकते हैं. Laparotomy. All right. Now laparoscopic is, can you see now? If I put a laparoscope in the abdomen, see the laparoscope will go like this, and this is the uterus. When I put a laparoscope like this, or I'll show you on my something like this. See this? This is the uterus. Okay, my hand is the uterus, and I'm putting a laparoscope like this. Okay, you can't see the laparoscope. Okay, this is the laparoscope. This pen is the laparoscope. So I put a laparoscope like this, and with the laparoscopy, which fibroid I can take out easily? Obviously, the fibroid which is on the surface will be easily accessible rather than the fibroid which is inside the cavity, isn't it? So with the laparoscope, I can take out a type 6, type 7, maybe even a type 5, but that requires more skill. So laparoscopic removal of fibroids, you should try only if you've done a lot of open surgeries. I have repeatedly said in this topic, the only problem I'm worried about in fibroid is the bleeding during surgery. So pregnancy में तो सर्जरी करनी नहीं है. ग्रॉस प्रिंसिपल बता दिया. अब आपका प्रोफेसर बोलेगा यार मैं तो कर सकता हूं. योर प्रोफेसर इज अ गुड प्रोफेसर. Rarely extremely smart surgeons can do. I'm not discussing here that how many fibroids are removed during the during the pregnancy. This is not the forum. Fibroid in pregnancy don't touch. एक basic principle है. हमें core basics padna hai. Exceptions in post graduation we'll teach. Okay, so fibroid in pregnancy don't touch. Fibroids can bleed a lot, and when fibroids bleed a lot, you have to be smart in the surgery. So laparotomy, any tumor, any fibroid, any size we can take out. Laparoscopy, it's better that we take out for type 7 and type 6, maybe type 5, but I'm not writing. Now hysteroscopic, go into the uterus. See, I'm going into the uterus with a hysteroscope. Which one I can take out? Hysteroscopically with a scope inside. So I can take out a type 0, I can take out a type 1, maybe a type 2, but again surgical skill has to be better. So hysteroscopic for type 0, type 1. These are the outright core basics. And before doing a mammectomy, you should have some understanding that the hemoglobin should be built up. So you can make the woman amenorrheic. Uska periods band kar do, GnRS de do. Stop her periods so that she regains her hemoglobin. Give her iron ferrous sulfate capsules. You may give her blood transfusion, but if you can stop the bleeding and plan the surgery, that's always better. So many times we stop the periods of the lady, build a hemoglobin up, and then only do the surgery, because if the hemoglobin is less than 10, then the healing of the tissue is also going to be difficult after the surgery. So HP should be more than 10. Rule out other cause of infertility. Who knows, if you're doing a mammectomy, the cause of mammectomy could be that the man is having azoospermia. आपको लगता है कि एक बड़ा सा फाइब्रॉइड था 6 centimeters का, and that fibroid is the cause of infertility. You're planning a mammectomy. But actually the fibroid was a subserosal fibroid, and it was somewhere here, let's say 6 centimeters, and the tubes are away from this fibroid and the cavity is away from the fibroid. So this, even if it is 6-7 centimeters, it is not troubling the tubes, it is not troubling the cavity. आपने उसकी surgery कर दी. So myomectomy कर दी, it's a bloody surgery, it's a risky surgery. I've been scaring you about the myomectomy. फाइब्रॉइड निकालने में ब्लीडिंग हो जाता है, बट द पेशेंट कम्स टू मी आफ्टर 1 year एंड सेज, सर मेरा तो प्रेगनेंसी हुआ ही नहीं, आपने तो सर्जरी कर दी, आई एम नॉट प्रेग्नेंट स्टिल. एंड देन यू फाइंड आउट विद द सीम एनालिसिस ऑफ द हस्बैंड दैट ही इज एजोस्पर्मिक. ही इज एजोस्पर्मिक. अरे यार, ये तो बड़ी मुसीबत हो गई. व्हाई डिड यू डू अ सर्जरी फॉर दिस लेडी व्हेन द मैन इज एजोस्पर्मिक? दिस इज अ प्रीरिक्विजिट दैट hemoglobin should be more than 10, and you should have done a semen analysis of the husband before doing a myomectomy, because that myomectomy was a dangerous surgery and the woman could have died in the surgery. Yes, this has happened. Many doctors, it has happened that patients have lost their lives during a myomectomy. So please do this major surgery only if the semen analysis is fine. Okay, then during the surgery, minimal fimbrial and tubal handling, नहीं तो adhesions बढ़ जाते हैं. Minimal incisions on the uterus, and avoid posterior wall incisions because it can cause fixed retroversion, which causes infertility. This we've discussed in the chapter of infertility in our app also, and fixed retroversion can be a problem. The retroversion uterus, I can explain you again like this. So when the woman is having intercourse, the sperms are deposited. Suppose this pen is the penis and the sperms are deposited in the posterior wall of the vagina. The cervix is downwards and forwards like this. So cervix is picking up the sperms after intercourse, but that is when the uterus is straight like this, anteverted, straight like this. But if the uterus gets retroverted, if it gets retroverted, the cervix will miss the pool of semen, and that's why the patient will not get pregnant after intercourse, because of a fixed retroversion. So that fixed retroversion can happen more if you do a posterior wall incision. If you do a posterior wall incision for the fibroids, it causes fixed retroversion. थोड़ा सा PG वाला हो गया ये वाला segment, but never mind, since I have to teach you to become the best postgraduates, you can learn a little bit more, right? चलो आगे बढ़ते हैं. And avoid opening the cavity. You know, sometimes we do end up opening the cavity, but cavity injuries can cause fibrosis of the cavity and more problems in pregnancy later. Now, techniques of reducing blood loss during the myomectomy, we have this myoma clamp. This myoma clamp, if you see this tip, these two prongs which are here like this, these, can you see aisa hai na? These myoma prongs, they are like this myomectomy clamps. So kya hota hai, there's a big fibroid here. So we open the abdomen and put this clamp next to the uterus like this. ऐसे clamp लगा देते हैं. So when you put this clamp, the uterine artery is compressed on both the sides. When I'm operating on this, the bleeding will be much lesser. And then, very important, vasopressin injections. So all of that is coming now. The methods to reduce bleeding. ये सब आएगा exam में. Yes, viva में आएगा. They'll give you a specimen in the evening viva with the fibroid in front of you, and they'll say, how do you reduce bleeding during surgery? Steps of reducing bleeding during surgery. So myoma clamp, and that is during surgery, but before the surgery you can give GnRH therapy to reduce the congestion and time the surgery in post menstrual phase of the menstrual cycle. Suppose she had periods on 1st of February and she finishes periods on 4th of February, for example. I'll try to do the surgery between 6th to 16th of February. That's the time, because after ovulation, then the congestion of the uterus increases and bleeding during surgery will increase. So generally post-menstrual rather than pre-menstrual. Okay, arrange blood and FFP. You must always do intrauterine use of a uterine clamp, this myomectomy clamp. Tourniquet, instead of a clamp, we can put a a plastic tube around the uterine arteries. We can do that also. And vasopressin, local vasospasm you can cause by vasopressin. This is not enough, writing this. I'll show you how we give it. That's what is very important, vasopressin injection. So yes, look here. This is a patient. Wait, I'll have to. Yes, look at this one. I've taken the uterus out of the abdomen, and can you see the size of the uterus is so big? Now I'm injecting vasopressin. Look at this picture and look at this one. Can you see? When you inject the vasopressin, before that it was also red and congested and it was going to bleed a lot. After injecting the vasopressin, can you see it's become all blanched and white? So this is how you're putting the vasopressin here. Always withdraw when you're injecting any drug into any place. Always withdraw any part where you're giving an injection. Always withdraw. If you give vasopressin into the circulation, sudden hypertension can happen. So when you're injecting this vasopressin, we tell the anesthetist, injecting vasopressin. Anesthetists kai bar busy hote hain phone pay, because anesthesia life. They are very busy in the OT, but they are also having the time to go and have tea in between and catch up on the gossip with their friends. I envy the anesthetist sometimes. All right. वो मेरे को जवाब देते तो नहीं लेना था ना गायनी, क्यों कर रहा है सर्जरी, एनेस्थीसिया करना था. Okay, that war we will discuss when you come to PG life. We'll discuss all that, all the war which goes on between anesthetists and the surgeons. तो ये देखिए, ये this is got totally blanched. देख रहे हो, you give the vasopressin, ये पूरा area देखो white हो गया. Now moment I make an incision, hardly any blood loss is there. This is not much, please don't get scared. When you make an incision on the uterus, फुहारे छूटते हैं कई बार. You will have spurts going up till the ceiling of the OT and will come into your eyes so many times. So see, I'm able to do the surgery aram se without any massive blood loss. One, I've given the vasopressin and I put a tourniquet around the uterus, uterine arteries, and then I've given her GnRH analogues before, for 3 months before she came for the surgery, all to make sure that I will take out the fibroid and not take out the uterus when I want to do a myomectomy. So that's what, these are the steps. Chalo. Now the same surgery is still continuing. Then can you see now? This is a big fibroid, it's almost like this with this head of the baby, like this. I've tried to, yes, see here, I've tried to open the uterus like this. Like this, I'm opening up the uterus and taking out the fibroid here. Yeah. See this one now. Wait. Yeah, see this? Now, what is this instrument? I wanted to show you this instrument. This is your instrument. Yes, instrument question. All you exam going students for final MBBS and the PG students, entrance students. This myoma screw. This is what is screwed. This is like a corkscrew. That wine opener hota na, corkscrew. बिल्कुल उसके जैसा होता है ये myoma screw. It is put into the uterus and gives us traction while I'm trying to do the myomectomy. See, I'm giving a traction to the fibroid because of this. And then we're about to just finish this here. The base, now this is where, this is the part, the base of the fibroid when I'm finally trying to take it out. That base of the fibroid, uske niche hi to cavity hoti uterus ki. That cavity should not be injured. Try to, I mean, if you injure the cavity, of course, you will repair it also. It happens. I have opened the cavity many times. It's not that, we are always doing only good things. Yes, we end up in a few complications. But yes, again, touch wood, all the patients go fine and they have good results. Then any surgeon will have complications, but you should know how to diagnose and treat the complications. That's what makes you a good surgeon. Complication होता ही नहीं है, ऐसा कोई surgeon नहीं दुनिया में, कोई surgeon नहीं. All right, चलो, let's move on and see. This is the base of the fibroid which I've taken out, and now you have to close this in layers. And the surface, we say baseball sutures on the surface of the serosa. right? So this is the number of fibroids I took out. This is just for the size. See, this is more than 10 centimeters. This one big fibroid is around 12 centimeters. So many fibroids in this patient. After the surgery, we generally like to, take a picture, show off. होता है ये, सब लोग थोड़ा पिक्चर लेते हैं ऐसा मेजर सर्जरी के बाद. This is a myoma screw. This is a histoscopic myomectomy. Yes, I was trying to show you कि histoscopic myomectomy करते हैं. तो histoscopic myomectomy also you should be, we use some media to distend the uterus. I'll not go into much detail about this surgery now, but this can also bleed a lot. So you should have done a lot of open surgery before you do laparoscopic myomectomy and histoscopic myomectomy. So this is the histoscopic myomectomy. This is a type 1 fibroid I told you ना. Type 1 fibroid होता है. इसमें it is mostly in the cavity, but some part is in the muscle. More than 50%, less than 50% in the muscle, and mostly in the cavity. So this type 1, I'm going the base of the fibroid to remove this. This is a bipolar cautery which I have. So with that, we try to take out the, yes, we remove this. And then this fibroid has to be taken out. This is almost 3 centimeters, this fibroid. So to take it out from the uterus, that is also another task. Okay, remove तो हो जाता है, but how do you take it out? That is also one nuisance. So this is that fibroid. Can you see? ये fibroid ऐसे घूमता रहता है. It keeps running. Can you see? ये internal os है और उस पे fibroid यहाँ पे आके फंस जाता है. So then, can you see that? Yes. Then you have to take it out also. But yeah, once you become a gynecologist, then we'll teach you all these small intricate details. Thank you guys. A lot of things we discussed, much more than what I was hoping that we will do today. But it's always interesting to take a class, and I'm happy that we do all of this. Now, what is Sudha asking me? Why laparoscopic done in time? I'm saying laparoscopy is done for anybody. Yaar. See, if somebody has a gallstone, don't you do a cholecystectomy with the open procedure? But we can do laparoscopic also, so that there is lesser incision, lesser size of incision, and laparoscopy the patient will recover very fast. Isn't it? Laparoscopy karke patient recovers very fast. Today you do the surgery, tomorrow the person goes home. But you cut the abdomen and do the cholecystectomy, he has to be admitted. Similarly, when you do a myomectomy, open myomectomy, the patient will be in the hospital for 1 week. But you do a laparoscopic myomectomy, she goes home. So laparoscopy surgery is a smarter surgery, more cosmetic. Okay, smarter surgery, and the patient recovery time is much lesser. Yes, pros and cons hain, but much lesser. So why do laparoscopy for 6 and 7? Easy to do. That's why 6 and 7. 4 and 5, they'll be difficult to do. Okay, what is the possible getting pregnant at age 46? What is possible? Is it possible at 46 years? Yes, it is possible. But 46 years, we already menstrual physiology chapter, my friend John Batula. You must see the menstrual physiology chapter, and we have already done that. That menstrual physiology, I've taught you that the woman has the best fertility in the first 20 to 25 years of life. Then 25 to 35, it is still good. 35 to 40, much compromise. And after 40, it's only good luck. So after 45, you're asking about a 46-year-old. After 45, she cannot get pregnant. I mean, 99%. Yes, a lot of women have conceived spontaneously at 48, 49 years also. That has been shown. Even my own grandmother, she had a last child when she was 49. So yes, it does happen. One of my aunts is only around 4 years older than me. So yes, it does happen. But you must understand that those rarities. Common kya hai? Till 35 to 40, although compromised, that they can be pregnancy. After 40, chance is very less because the number of eggs is less. So after 45, like 46, you are saying, this lady needs eggs from a donor, sperms from the husband, and we can make a baby, and that baby can be put into the uterus. So donor eggs and sperm of the husband can be used to make this lady have a child. Can be done. She can get pregnant, but not with her own eggs. How to find answers? Know how to find answers. Okay, hysterectomy, mammectomy, please. Hysteroscopic. Yeah, yeah, hysteroscopic mammectomy. Yes. Yes, you want to see, Sudha? You can see. Hysteroscopic mammectomy, with the hysteroscope, you go inside. Ab kya hota hai na? When you go into the uterus, see, this is the hysteroscope, Sudha. You go inside like this, you cannot see anything. You have to distend the uterus. Hysteroscopy की class में पढ़ाएंगे आपको, ठीक है? You have to distend the uterus. Then only you can see. So while you're doing this, all this water can you see bubbling, because along with the light, there's a lot of fluid going to distend the uterus. And then with my hysteroscope, you can see through the hysteroscope, this instrument is gone. So, I am seeing with the scope. The scope is somewhere here. This instrument is going through the scope to do the surgery. This is a hysteroscopic myomectomy. Very interesting, yes.